The House Committee on Healthcare Reform will come to order. Please call the roll.
Hayden.
Here.
Stinnett. Here. Lewis. Present. Boggs. Buckeye Courtway. Here. Vogel. Here. Cragg.
Here.
Keithley. Nixon Clark. Boucher. Seitz. Here. Thomas. Here. Tolson Reich. Here. Unsicker.
Okay. 11 present. We have a quorum. Of course, for hearings, we don't need a quorum. Just a little decorum for what we're going to hear today. We're going to hear two bills simultaneously. They contain, one is actually contained and the other has potential. So we're going to hear 271. And Benny, your other bill is 320. Is that correct? I've got it right in front of me. 330. We're going to hear them. We'll have both representatives come up and present their bills. We will take testimony on those two bills. Floor rules, none of us want to be here till sunrise, okay? And anything after probably two and a half hours, nobody's listening anyway. So we will make every effort to be fair, have equal representation. We're going to have the presenters give theirs first. Then we will have key facts people from each side. We'll have 3 to 5 minutes. Then we're going to go to 2-minute testimonies. And I know some of you are doing it a long way. I don't want to not have you. If you're in the middle of a lot of facts that we don't have, you may get leeway on that. If not, I'll probably have to gavel you out. And the committee, I asked them to be respectful, ask serious questions, and also we're trying to get, I feel like Solomon when they split the baby, you know, except there's not one mother, there's a whole bunch of mothers in this deal and not just one. So we're trying to get at the best facts we can get at. Those of us on the committee appreciate facts, brevity, and when if someone has given testimony that you already coincide with or you support, please say, I agree, I'm in support of the bill, I'm opposed to the bill, and if somebody's covered those facts, we probably don't need to have more discussion. Again, I'd like for this hearing to be facts-centered, and I know there's a lot of emotion. Based on the emails I'm getting and the committee got, I think we'd all agree that, but we need to be very fact-centered and try to get to as much information for the members of the committee as we can get as to what is occurring in these issues. Okay? Roughly, how many are going to testify in favor of the two, Representative Riley and Representative Cook's, the first two bills we're going to, how many in favor? Somebody count for me. All right. And this is on 329, right? No, 271. All right. Yeah. All right. Good. Because I had another list that had a lot more than that on. So there's 10. All right. I guess we need to check in overflow how many is going to testify for and against. All right. How many are going to oppose 271 and 330? How many? 2? All right. All right, we're going to alternate back and forth, and again, try to keep it as close on time as we can keep it. I think back and forth is the fairest so that we don't remember one side or the other longer than when we get through. Okay? With that, let's start. Representative Riley, you want to present your bill, then we have Benny, Representative Cook present his, and then we'll start the alternating. And after Representative Riley presents, we will ask him questions. And we are presenting because many of you are aware, as we try to possibly put bills together this time, we need some type of understanding of bills that have similarity, and that's why we're hearing these two together. So, Representative Riley.
Thank you, Mr. Chair, Madam Vice Chair, members of the committee. My name is Alex Riley. I'm the state representative from the 134th District, which covers parts of Southwest Springfield, the city of Battlefield, and Greene County. Thank you for allowing me to present House Bill 271 to you this evening. This is the Regulatory Reduction Act for APRNs. At a high level, this bill is designed to improve access to care and reduce the cost of care for patients in our state. I think those are two items that all of us in the legislature are extremely focused on, and this is a possible tool in the toolbox that we have to do that. The way the bill does this is, broadly speaking, it removes a series of government-imposed regulations on a number of medical providers in our state, and these are APRNs, Advanced Practice Registered Nurses. These are folks who have a great deal of training, and they are trained to do a lot more things than the state of Missouri currently allows them to do. The way the bill operates is it removes a series of regulations that prohibit APRNs from practicing to the full extent of their training. And just briefly, the items that it removes are it allows the State Board of Nursing to provide APRNs in Missouri a state license to practice versus a document of recognition. And we've got a number of folks here who actually practice, and they'll be able to tell you why they think that is important. Importantly, it also removes a series of artificial and outdated barriers to practice, and a number of these were waived during the COVID emergency a couple years ago. And what we found out when those rules were waived is there were no reports of abuses, and the system functioned well. A couple of these things that were waived that would help our APRNs practice more to their full ability would include removing mileage restrictions. So right now they're required to be within 75 miles of a supervising physician, and remove some chart review requirements as well, where the law currently requires physicians to conduct chart reviews on occasion. And these are all things that the APRNs say inhibits their ability to practice fully and provide more care and opportunities to care for their patients. And then finally, it would allow APRNs to practice to their full extent of their education and training by removing a requirement for a collaborative practice arrangement with a physician. And you'll hear a lot about collaborative practice agreements from the medical providers themselves on all sides of this issue. But this has been a big barrier to our APRNs being able to practice to their full abilities. There's a clear trend in the country right now going in the direction of House Bill 271 and opening up the scope of practice for APRNs. And if you haven't seen it yet, I'm sure there probably will be something coming around at some point that will show you the number of states that now have full scope of practice for APRNs. And this isn't a red state issue. This isn't a blue state issue. You can look at the map, but you'll see you have West Coast states like Washington and Oregon that have gone in the direction that we're trying to go with House Bill 271. You've got almost all of the New England states that have gone in this direction, as well as a number of states surrounding Missouri like Iowa and Kansas. And what we've seen in those states is there's not been any data suggesting that you're seeing increased harm to patients. There hasn't been any data showing any harm for that matter. And one of the things that I've been especially interested in over the past couple years before I decided to carry this bill was, we'll hear a lot of testimony today saying that this is going to harm patients and it's going to put patients in danger if we open up scope of practice for APRNs. And I've been asking for specific numbers, specific data for years now that show that this will harm patients. And I will say, if I saw those numbers, I would not have carried this bill. I would have had no interest in doing that. But I haven't. None of those numbers have been provided to me over the years now, and my only conclusion is it's because they don't exist. So as you're hearing the testimony from all sides, I would keep that in mind, and also I think it'd be good for the committee to try and get those numbers so we can actually look and see if there is proof of harm to patients. With that, I could comment on a number of other things, but I suppose that's enough for now. I know we've got a lot of people that want to talk. So I'll open myself up to questions here in a moment. But I would also note, I'll be able to comment on some things, but I know that we have a lot of medical providers here on both sides of the issue who will be able to dive into the technicalities of why these things really matter to them on both sides. So, again, happy to answer any questions, but on those more technical pieces, I'll probably ask you to ask some of those to the medical providers themselves because they'll be able to give you a better, more full answer.
Okay, questions? Representative Sykes.
Yes, thank you. To inquire?
Go ahead.
Thank you. Hopefully this is not a too technical question, but are APRNs traditionally supervised by an attending physician, or do they by and large operate independently of that physician?
So right now, they are required to have some degree of supervision. And the idea here is they are trained to do a lot more things than we currently allow them to do under state law. And we would like to remove some of those supervisory requirements.
Okay, and are nurse practitioners considered APRNs?
They are.
Okay. All right, thank you.
Thank you, Representative.
Yes, Representative Unziger.
Thank you, Mr. Chair. To inquire.
Go ahead.
Thank you, Mr. Chair. A couple questions. First of all, there's a lot of different medical providers. I looked through this bill and noticed, let's see, there's APRNs, physician's assistants, assistant physicians, registered professional nurses, and licensed practical nurses. Do you know the difference in these categories? And if not, I hope somebody else will explain.
I am sure somebody can walk through those, but I could give you a rough summary of my understanding, but there's probably someone who can articulate it much better.
Yeah, I would like to know the difference between those categories and what the educational and practical requirements are for
Absolutely.
those. And then does your bill address anything about revoking a license?
I don't think it does.
For example, if somebody is convicted of a felony, can we revoke their license? That would be something to look at.
Yeah.
Okay. Thank you.
Thank you.
Thank you, Mr. Chair.
Other questions? Representative Thomas.
To inquire, please.
Go ahead.
Thank you. Do you know in the current law where it makes any limitations on APRNs practicing to the full extent of their license, their training, their expertise, their education? Where is that language that's limiting them, and what are you replacing that with?
Yeah, so I think the language that at least the APRNs feel limits them is the language in front of you today, especially the collaborative practice piece. And I think that there would be some people here who would be able to speak to what exactly in there they think limits them to do certain things, and I'll defer to them because I wouldn't want to put words in their mouth.
So, again, we'll definitely talk more about that, but so to the best of your understanding, it's not a matter of particular skills or practices or techniques that they're not allowed to do. It's just the fact that they require supervision. I mean, again, that's your understanding?
I think that's a piece of it, but again, I don't want to put words in their mouth.
Okay, because I think that needs clarification, because I don't know that there's anything that actually limits the skills and abilities, but within a network of provider supervision, which is the collaborative practice arrangement. But, okay, thank you. I'll ask another individual. Thank you.
Thank you, Representative.
Other questions? If not, I have a couple. You are an attorney, correct?
Correct.
You are a licensed attorney.
Correct.
Let's look at what's good for the goose is good for the gander. What if we took and we could read law again and practice law without a license? Or with a license, but not a law license, but similar. How would you feel about that bill?
So to be honest, I would actually be in support of a lot of rules and changes along those lines as well. So I appreciate where you're going with that line of inquiry, but
Well, that's asking another specific thing in relation to law. Would you be opposed to removing the Missouri plan for Supreme Court justices in, where the bar only gives certain numbers of members to the governor? Would you be opposed to limiting that?
I have a lot of concerns with the Missouri court plan
Okay.
and would like there to be some significant reforms made.
I'm wanting to get a standard. We have, as a legislature, we have bills on allowing physical therapists more leeway. We have bills allowing chiropractors to do work on horses without a veterinarian present. We have all kinds of bills that are eliminating what we have historically worked under as practice acts. And my question is, your intention, or you think that'd be all right for any of those to be challenged in that way?
Well, I think
By the way, when I ask those questions, these aren't choosing a side. I'm just trying to get a perspective of where you're coming from.
And I appreciate that. And I think every category should be debated on its own merits. I think in some respects, in some areas, it makes sense, and I think in others, it probably doesn't. So, for me, I've looked at the data coming in from around the country, and and it seems pretty clear on the proper direction to go here. And for that reason, I'm supporting and have filed this bill to expand scope of practice for APRNs. But, some of those other bills you mentioned, I like probably better than others, and some I may not be as excited about. But I think each one of those bills should rise and fall on their own merits. I don't think we can lump them all in together in one category.
What type of research have you done on data, either research that's been presented to you or other research as you looked at this, that you have personally looked at in preparation for this? Here's the question. In the last week, as a committee, we have got substantial data. Is reams fair for the committee? We have reams of data that appears to be contradictory.
Yeah.
And one of the things I hope to get out of this committee hearing is data, is it subjective, is it objective, or is it hard studies of here is data and where it's presented from? And so in your research getting ready for this, what data have you looked at and from what sources to lead you to believe that there's no difference in outcomes?
So I would say I've probably seen all the same data that has been presented to this committee over the past few weeks. I sat on a committee called Professional Registration in the past 2 years where these bills have gone through previously. So as a committee member, I listened to the arguments on all sides, looked at all the data presented as a member of the committee analyzing these bills, and then as I was looking and considering whether to file it myself, looked at that again, including data from all sides. I reached out to the folks opposing this bill to let them know, hey, I'm looking at filing this. I'd be interested in visiting with you about that, asked for information, asked for data, reviewed what they provided. So I can compile a list and provide it to you at some point if you would like, but it is voluminous and probably the same reams of data that you all on this committee have been inundated with over the past few weeks.
And our committee historically is short, but they have been very good on studying what's presented to them.
Yep.
I don't know if any of us could have studied all of the data that's been presented to us on this one, because it has been huge. So, thank you. Other questions? Yes. Representative Tennant.
To inquire.
Go ahead.
Do you know if APRNs are currently able to serve as a primary care provider?
I don't know that I do know the answer to that question.
I'm sure somebody else can probably answer that. I think that's an important distinction. I also wanted to ask you a couple questions just on a couple points. On page 25, you have some mark out related to certified registered nurse anesthetist. Is that?
So the only portion of this bill that deals with the CRNA piece is dealing with that, allowing the State Board of Nursing to provide the state license versus a document of recognition. Nothing else in this bill addresses the CRNA aspect of it, and that's not my intent. I think there's another bill you'll be hearing here shortly that's the CRNA piece.
Okay. And then on page 32, there's a reference to section 335.176, which we talked earlier, actually references to page 50. In that, we're talking about the ability to prescribe drugs, and there's mention of obtaining a reliable medical history, physical exam, dialogue with the patient. Would you be open to adding something where they're required to at least attempt to provide or find out if there are other providers who have previously been prescribing medications, basically a consultation with any other providers?
Yeah, I'd be happy to take a look at that. I think this bill is very much a work in progress, and I'm open to discussions over any aspect of it.
Sure. And then my only other questions on page 42, line 28 says the Board of Nursing may grant a certificate of controlled substance prescriptive authority. Is that something they're already doing for this?
I'm sorry, Representative, would you repeat the page number?
42, line 28.
Okay.
Are
I
they-
found the spot now. Could you re-ask the
Yeah,
question?
absolutely.
Thank you.
So the Board of Nursing may grant a certificate of controlled substance prescriptive authority for APRNs. Is that something they're already doing, or is this new, completely new to the Board of Nursing?
My belief is this would be new, but I'm going to have someone clarify behind me who knows better than I do on that item. And if no one knows, I will find you an answer.
Sounds good. Thank you.
Other questions? If not, yes, please, or Representative Thomas.
Yes, to inquire, please.
Go ahead.
There has been a tremendous amount of information brought forth, and just some of those bits of data do contradict, as Chairman Hayden was saying, the information you're testifying to, that there's not a difference, or well, let me explain. Are you aware that in states where there's been an expansion of scope of practice, and I'm just going to read you the numbers here, it's easier, that x-ray ordering has increased 441% among non-physicians. Non-physicians needed 2 times the number of biopsies to screen for skin cancer. Patients were 15 times more likely to receive an antibiotic for an infection that was viral that didn't need an antibiotic if it was a non-physician prescriber. 6.3% of nurse practitioners prescribed opiates to over half of their patients, compared to only 1.3% of physicians. One of the leading ACOs, accountable care organizations, that use non-physician primary care providers showed that they have an increase of $43 per month in their average cost, which translates over time to a $10.3 million difference in annual spending. So nurse practitioners are actually, and non-physicians are causing higher cost of care, ordering more tests, prescribing inappropriately in some cases. I certainly would vehemently disagree that there's not data out there. And have you come across any of these statistics?
I was looking at the page you were holding there, and it looked like something I had seen before.
Okay.
Yeah. So again, I think this is one of those items where you have folks on both sides that have an opinion on it, and I think that's one of the values of this hearing is you're going to be able to hear from all sides and inquire and form your own conclusions based on the data and facts and information provided.
Other questions?
Thank you.
Yes, Representative Nixon. Go ahead.
So you've heard or sponsored this bill in previous committee, correct?
This is my first year sponsoring it. I've heard it before as a member of the committee, but the prior representative who had worked on this issue is no longer in the House, so I picked it up.
Okay. And with all the information and data that we received, we have received emails on top of emails. And so you stated that you are, in fact, an attorney, correct?
Correct.
Okay. And I just want to know what's your inspiration for this bill to pass this particular bill without the data or without the knowledge of being able to answer any of the questions that have been asked?
So I think my inspiration for trying to work on this bill is I'm trying to work to improve access to care in the state, reduce cost where we can, and you're going to hear a lot of information that is going to back up the position that this will do that. And I've found that evidence to be compelling, and I've brought this bill forward because I found it to be compelling. But again, I'm not going to tell you what you should do. I think you should listen to everybody and come to your own conclusions, and then vote based on the way you think the facts and data show you.
Other questions? Representative Lewis, I'm not ignoring you, just out of my field of vision. I'm sorry, but
To inquire.
go ahead.
Thank you. Good evening.
Good evening. Or
Afternoon.
whatever.
Almost evening. Thank you for being here today. I just want to point out all the data that we've been presented. I was looking at what you were referencing, and then some other outcomes. I think also there's one in favor of this bill that you're sponsoring that we have received that has footnotes that references that the outcomes have been positive in the 26 other states who have adopted similar language. So when we look at information that's given to us, I think we should also, look and make sure that, it's been referenced and it's not just like someone saying, the sky is falling or something. So anyway, I appreciate you bringing this bill forward. You obviously know I support it because I did co-sponsor it. So thank you so much.
Thank you, Representative.
Further questions? If not, we're going to use a rule of one with questioning from the members, but I'm going to break that because I'm the chairman, okay? So because you're an attorney, do you do any malpractice law?
I do. I've actually done quite a bit of medical malpractice defense, so defending doctors, nurses, hospitals when they get sued. That was where I started. The first 3 years of my practice was almost devoted fully to that. And most of my first trials were defending doctors in medical malpractice lawsuits.
Good. I have a question. If we take, as I see it, what your bill basically does is that we have 3 groups of people who practice in Missouri. We have MDs, DOs, and nurse practitioners. Am I correct in that understanding? Your bill, in essence, presents that position.
I think that's a fairly accurate
All right.
representation.
If you have that in your experience, because you have experience, what will happen with malpractice insurance? Some are covered by the hospitals they work for. Some are covered, several have told me they have their own malpractice. Some are covered by the doctors they work for. What's going to happen to malpractice insurance in this case? Now, some have told me their insurance for Kansas is cheaper than Missouri, and I would contend that Missouri is a much more litigious state.
That is correct.
And then people come to Missouri to sue because we have better juries for settlement, correct?
That is also correct.
All right. So what's going to happen to our malpractice insurance for nurse practitioners if they practice basically without physician authority in the situation? I don't know the answer to this. I want to know what you think.
Yeah. No one has come to me and told me that they think that this would increase the cost of malpractice insurance. If people do think that, I'd certainly like to know. But I appreciate the question. I think that all that we're doing in this bill is removing some government restrictions that are in place. There wouldn't be anything that we're doing here that would prohibit a hospital, for example, to require a collaborative practice agreement. For example, if Cox Hospital or Mercy Hospital, where I'm from in Springfield, wanted to require collaborative practice or have some of these restrictions in place, they could still do that. So if they felt that if you have providers, for example, from Cox Hospital, which is self-insured, if they well, that'd be a bad example. Let me go with Mercy Hospital. If Mercy feels like this would be a situation where not requiring collaborative practice could potentially escalate their malpractice insurance, they could still require anyone that falls under that Mercy umbrella to still have collaborative practice. All we're doing with this bill is requiring, or it would be eliminating the state-imposed regulations. So Washington University and St. Louis could still have something. Any medical facility, group, whatever, in the state could still impose that on itself. All we're doing with this bill is eliminating the government mandated, the state mandated requirement.
Okay, thank you. Representative Courtway, Buckeye Courtway,
To inquire?
go ahead.
Thank you. So my question is, if we would allow a nurse practitioner to be able to do the same thing as a doctor, why would anyone want to go to become a doctor? Because I'm assuming they have to go to more years of schooling, more expensive costs for them. What would be an incentive for someone to go be a doctor versus a nurse practitioner?
Well, I think there's a few pieces to that. I don't think the bill says that they can do all the same things as a doctor. I think what it says is they can do the things that they are trained to do. So there would still be a number of things that I don't think that they could do. I don't think you're going to have nurse practitioners running around doing brain surgery on people. I don't think we're going to see that. But I still think that it is still a different job, even if we allow them to do all the things that in their years of training they are trained to do. You're still going to have people who will want the increased earning potential that some MDs have that various APRNs don't have. I think there's a number of things that would encourage people to still go on to medical school. I don't know, and looking at the numbers, and if someone knows and can correct me, I certainly welcome them to do so. But I don't think you're seeing situations in Washington and Oregon and New York State and Massachusetts and a lot of these places that have extremely well-regarded medical institutions of people saying, well, I'm not going to go to medical school, I'm just going to go be an NP instead. I don't think we see that.
Okay, thank you.
Thank you.
Further questions? If not, I think we're going to move to Representative Cook. He's going to explain his bill, which has some similarities, and we're moving that progress. Representative Cook, you're on the show.
Thank you, Mr. Chairman. Thank you, committee. Appreciate you hearing this simple bill. This is House Bill 330, the APRN licensure component, which is in Representative Riley's bill already. So you already have this in front of you. It's very, again, I'm just going to say it is simple. Really, it is. APRNs get a document of recognition from the Board of Nursing permitting them to practice. This is a simple paper change from a document of recognition to a license. It's very basic. I could try to answer a few questions, but we have several folks behind us that want to get up here and talk to you. So I feel it would be great to have them come up here and go through both of these pieces of legislation and give you additional knowledge on the subject.
Okay. Representative Fogel.
Just to clarify, the entirety of your bill is in Representative Riley's bill. There's nothing different.
No, mine is in his bill already.
Okay.
Okay. Other questions? If not, I don't see any. Am I missing anybody? If not, we're going to proceed, and let's have the first pro position. I think this is a position that brings some data and expertise, as I understand from the election, from the deal. Please fill out your testimony forms. Tell us who you are, what you represent, and a little bit about your experience. So, Is your mic on?
I don't know.
Maybe there.
Yeah, I think it is.
You may have
Okay.
to speak into it.
Okay. My name is Lila Pennington. I am a board-certified family and gerontologic nurse practitioner. I have 2 certifications. I have been practicing in the state of Missouri as a nurse practitioner since 1977. I practiced for 19 and a half years in public health, where I did clinics that physicians hardly ever, if ever, came to. I did both baby clinics. I did family planning clinics, women's health clinics, prenatal clinics, and STD clinics. So I had that experience. Then I also taught for 20 years, or 21 years, at the MU Sinclair School of Nursing, where I, for the last several of those years, coordinated the family nurse practitioner area of study. So I'm very familiar with the education that advanced practice nurses have to go through. I just want to hit a few highlights. I have submitted written testimony, which goes into more detail, but I have some highlights that I want to know, because I know your time is short, and I want to be respectful of that. I know you'll be presented with more information on this, but there is a severe primary care provider shortage in Missouri, especially in rural counties. The current restrictions that we have, having to be within a 75-mile radius of the physician we collaborate with, and numerous others, inhibit our ability to actually go and help answer those access problems in those counties that currently don't have primary care. There's been some question about, do nurse practitioners go into rural counties? And there is a study from Johns Hopkins School of Public Health and Economics that looked at 9 states while they had a collaborative practice agreement, and then looked at the same 9 states after the collaborative practice agreement requirement was removed. Their percentage of nurse practitioners that went to rural areas increased substantially. So we are willing to go into underserved areas, and all of my clinical practice has been in underserved populations. So actually, I've been here before the law and since the law requiring a collaborative practice agreement has been in place. We had access issues when the law was passed. Since that time, the access to primary care in Missouri has decreased. It hasn't gotten better, it's gotten worse. And part of that is because of the requirement of the collaborative practice agreement, which inhibits APRNs from doing what they can do. Health outcomes. Currently, we rank, depending on the study, which source you look at, we rank anywhere from 42nd to 43rd in general health outcomes as a state. That means there aren't that many states that rank below us. And if you look at that list, all the states that rank below us are restrictive, like Missouri. All the 26 states that do not require collaborative practice all have better health outcomes than in Missouri. There are 40 years, there's over 40, about 50 years of research on nurse practitioners and other APRNs and the quality of care that they give. And they have found, in fact, you were asking about research, I have a 8-page annotated bibliography, and that's only a few of the studies. Some of those studies are, okay. So anyway, we have, yes, so we can improve, and we can improve the Medicare, access to Medicare and Medicaid beneficiaries. We can decrease hospitalizations and re-hospitalization. That's according to a study that I participated in. The Missouri, as far as cost, the Missouri Foundation for Health indicates that fully utilizing APRNs, such as NPs, would result in substantial health care savings of $1.6 billion over 10 years. So we're not talking, more study that has been done on that. I think one thing that rarely gets mentioned is that physicians receive pay for collaborating. Most physicians receive extra pay for collaborating with nurse practitioners, and that increases the cost of health care. Finally, I'd like to address our education. We are not educated as physicians. We're educated at the highest level of nursing practice, advanced practice nursing. We are nurses. Do we do some of the same things physicians do? Yes, but that has been the way throughout history. At one time, only the nurses were the first people to provide anesthesia, so that's not unusual. APRNs have to be a registered nurse first, so they have to have their RN education from day one, they're in clinical, do clinicals from day one. And on top of that RN education, then we add the APRN education on top of that. And so by the time that the APRN comes into her educational program, she's got years of experience as a nursing student and as a registered nurse. So medical students are not required to have any experience prior to coming into medical school. They don't have to have any healthcare experience. They may have, some do, but they are not required to. Our 6 to 8 years of education, depending on whether we're masters or doctorally prepared, compares favorably with optometrists, pharmacists, dentists, and lawyers. And all of those practice without a collaborative practice agreement with a different profession. You mentioned paralegals and lawyers. Paralegals don't have nearly the education of an advanced practice nurse. An advanced practice nurse's years of education actually get closer to lawyers. And if you want to look at a better comparison, look at optometrists who do a lot of the things that an ophthalmologist does, but they practice separately. They are not required to have a collaborative practice agreement with an ophthalmologist. They will, if a patient needs, in fact, your eye doctor may have been an optometrist all your life, unless you had an eye disease or required surgery, and that requires an ophthalmologist. We're a separate profession from physicians. We are not the same as physicians. You mentioned controlled substances. The information, currently we can prescribe controlled substances, but the amount that we can prescribe and what we can prescribe is limited, and it has to be written into the collaborative practice agreement, and if the physician doesn't want to write it in there, then we can't. Now, I heard what some of the data you had, but if you look at the National Practitioner Database, which looks at complaints against physicians, nurses, nurse practitioners, PAs, a wide variety of healthcare professions. Complaints against nurses are minimal on narcotics. Probably, and most of the studies actually show that we prescribe fewer narcotics, probably because as nurses, we have been taught many ways to relieve a patient's pain without using medication. So I just, that was one question that came up I wanted to answer. We do not want to practice as physicians. There are many things we don't do or don't plan to do that a physician does. We won't be practicing surgery. We specialize the minute we get into our APRN program. And so I can't go beyond the scope. I have to stay within a population of family. And that's a primary care specialty. Yes. So I have more information. If you mind asking questions, I'm done.
Questions? Representative Seitz.
Thank you. To inquire?
Go ahead.
Thank you. Changing the mileage piece and residency requirement seems like a no-brainer because we're doing that with other occupations such as policing so that we can get qualified people into those areas and they may not actually live there with, say, in a 75-mile radius. Do you think Missourians would be better served if we change the mileage requirement like this bill is trying to do?
I don't think this bill would remove any mileage because it would remove mandated collaborative practice agreements. I don't think it would help because some physicians don't want to be 75 miles away from somebody that they supervise. If they don't want to be 75 miles away, they aren't going to want to be 200 miles away. So I don't see how that's going to change things in a rural area.
Okay, thank you.
Representative Keithley,
To inquire?
go ahead.
Thank you. I guess I'm interested in exploring how these contracts work. It sounds like you've been involved with collaborative practice for a while. I'm assuming that then you're familiar with the contractual requirements, obligations, how these work.
Yes.
And some of the things, I guess I'll probably have some follow-ups too with it, but I guess just a place to start with it is how are these contracts formed in? Does a nurse practitioner approach a physician? Is it the other way around? And how is payment received? Is it a per patient? Is it a per work done by the doctor? And what do these contracts look like generally?
That depends on where the nurse practitioner is working. If the nurse practitioner is working within a system of clinics that a hospital owns, the hospital will negotiate the collaborative practice agreements. They'll find the physicians to practice with the collaborative practice nurses, and they will pay them an substantial amount to collaborate with nurse practitioners or advanced practice nurses. I know in the past, I've heard from some APRNs who owned their own clinics, and their collaborator might charge them up to $30,000 to $40,000 a year just to sign that collaborative practice agreement, so they could operate a clinic in a underserved area.
So is that's like a flat fee that gets paid out? It's not rated per patient. Do they take into account what the practice is like?
I think
volume, anything like that. How much work? I assume in collaboration that
depends.
It's different with every physician.
Yeah, that's going to depend on every physician. The collaborative practices I've been in the health department, most of the physicians, because we saw patients who couldn't pay, and most of the physicians did not charge much, if anything, for that. But then they didn't do much of anything either. The public health has an exemption in the collaborative practice agreement, and the physicians don't have to review as many charts. They don't have to be present at the clinic at any time. So their responsibility is a great deal less. And as a nurse practitioner at a public health clinic, I was very independent, except I could only prescribe certain medications depending on my collaborative practice agreement. I have been taught, and I taught my students how to prescribe medication appropriately. I taught the advanced pharmacology class at MU for several years, and in the advanced assessment class, I taught them how to do differential diagnosis and what to do with that differential diagnosis. So APRNs learn to do diagnosis and learn to prescribe. But in Missouri, we can't do that without a collaborative practice agreement, whereas as in those 26 other states, they can prescribe medications and provide treatments that were within their scope of practice without a written collaborative practice agreement.
So how does this change that collaboration? So in your practice, for example, how you do it, what would this, if this bill were passed as is right now?
This meant that in my, I'm semi-retired right now, and the job I currently have is doing Medicare home assessments, which does not require collaborative practice agreement because I'm not prescribing, and I'm not diagnosing new diagnoses. However, in my public health clinic, I saw a lot of patients who did not have a primary care physician or primary care nurse practitioner even. They had no one except the clinic there. And I caught, in my women's health clinic, I caught people with diabetes, with high blood pressure, and with numerous other health problems that had there been no requirement had this bill been passed, we could have expanded our hours in the public health department, and I could have provided care for those patients. Whereas what I had to do was I had to refer them to another clinic several miles away and hope that they went.
So why what was the point of that referral? Is that to get within a 75-mile radius?
No, it was because in public health there was an exemption. The public health exemption requires only certain things be done in the clinic, so I couldn't do primary care. I could do women's health, which is a type of primary care. I could do birth control. I could do breast and cervical cancer screening, I could prescribe certain limited medications, but it had to be a public health considered service, a population-based service. And primary care is not considered a population-based service. Therefore, I couldn't do that because my collaborating physician could not meet all the requirements of the collaborative practice agreement because, he didn't have the time. And so public health kind of I could have done so much more for my patients in public health had I not had a collaborative practice agreement.
Okay. Thank you.
Questions? Representative Thomas.
I'm sorry, but I'm really confused. I thought you were saying just a few moments ago that it wasn't the collaborative practice arrangement that limited you, but it was being in the health department that limited you. That you said if you hadn't been in the public health system, you could have done so much more, which has nothing to do with the collaborative practice arrangement. So please educate me.
Yeah. The difference is that the collaborative practice arrangement was much simpler in public health. Therefore, it limited what I could do in public health. I also practiced in a federally qualified health center. Doing primary care there, seeing anything that came in the door from a baby, 4-week-old baby to a 90-year-old woman. I diagnosed everything from ehrlichiosis to pneumonia to the common cold. There, I had a more extensive collaborative practice agreement, but the physician was on that. In that clinic, there was a physician on site. In many clinics, there can't be a physician on site. That's a problem.
And I'd like to follow up, since you're actually someone who was in the field and working, back to the issue of malpractice coverage. Because in a collaborative practice arrangement, you're not the person where the buck stops. It goes to your collaborator. So I have a hard time understanding how, if there was no collaborative practice arrangement anymore and the buck did stop at your desk, that your malpractice wouldn't suddenly jump dramatically because you suddenly become the deep pocket. There's no one to pass that off to. And there are limits, the 1 million, 3 million, for example, that most people cover at this point. Would your insurance jump to cover those rates?
No, I pay insurance as a family nurse practitioner. It doesn't matter where I'm practicing. Now, I can answer that question because at a previous hearing on a similar bill, I was asked, was malpractice insurance higher in the states, the 26 states that allowed full practice authority? No, it is not. I actually applied to my own Missouri malpractice insurance company for a spot in the District of Columbia, which has a very high population of urban underserved population, as well as that's where all, of course, the senators and the representatives are. The District of Columbia is one of the full practice areas. It's 26 states plus the District of Columbia. My malpractice insurance in the District of Columbia, where I could have practiced without a collaborative practice agreement, was actually have been less, about $500 a year less than it was in Missouri. So, and the other thing is, if you lawyers will sue whoever has contact with the patient. So not only will the physician get sued with a collaborative practice agreement, but I will be sued and anybody else that had contact with that patient. I don't have a problem. I've not seen the malpractice rates go up in the states that have full practice authority. It just hasn't.
Well, as was mentioned earlier, Missouri is cherry-picked as very, very friendly to defendants and for big jury awards. So it's very difficult to compare Missouri to another state because that's, again...
That may be, but surely out of 26 states and the District of Columbia, there'd be one other state that was as litigious as Missouri. And the malpractice rates are not changed by state.
I'm
not
curious. Okay, and I'll take you at your word. I have some questions about that. But back then also to education. In no way are nurse practitioners comparable to physicians. I mean, there's no residency. I mean, you have hundreds of hours of training, but there's thousands, up to 10 and 20,000 hours of training for physicians. Again, the statistics I see are that upwards of 60% of nurse practitioner programs are either fully or significantly online. That's not hands-on, and the practicum work is not necessarily with people that are part of the program. They're not necessarily medical educators. There's not a standard of care there. So could you possibly address any of that?
Yes, I can, because there is a standard of care. Nursing schools are accredited by there are two different accrediting organizations for schools of nursing. And school nursing, an APRN program is accredited by one of those two. They have standards. They have who can be preceptors, who cannot be preceptors, and how often you need to meet with a preceptor. We would develop preceptor manuals for our preceptors. You know, a lot of physician training is not necessarily done in the medical school where they are. I know medical students who have gone off to train with a physician. The physician I practiced with in my fairly qualified health center used to have medical students come in and follow him around and get part of their clinical experience there. He wasn't on faculty anywhere. In fact, sometimes he would send them with me to see patients. So, you know, but you're trying to compare apples and oranges. We're addressing advanced practice nurses. And so, yes, we have to keep contact with our preceptors. As a coordinator of a family nurse practitioner program, have we chosen to eliminate certain preceptors? We have. If we found that the preceptor was not doing what was appropriate or is not giving appropriate care, and we did monitor that, then we no longer would send students to that preceptor. Most of our, and then when you're talking about all these thousands of hours, there's a couple of things there. Again, RN education has a lot of clinical hours. Plus, most nurse practitioners are practiced as an RN. The person caring for you, if you're critical in an ICU, is an RN. There's not a physician standing over her shoulder all the time. You're under her care. That person is may decide to become a nurse practitioner, then she needs more clinical hours, but she's already got hours and hours of clinical. And sometimes what's forgotten in the residencies do have a lot of clinical hours, but they also count the hours that they're on call, which means that sometimes the intern is in the intern sleeping room, sleeping, and I know that from working at a hospital.
Rarely from my own experience, but
yeah, no,
it would have been nice to get some shut-eye. Didn't happen.
Well, maybe it didn't happen. Yeah, and sometimes that didn't happen, but it did happen where I was practicing in hospitals. So,
all right, thank you.
Thank you, Mr. Chair, to inquire. Thank you, Mr. Chair. To go back to the malpractice, you said that malpractice rates did not go up for that advanced practice registered nurses in any of the states where they passed it?
Not to my knowledge. Not to my knowledge.
Okay.
It has. I went online anticipating that question and tried to look that up last night. A lot of the studies that compared the states with collaborative practice to states without collaborative practice and their malpractice insurance rates seemed to stop about the time the pandemic hit. So, but the studies prior to that did not show any rate differential much at all. The rate differential comes in what kind of a nurse practitioner you are. If you're an acute care nurse practitioner, your rates might be higher. If you're a highly specialized dermatologic nurse practitioner, your rates might be higher. I'm a family nurse practitioner, so I know what the rates are for me.
Yeah, and there was a mention that Missouri is a more litigious state, so that might cause rates to go up. I did a search actually for litigious states, and I wonder if any of these places are in the list of places that have already expanded the scope of practice. California?
No, they have not.
They have not. New York?
They have.
They have. Georgia?
They have not.
It says the Philadelphia Court of Common Pleas and the Pennsylvania Supreme Court.
I don't believe, if Pennsylvania's, I don't think they have yet.
Okay. What about Illinois?
Illinois, you can transition into full practice in Illinois. And in Illinois, you have to spend so many hours in a collaborative, or so many hours or years in a collaborative practice prior to becoming full practice, but you can transition.
Okay, and the rates there have not gone up to your knowledge?
Not to my knowledge, no.
Okay, those were the top 5 listed, so thank you. Thank you, Mr. Chair.
Okay, so let's start with the malpractice question because I'm a little well. I want to thank everyone that's came by my office today. I've learned a lot, and it's been a great experience, and I'm now out of water in my office. If anybody didn't come by my office, you're welcome to come by later. So no, I had a great time. Thank you all. So the malpractice. So it's my understanding this law does not make nurses do a different job than they're doing now. So why would malpractice be a problem?
Exactly. We would be doing the same thing we're doing now. We just wouldn't have to have a mandated agreement from another profession to do it.
Just minus phone call, is that the Boggs way of putting it? Just minus the collaboration. So with the phone call, so we're and I'm trying to understand. So I'm taking everything I've gleaned over the last couple weeks, and so with I believe to Keithley's question there, as far as the he almost answered it, but so let's just say I'm the doctor, you're the nurse, and I say you got to pay me $100,000. I love that idea, but you got to pay me $100,000 to give you permission to do what you do every day. But you've got to have a doctor's signature or whatever you call it. So I'm the collaborator. So you have to call me. You get permission from me, and that's going to cost you $100,000 more dollars as a practice. Let's say you have, a short amount of patients, and so let's just say that's $100 a patient. So you're not going to pay that. You're going to pass that on, correctly?
I've not practiced, I have not owned my own clinic, but yes.
But I mean, as a business person, isn't that how it works as a business?
Yes, and so that increases healthcare costs.
It makes sense to me, because if you're going to take that loss, then you've got to look at your end and see if that's going to work in your budget or not.
Exactly, and it will increase the cost of healthcare.
So me as a builder, whenever materials go up, the building costs more.
Yeah.
And the building we're talking about is the patient that comes through our doors and they leave with the care that they're looking for.
That's one factor in the increased costs.
Sorry, it's got to bring buildings into it too, but I mean, everybody's heard everything from farming and everything else, but we're getting there. And I appreciate them bringing this forward, because I've learned so much, and I can't believe that some of these things exist, but in a rural area, so I think I need to lay the foundation. First of all, I'm in a rural area. I have people leaving my area going to job in Springfield because, there's better jobs, and I'm right in the middle of them. And it's not a huge deal because we can get there in 40 minutes, but we don't need to lose anything else. So a pullback, but for the malpractice side, if I understand it correctly, you're not getting permission to just do anything you want to do. You're going to do what you've done with permission.
Right. This bill would only give us permission to, to practice what we have been educated to do. Nothing past that.
So you know your limitations. You know what you're able to do.
And
you know what you've been doing.
Right. And we refer to physicians all the time. I referred to cardiologists. I referred to dermatologists. I referred patients to. I referred to physicians all the time because I know when something is beyond my limit.
But if you're stumped, you know that you're going to reach out to some. You're not just going to go, let's see, because it's a loved one's life. It may be my loved one, but you're not doing something other than what you normally do, and that was what I wanted to clarify. So, in my thinking, pardon me if I'm wrong, the malpractice is going to be the same as it is today. It might be in the hands of someone different. I don't know about that, but it shouldn't raise. I mean, maybe it will at the beginning whenever people's figuring out, but once you learn, your limitations. Mm-hmm. So, thank you very much. Thank you, Chairman. I believe that answered my question.
Other questions? I do have one quick one in relation to malpractice.
Yes.
What do you know what your limit is?
What my limit is?
What's your limit? Is it $1 million, $3 million? What's your limit?
I believe it's I believe it's a million per episode, up to 6 million per year.
And that would determine, the level you have, determine what the malpractice rate is.
Yes.
And the insurance
I could,
people
if I wanted to go for a lower malpractice rate, I could.
you could go for a lower. Insurance people I talk to say that, hey, the reason your rate is lower because you're either working in a collaborative or you're working for a hospital. And if you take that away as an insurance, their risk-benefit ratio goes up and they would charge you a higher rate, and that most of the physicians are at a $3 million or higher rate. So when that happens, your insurance is going to go up to be at the same level of risk that he is. Does that make sense?
That makes sense, but so far we haven't seen it in any of the states with full practice authority.
All right. And again, my question is,
And a lot of those nurse practitioners are not practicing with a collaborative practice agreement.
and my question is, with St. Louis particularly, where it is, people try to get into St. Louis jurisdiction because of what lawsuits are scheduled and at what rate. That is a question I have, different than some of your others. I mean, I think we're known nationally for our settlements have been, that's a question. So,
That's
all
a
right.
Missouri problem.
And your testimony is, what percent of nurse practitioners' training is online?
Okay, the online component, because I taught both classroom and online. And I will tell you the difference. The difference was,
Can you give me a percentage?
no, because the didactic, the book learning part was online. And the clinical is done with preferably another APRN. Most schools require that most of their APRNs do clinical hours with another APRN, although they can do it with the physician if they can't find an APRN to do it with. So
how competitive is that?
How competitive is that?
Yeah, I mean, like competitive as compared to competitiveness for medical school, DO school. How competitive is that?
To find a collaborative practice?
No, how competitive is your studies? In other words, are you graded on the curve? Are you graded on performance? Does everybody pass? How competitive is that?
We are, at the school where I taught, we were graded on a strict A, B, C, D scale. If you made a C in a clinical course, you had to repeat it. If you made a C more than once in a clinical course, you were gone.
Okay, that was answering my question. All right. Other questions? If not, thank you very much. The next person would be a for against who has a significant amount of data. Who might that be? Okay. Give your name, sign the roll, sign in, and tell us about your testimony.
Thank you. I'm Dr. George Hruza. I'm a dermatologist specializing in skin cancer treatment, former president of Missouri State Medical Association, St. Louis Metropolitan Medical Society, and the American Academy of Dermatology, and adjunct professor of dermatology at St. Louis University School of Medicine. So thank you for allowing me to testify on these 3 bills. Actually, 2 bills, I understand. Sorry. So I'm testifying in opposition to those bills. I speak on behalf of the Missouri State Medical Association that represents thousands of physicians in Missouri in strong opposition to these bills. Patient safety of Missouri residents, your constituents, should be top of mind when considering changes to Missouri healthcare laws. Any proposed healthcare legislation should be assessed to whether it advances high-quality, affordable, accessible healthcare for Missouri residents. These bills earn an F on all counts. Malcolm Gladwell estimates that it takes 10,000 hours to become an expert in a discipline. How do nurse practitioners and physicians compare? Nurse practitioners have 2 to 3 years of post-college education versus 4 years for physicians. Nurse practitioners have no residencies but 500 to 720 hours of preceptorships, while physicians have 12,000 to 16,000, that's for dermatologists, of direct patient care through residencies and fellowships. That's in addition to the previous 2 years during medical school where they have clinical training as well. And even more concerning is that 60% of, as Dr. Thomas mentioned, of nurse practitioner programs are 100% virtual. And then they do the 500 hours of clinical training outside that. And we all know the disaster virtual education had on our K-12 students. So do you want to have someone who has been virtual training or learning to be able to work on you? Finally, physician training is multiple years of gradually increasing responsibility and independence with rigorous understanding of differential diagnosis in residencies accredited by the ACGB. APRN clinical training is through mostly observational preceptorships with variable quality control. In medicine, such preceptorships were replaced by residencies almost 100 years ago due to the inadequate training preceptorship offered for independent practice. The evidence in practice is also compelling. In my specialty of dermatology, nurse practitioners perform twice as many biopsies to find a skin cancer than a dermatologist. Nurse practitioners prescribe opioids to more patients than physicians, which is concerning at a time of the opioid crisis we are experiencing in Missouri. Really, we don't need to be prescribing more opioids. They order many more laboratory tests and imaging studies and prescribe more antibiotics than physicians. In the emergency room, patients treated by nurse practitioners without physician involvement have worse outcomes, especially for complex cases. This suggests that nurse practitioners are less certain of their clinical diagnosis, evaluation, and treatment plan than physicians. Also, what about consumer protections? Liability insurance has been mentioned and bandied about, but it's really about protecting the patient. Where are the deep pockets going to be? Affordabilities. These issues of actually some uncertainty leads to significantly higher costs due to unnecessary tests to the healthcare system and to patients, with many now having high deductible plans, so they have more out-of-pocket costs. Unnecessary tests also have negative consequences for patients. For example, unnecessary skin biopsies lead to more painful scars, risk of bleeding, and infection. Studies in hospitals, emergency rooms, and accountable care organizations have demonstrated that nurse practitioners operating without physician involvement give rise to significantly higher healthcare costs. So do nurse practitioners improve access to rural care? That is proposed as being useful, would be very helpful. Actually, they do not. Nurse practitioners practice in exactly the same geographic areas as physicians, desirable suburban locations. 9% of nurse practitioners practice in rural areas, and only 2% practice in federally qualified health centers. There is no causal link between independent practice and a mass migration of nurse practitioners to rural areas. This has not occurred in other states. And independent practice will not help to solve the access problem in underserved areas in Missouri. There are other ways to deal with that. So in conclusion, what do your constituents think about independent nurse practice? 95% of patients say it is important for a physician to be involved in their diagnosis and treatment. 3/4 would wait longer and pay more to be treated by a physician. 91% say a physician's education and training are vital for optimal care. Nurse practitioners are very valuable members of the healthcare team. I have several in my practice, and a physicians-led healthcare team is the high-quality, cost-effective care that our Missouri physicians deserve. Thank you so much. Did my 5 minutes, I think.
I'm sorry. I'll try to give you when you're getting short, and
Thank you.
I'm sorry. All right. Representative Fogel,
To inquire.
go ahead.
Thank you. Can you walk me through, in a typical collaborative practice agreement, and I don't know if this is defined by the agreement, by statute, by something else, but at what point do you, as a doctor, review the charts of your nurse practitioner who's working underneath you? Can you walk me through the timeline of that process?
So myself, I actually work with a physician assistant, and I review all their charts, every single one. Nurse practitioner I work with, I review every single chart. So I'm maybe an outlier, but I feel it is really important for me to be involved, because it is also my license on the line.
Of course.
When my nurse practitioner takes care of patients.
What is the requirement, though? Is it 2 weeks? Is it 30 days? I would imagine that's defined somewhere, that the doctor has to review the charts within a certain timeline. Do you know what that timeline is?
I do not.
Okay, because my question is, a lot of the concerns that you brought up are related to cost of healthcare, over ordering tests, and it just seems like a lot of the physicians I know maybe are reviewing those charts after the patient's already left, so they're already ordered whatever they were going to order anyway, so it doesn't really matter if the provider has a collaborative agreement or not, because they've already made the choice of what they're going to do in that visit. The provider is not holding their hand in the time that they're in the exam room. Is that fair to say, or would you say that's off base?
I would hope that a collaborative agreement is not just a piece of paper. It is a setting where the physician is available to the nurse practitioner, so that when she sees a patient that she has some questions, she's a little bit uncertain possibly, hasn't seen that before, she will contact her collaborating physician so that they can have a kind of curbside consult and address the issue. So that is how you would reduce the problem.
I want all of us to be aware that there are male NPs, mid-level providers, and they're female doctors. We're all, everyone in this room has used kind of gendered language, so I want to point that out. So if someone, a subsequent testifier, could explain that to me, I want to understand what that process looks like, because I know, physicians oftentimes, or at least the physicians I know, aren't even looking at that chart until 2 weeks after the visit. And if that's the case, I just don't think that your concerns will change one way or the other based on whether or not there's a collaborative practice agreement. So I would just like to understand that for someone who's coming up next.
I totally agree. Thank you.
My second question, what was the statistic you listed about FQHCs? Because that seemed really low to me, that only
That 2% of nurse practitioners across the whole country. That is from the, I actually have a packet here of references that I have for everybody.
Okay, I would love to look at
review,
that. That
so you
number
can
just
review
seemed
those.
particularly low, just based on the FQHCs I know in Missouri. So if someone has any counter evidence, I would like to hear that as well. Thank you.
Questions? Representative Lewis.
Inquire.
Go ahead.
Thank you. Good evening. Thank you for being here. I just had a question based on what the previous witness said and what you're saying with your collaborative practice. So I think I was very intrigued by the financial, to enter a collaboration that it can cost like 30 to 40K or something. So, and then also, I guess from your experience, you work with nurse practitioners. What is your financial agreement to collaborate with them?
Well, what we have in our practice is that the nurse practitioner gets salary or percentage of productivity if they are billing under their name, and the supervising physician usually gets a monthly stipend not related to their productivity one way or the other. I believe in our practice it's about $2,000 a month.
Okay. And then is there a financial incentive for signing charts? You get additional money for chart reviews or?
No.
Thank you.
Further questions? Representative Seitz.
Yes, to inquire?
Go ahead.
Yes. I think you suggested that most nurse practitioners practice currently in a suburban setting. Do you think that it's because they practice in a more urban setting because of the restrictions that this bill is trying to alleviate? So really, if this bill passes and becomes law, wouldn't more nurse practitioners begin to practice in rural areas where there might not be the healthcare opportunities that we have in the larger cities?
That's certainly not been the experience of states where nurse practitioners gained independent practice. I do have an example of Oregon. Is a state which has been looked at, and it's going to be in this handout, which shows that physicians and nurse practitioners are exactly in the same locations before and after the law. So there's been no movement of nurse practitioners to rural areas because of the independent practice that they gained.
Okay, have you ever practiced in a rural setting?
I have not, but some of the physicians in my practice, I have a single specialty dermatology practice, do practice in a rural area in Illinois, in Mount Vernon.
Okay, thank you.
Representative Boggs,
To inquire.
go ahead.
So I just want to get something straight in my mind, because, from the document you read, it sounds like that there's a lot more oversight. But whenever I think about collaborating, I think about someone being at one location and someone else being at another location. So let's just say, for instance, you're the doctor, I'm the collaborator. I call you, I've got the patient there, and I'm telling you what I see. You're not seeing the patient, right?
Well, it depends on the setup you have. You certainly can nowadays. It's very easy to
Sure,
see
and
the patient.
I get that too. So yeah, that's maybe a piece and another question. But most of the time, if we're collaborating, you're making a decision based on what I present. Is that a correct assumption?
That would be how and that's how it actually works when you're training in residency. You present, you're as a medical student or an intern, present to the higher up person the case.
Yeah.
And often that's actually done off-site as well.
So then there's a trust built in between. So that person is really not doing anything above, I hate to use pay grade, but what they're trained for. So you're not giving them permission to do something that they are not trained to do, correct? So if I collaborated with you and said, hey, I don't even know the situation, but say I've got training to here, you can't give me permission to do here, correct? I've still got my limitations. This law does not broaden my limitations, I guess is the way I should ask that question.
As far as what you can do, someone mentioned doing brain surgery, and certainly this law actually is silent on that. Just like the medical practice law is silent on that. I'm a physician and surgeon, and there is no restriction on what I do, so it will be the same for nurse practitioner. So it will be what they feel that they are able and ready to do. And there is nothing saying that they can or cannot do dermatology or obstetrics gynecology, because the law only says they're advanced nurse practitioner, and the scope is whatever their training is, and there is actually no restriction on it. So this removes any kind of checks and balances.
Okay, I think I'm confused.
Sorry.
Thank you, Chairman.
Sorry.
Questions? Representative Courtway,
To inquire.
go ahead.
Thank you. Thank you for being here. Just a real quick question. In your practice, you said that you check all your charts of the nurse practitioner and the advanced physician. So what is your percentage basically each day or week of how much you actually get to see patients on your own if you're always basically checking over everyone else's work?
Well, so I do 40 hours a week of seeing patients, and I do skin cancer surgery. And at the end of the day, I review the charts. I review all the charts that I dealt with, and the nurse practitioners and the physician assistants chart that we have in the practice. It actually does not take a lot of time. The one benefit of some of these electronic records is that they're kind of formalized, very formalized, so you can very quickly get through to make sure that everything is okay.
So if you work your normal 40 hours doing your patients in surgery, then roughly what is your amount of hours you put in total per week then with that extra?
It's probably about 5 hours a week.
Okay, thank you.
Representative Keithley,
To inquire.
go ahead.
Thank you, Chair. Do you have any collaboration agreements or anything outside of anyone who's on location at your practice or your office?
So I myself do not, and our other physicians all have their collaborating agreements with nurse practitioners in their setting. So we do not have off-site, so like the 75-mile type of thing. We do not have any of that. We have everybody's on-site, and they're most of the time directly supervised, really, because there's a physician there at all times.
Okay, thank you.
Representative Hunziker.
Thank you, Mr. Chair. You were talking about reviewing charts and how you can do it fairly quickly. And what is the purpose of reviewing charts?
Is to make sure that we don't have any surprising outliers, because the dermatology is a very visual field, so we have pictures in there. So I will look at the picture and make sure that the diagnosis matches, and then also look at if they have a diagnosis, if the treatment matches. Also, we generally do not have nurse practitioners seeing patients as a new patient. You usually see them as established patients. So they already have an established diagnosis. We do not have them actually do the original diagnosis.
So you're making sure the treatment matches with the diagnosis that you gave them, the patient, is that right?
Originally, and of course there can be changes because it's an established patient. Sometimes new things come up.
Of course. And you review your own charts too?
Yes.
Is the review process the same for your chart as the nurse practitioner's chart?
Mine may be a little faster because I actually saw the patient, so I remember the patient, and so I can that goes faster.
So you look at it and say, "Yeah, I saw
yes,
the patient, and I put down what I thought thought was at the time."
Thank you.
Okay, thank you, Mr. Chair.
Representative Gregg?
Inquire?
Go ahead.
Thank you. So you said you do have some APRNs
Correct.
on site?
Yes.
Okay. How many do you have?
Well, in my setting, I have one, and then in our other upstairs in the same building, we have one now, and then in our Illinois office, we have two, and we have another Illinois office. We will be getting another one, so we have a total of about 4 or 5, but different physicians are supervising those.
Sure. Okay. How often do you find errors in their recordings?
Fortunately, the ones that I have had that have been with me my physician assistant has been with me for 7 years, and I find those quite rarely.
In the beginning, did you find many?
But in the beginning, I find a lot more, and that's where in my mind the collaboration comes in when we discuss cases and talk about how we might want to handle them differently and what would be a good way to manage the case.
Okay. And you said you've got about how much time do you spend checking over?
It's about 5 hours a week.
So 5 hours a week for the one that you've got?
Yes, for the one that I've got, yes.
Okay, thank you.
Actually, I'm sorry, I misspoke. I have two because I also have I do now have actually a second one. So
and both on site
sorry.
then still?
Both on site, yeah.
Both on site.
So I apologize. I didn't want to.
Representative Seitz, is this your second time on this person or not?
Yes, as a chairman of tourism, I think that allows me to ask 2 questions.
I'm sorry, you're not the chairman of this committee.
Thank you, sir.
I give you permission, but again, in sake of time, and I abused that while ago, and I apologize, but in sake of time, make her quick.
Okay, thank you very much. All right, you inferred while speaking to Representative Boggs that APRNs would be able to treat possibly outside of their training. And I'm looking at the bill. It says, page 40, line 45, practice of advanced practice nursing, the performances for compensation of activities, services consistent with the required education, training, certification, demonstrated competencies, and experiences of an advanced practice registered nurse. So I'm seeing right here in the bill that I don't think they would be able to treat patients outside of their training. That would be part of the law should this bill pass.
So the reason I mentioned that there would be no more checks and balances is because the Board of Nursing determines the scope of practice for advanced practice nurses, and at least so far they don't seem to find any restriction in their opinion. So that is why I was referring to that. So right now, you still have the physician that's involved in the care, so that to make sure that there's nothing that happens beyond where it should be.
Okay, thank you, Mr. Chair, for your indulgence, and I owe you one.
When I come to tourism, I'm one up. So, all right, Dr. Thomas, Representative Thomas, I'm sorry.
Brief inquiry, please.
Go ahead.
Thank you. I just wanted to thank you also for being here and to comment that it would make perfect sense that at this point, because you're in a collaborative practice arrangement, that you wouldn't be finding a lot of errors because what you're reviewing in the chart, if I would understand correctly, would be if there had been questions about a particular diagnosis or an intervention or something that needed to be done, you've already worked with your collaborator, and that person probably would have been contacting you and working that out before the patient visit was over and before the documentation was done, so that one would expect that you have a good ebb and flow in your working relationship, and that ultimate documentation is the collaboration between you and your nurse practitioner, and there should be minimal errors at this point that shows the effectiveness of ongoing collaboration. Would that be a fair assessment?
Exactly, and every day I have my work with my. They call me over with a patient that actually comes within those 5 hours of my supervision. So I go over and they have a question about a patient, about something that they want help with, and we help her. With a physician assistant, it more often is because she helps me with closing, suturing up, and it's because she has a finger in the dike and there's some bleeder that she needs assistance with. So that to me is the collaboration part of it. It's that we work together, and the close collaboration, I think, is the key to optimal care.
Thank you.
Other questions? I have one real quick one. As former president of the Missouri Medical Association, what's the average cost to get through medical school, through medical school, not residency? Do you know that number?
It is north of $200,000 to do that. Now, that is at a private medical school. If you go to state school, might be less than half that. Unless you go
a father, somebody's been through there. I wish we'd got through in $200,000 because that was fairly reason we didn't. We don't know what the average is.
Well, the average. So as I said, private schools are north of 200,000. And actually can go all 250, 260. Public schools are going to be in the 50 to 100,000 range, the much lower range in state schools tuition.
Talking about it 4 years or a year?
That's 4-year medical school. Now, of course, you have 4 years of college before then, too.
Right.
So that will add some more. Except if you go to my alma mater, which is New York University, which actually eliminated tuition for medical school a few years ago.
You're talking tuition only, not room, board,
Yes.
books. Okay.
And of course, it was after I graduated, so I wasn't too happy. Sorry.
So could that amount of debt, what would that, if you're competing with that amount of debt for medical school, could that inhibit people from going? I'm a rural area. I'm in a medical desert. Some of you in this room know what I'm talking about, a real medical desert, Gloucester Hospital. Could that prevent physicians to going into areas because they can't compete with somebody who's a much cheaper education to go back? My fear, and this is a fear, is that we very well could be starving our communities of physicians because of the difference in debt of education.
I think that really applies especially to primary care specialties. Pediatrics is the lowest paid specialty. So it's not just the $250,000 of debt plus another 50 or 100 from college. It's also the extra years that you're going to commit to this, and the many hours and sleepless nights, including sleeping or not sleeping in the on-call room. So I know many physicians actually recommend to their children not to go into medicine and to go into physician assistant school or nurse practitioner, because it is also a well-paid specialty. You can take care of patients. You do provide good care. So it's very rewarding both financially and emotionally, or feeling a sense of purpose. So I do agree with you. I think that's a concern that it could certainly reduce that, especially for primary care, which is where the shortage is the greatest.
Well, I know as a veterinarian, return to capital employed, people don't go to rural areas because return to capital employed is not adequate. I don't know if that's the situation. I have a real fear that we could be completely starved and only be nurse practitioners in rural Missouri. Now, it may be anyway. That may be the fate we're going to see. But I have a fear looking at the debt load. Can they go back with that debt load and be competing with somebody doing the same things at a much lower cost of education? I don't know. I am toying with that idea. So, other questions? If not, thank you very much.
Thank you.
Our next, you're going to give these.
Yeah. Thank you.
And you have those. You have your statistics footnoted, I hope.
Yeah.
Good. If you have statistics, please make sure they're footnoted, or we're just assuming where they came from. And I would rather not assume. I'd rather know where the study came from and make sure it's footnoted. So with that, in opposition, then you would have four.
It's okay.
Four. I am confused already, and it's only 6 o'clock. It could be 12.
It has been a long day, right?
Not yet. It hasn't. Hang in there. So I would like for you to go ahead, and again, about 3 minutes. I will give you one when you got 1 minute left, and try to wrap it up.
All right.
And again, I'm not being picky, but we're all seeing how long it's going to take, and it looks like it could be a long time.
Could be a long night.
So
yes.
go ahead.
Thank you all very much. My name is Karen White. I'm the CEO of Missouri Highlands Healthcare. I have the distinct honor of serving at a federally qualified health center where we employ 8 physicians and 25 APRNs. We have long been known in the rural areas of utilizing APRNs to fill the void, because that's been the one thing I don't think has been addressed fully, is access to care in rural areas. Physicians are not knocking down our doors to come to work for us. And so with the limitations of the APRNs, we really have to be very strategic as we place our APRNs throughout our 7 counties. 75 miles, it won't even get me halfway across the coverage area I have. So I am limited on the number and the location of my APRNs in conjunction with the physicians that I have employed. Again, I have 8 physicians, 25 APRNs practicing at 12 locations. It is a nightmare some days to staff and make sure that patients can be seen. But access to care is what we do. We have to ensure that our constituents, your constituents, my patients, have access to care in rural areas. We lost 2 hospitals, one in 2016 and another in 2018, leaving us to provide care in 3 counties that have no other services. We're it. There isn't enough physicians coming out of medical school wanting to go into rural areas to practice medicine. We have utilized nurse practitioners for a very long time. I have the distinct honor when I came to work at Missouri Highlands of working with one of the very first nurse practitioners in the United States. She had some wonderful stories to tell, and she was able to provide care. So I think it's been mentioned, what is it that an APRN does that's different than a provider? And again, it comes down to scope of practice. My nurse practitioners, my APRNs, provide the same care in the rural areas. Most of the patients that come in the door don't know the difference. All they know is that there is a care team surrounding them and that their needs are being met. So I do want to, again, focus on the access to care issue as being one of the big things that this bill would address, especially, like I said, in rural areas.
Just an aside, just today I had one of your groups listed as how we should do rural medicine at Piedmont. So
yes,
you need to be very proud of.
I am very proud of the Tonys.
That is someone they refer to a lot, and his comment says this is how we should do rural medicine, and it works. So.
And it works. The Tonys, father and son, have practiced medicine in Piedmont in Wayne County for quite some time. The younger Dr. Tony is, of course, very passionate around addiction medicine and has really led our organization and the APRNs along the way to really expand that type of care and to make sure that it is delivered at the rural clinic. No more stigma is attached to seeking medically assisted treatment for substance use disorder. And but he's limited. He can only take 6, right? So if we could do away with this, think of what else we could do.
Okay. Questions? Dr. Thomas.
To inquire, please.
Representative Thomas, I am sorry.
That's okay. Thank you. So you made the statement, and I totally agree with this, that, and nurse practitioners do a wonderful job, and we need them. We need the entire range of professionals that provide healthcare services. But again, in my opinion, and traditionally, there has been a hierarchy of supervision. And you commented that most clients don't even know the difference between who they're seeing. So is that not a little confusing for some people? And on top of that, if we take on face value, and I'm just going to ask you to do that for a moment, the data that says that on average, nurse practitioners require or utilize more tests, more procedures, whatever, to get to their diagnosis, how would the patient know that they were subjected to additional tests? Because ultimately, if they do get to the right diagnosis, they may not realize that they had a couple extra blood tests or they had extra x-rays or something. They're not going to know that. And so I have a hard time understanding how that's comparable care or the best care possible without, again, some type of collaborative arrangement so that you've got people working together and trying to, between them, utilize services the most efficiently and effectively that they possibly can.
Okay. Let me unpack that just a bit.
It's a long question,
It's a long question. And do you need a job? Because I could so totally use. Sorry. Today was White Coat Day. I think a lot of us walked around handing out business cards trying to recruit. So sorry. Our nurse practitioners, so a story comes to mind. I live in the middle of nowhere. We like to tell our stories. And there is a nurse practitioner that has been practicing, probably 15, 16, maybe 18 years. Patient came in to see her, had been other places. Nobody could figure out what was going on with this patient. Nurse practitioner sat down, went over the symptoms, started ordering tests. Those tests came back negative. She ordered more tests until finally she was able to diagnose this patient. And I don't remember what it was, but no one else had caught that. The patient had been to an internal medicine doc who had missed it. But the nurse practitioner sat down, went over the symptoms. So my argument back, or not really an argument, as much as a statement, they look at what is being presented by the person before them. And in my rural area, I have people with a 2 to 3 is average, 4 to 5 is more normal, comorbidities. Where do you start? You start with the test. You start with the basics. You start with the knowledge. Yes, folks can diagnose based on symptoms, but isn't it better to diagnose based on data? And that's what they do. They get
history is data.
History,
Good
history is data,
and all physicians are trained in doing that. And
review of systems is
that's
so
one
important.
of the issues that because there's additional training, a physician can come in and immediately rule out certain conditions and not have to start with basic tests because they already know those aren't part of the picture. and can jump into
But
more
for the most
sophisticated
part,
tests. And again, I'm clearly
yeah.
speaking in generalities, but from my own experience, I worked in the VA system, among other places, had nurse practitioners, psychiatric nurse practitioners, very well trained, long-standing. However, one in particular, after I kept getting referral after referral from this person, and they were very basic cases that didn't need additional evaluation, I went and asked her. And yes, I had male nurse practitioners there as well, but this happened to be the female. And I said, I'm a little surprised why I'm getting all these referrals for these routine issues. And her answer to me was, I refer everyone. Now, I don't know how that's efficient because she wasn't confident enough, apparently, in her diagnosis and wanted to cover herself. She referred every patient she saw for psychiatric consultation, despite having already done an assessment and treatment of her own.
Yeah.
And again, I recognize, and we can go back and forth,
We could,
individuals,
yes.
that's not the way you prove a case.
Right.
We need to look at generalities. But just to let you know.
Primary care, family practice, family practice nurse practitioners are just good. I mean, they care, and they are really good to dig in deeper because they have a nursing background. Right? So that has, the conversations have been around the amount of time that a nurse practitioner spends in clinic. Many of them, the majority of them, have spent years and years and years in nursing prior to going on to being an APRN. And while they were in their APRN training, they were doing rotations. We do them all the time. We love to have nurse practitioners come in and do the rotations with us because we give good quality care. Case in point, the Tonys are just wonderful. That is how you do rural medicine. That is that partnership. That is that team approach. And it is. Healthcare is a team approach. And I think giving APRNs a little more, I don't want to say, how do I dare say this? Lifting the restrictions, allowing them to practice the full scope, not having a physician spend, the prior physician said, hey, he spends 5 hours a week. That's time away from our patients. Those physicians doing those chart reviews, that's time away from patient care. Does that fix our access issue? Taking that away would allow a lot more time for physicians to see patients face to face.
Well, I appreciate your perspective. I don't like the subtle implications that nurses care and doctors don't.
Oh, no. I don't ever. I have.
The way that was phrased,
so
I have
sorry.
a little issue with that.
Yeah, so sorry.
But again, I appreciate what you all do. But again, flight attendants spend an awful lot of time in planes and around airports, but we're not going to ask them to fly the plane. So again, there's differences in training, and as you said, the best system is a system of care, a collaboration, a hierarchy, if you will, but a breadth of experience and specialization to give that team approach. And I highly agree with that. Thank you very much.
Representative Stinnett?
To inquire.
Go ahead.
So we're really considering sort of an all or nothing approach right now. We're either in a collaborative agreement or we are not in a collaborative agreement. And in your testimony and in prior witnesses, we're talking about APRNs that have been practicing for 15, 20, 30 or more years. Their experience is quite vast. But what about an APRN who's maybe just graduated, should there instead be a process for removal of that collaborating agreement versus just you graduated, you're done, you're set? In addition, I'd like for you to speak to, I don't know about your organization's experience or the type of care that you provide. Is it all in primary care? Should we have different considerations for APRNs that work in different settings? Maybe there needs to be a collaborative agreement in a more specialty setting, but maybe in other settings that could be. I mean, we heard earlier testimony that in public health there's already exemptions. Maybe there's some room there.
And I can only speak to what I know, which is primary med.
Sure.
And we also do an OB-GYN practice, as well as some pediatrics. And so it's to review kind of what you're asking as far as, should a collaborative practice be established for a new APRN? Is that what you are... And if it was a specialty,
sort of a step in the process,
right?
I
can let you know that even new physicians coming in, we still do peer reviews, right? They are still working with our chief medical officer for a period of time. I don't see that practice being any different. With a new APRN, they're still going to be peer reviewed and with the chief medical officer or the assistant medical director, one of the two, for a period of time. And that is, that would continue because that would be, what our practice would choose to do, just to ensure that, good patient care is being handled, whomever is doing that.
Sure, and that makes sense maybe for your organization, but what we're talking about doing is removing that completely, and that may not be the case in other organizations. So I commend you for that being the practice. I think that's important, and I'm glad that your organization does that, but I do think it's important to highlight that may not be the overarching practice throughout the state. I don't know.
Yeah, and again, I can't speak for a hospital system. I couldn't speak for a specialty care clinic. None of those. I can only speak for a community health center and the primary care that we provide.
Sure, thank you.
Further questions? I have one quick one. We referred to the Tonys, which I just met Dr. Tony, and yet you're telling me that they're key to your operation because of their oversight and their leadership, but you're wanting to do it without them. I'm a little confused on.
I need all players on deck.
That's my question. Is
they are key,
and
the way
my understanding they were key to the quality that you had, and yet in your testimony, kind of leaves me to think they maybe weren't that key. Is that?
No, and I don't want to lend
right.
that. So right now, we only know how to practice under the present law, which is a physician, and they can support 6 APRNs.
Okay.
Okay.
That was my question.
Yeah.
More questions? Yes. Representative Gregg.
Inquire?
Go ahead.
Thank you. Okay, so I'm glad you're here because I'm all about the underserved rural areas. Where are your areas that you serve?
I am in Butler, Carter, Iron, Reynolds, Ripley, Shannon, and Wayne.
Okay. I'm in Southwest Missouri. Luckily, we're not in a desert, but just east of us we are. And today, thanks to all the visits and emails that I got, so to echo Representative Boggs, thank you for the education. What comes first, the doctor or the APRN in an underserved area?
You have to have a doc right now under present law.
Okay.
Before you can move into engaging an APRN.
So if there's an area that does not have
within
anything,
75 miles, yes,
an APRN has to find a doctor. The doctor doesn't find the APRN all the time, right?
No, you are correct. And it is our practice that when we engage a physician, we do disclose, obviously, that we do practice an APRN practice.
On your APRNs, if they are over their head or there's something they just don't know, without the collaboration, what would they do?
Depending on what it is. So I can think of a time when I had an APRN practicing in Annapolis, Missouri, who had a patient come in with a problem. I believe it was a podiatry problem, and called the one of the area podiatrists, which was a couple of hours away, and did a phone consult, and then set the patient up for a specialty care visit. They do recognize, obviously, when there is an issue that is beyond what their training and scope is.
Okay. And if they did something other than just, ordering too many tests or anything like that, we're talking major, because that's really the big fear. They do something they really shouldn't be doing, and there are dire repercussions from a patient. What are the repercussions down the road if we vote this in, and they do something, messes up, and the patient is scarred or lifelong? What would be the repercussions for an APRN?
I would presume, since I am not an attorney, I don't know what the repercussions would be, but I would presume that there would be a lawsuit on that.
So the APRNs are taking this real seriously because they know the repercussions down the road then. Okay, thank you.
Further questions? Representative Courtway.
To inquire, please.
Go ahead.
Thank you. Thanks for being here. I see where rural counties are struggling, and so I'm not one way or the other yet on this bill, but I have a question. So let's say Representative Dr. Thomas and I both come to work for you, and you set us up in a clinic, and she's the doctor and I'm the APRN. What would a difference in salary be? Because I'm just trying to see if maybe this is beneficial to the clinics that they can pay less, or if it's truly because we want to get the care there.
It is, I would say, for most people who run a health system, it is a little bit of both.
That's what I'm thinking.
I could use more of everybody. I just can. I can't see the number of patients that we need to see. So for me, it is an access to care issue. And I know that I can't, because I'm trying, trust me, I've been trying to recruit a physician to come in to a couple of my clinics now for well over 3 years. And it is, it's impossible. They don't want to be in Eminence, Missouri, or Ellington, Missouri, or Van Buren, Missouri, or Poplar Bluff, Missouri.
They're totally missing out if they don't want to go to those places.
Exactly. That's what I say too. But I can get an APRN to fill those needs.
And then is there a difference in that salary?
There is a difference in salary. Like it's half. It's typical to see an APRN salary being about half of what a physician is.
And do you think if we would pass this that they would start to expect more, the APRNs?
I don't know. There would be more opportunity for them to go to work. I think that is, so if there's more opportunity, more jobs open to them, I think, if you go back to economics, you're going to maybe see a little more level playing field on that. I don't anticipate, and maybe that's very naive of me, but I would not anticipate that to go up.
Okay, thank you.
Dr. Thomas?
To inquire,
Representative
please.
Thomas, I'm sorry.
That's okay, thank you. So help me understand as far as reimbursement. Do the nurse practitioners get the same rate of reimbursement as physicians? For the clinic's sake, their percentage of reimbursement, does it matter who generated that bill, that procedure?
So if a physician and a APRN both see a 99213, it gets reimbursed the same. We do utilize our physicians to see the higher acuity.
Okay. And do you also get reimbursed per procedure? Or I mean, obviously for procedure code, I assume, but maybe if you order x-rays and blood tests, and so it kind of complicated increasing the level of care. So at some level, maybe if somebody's ordering more tests, you actually might make more money because you'd bill at a higher level, whether or not those tests were necessary?
There is some reimbursement, so I will tell you, ancillary services typically are not very high reimbursement. And
Doesn't that lead into complexity of care, which gives you a higher billing code, which gives you higher reimbursement?
Complexity of care is an E&M code. Goodness.
Yes.
Yes. And that is as much time spent face-to-face on that. So,
But you're also, built into that, is there not some issue of the actual, you discuss procedures with patients. It increases the time if you have to explain the risks and benefits of procedures or this or that intervention. So, there's an overlap there.
Okay.
So more procedures probably translates to more time and more complex care, correct?
it could.
Okay.
Again, we've
And
not
therefore
really
higher
looked at that.
Okay.
Typically, whenever we have chart audits completed, which we do, that is typically not an issue that we find on that.
All right. Well,
So-
thank you.
And the other thing is, being a federally qualified health center, we try to roll all the care we can into the sliding fee discounted amount. To the point of, the more tests that are ordered, things like that, for our sliding fee uninsured population, they pay the same amount regardless of what gets ordered.
Okay. Thank you.
You're welcome.
Representative Nixon Clark, and I apologize. You've been hiding behind Brother Greg's head, and I just didn't see you there.
That's okay. To inquire, Mr. Chair.
Go ahead.
Thank you so much. So I have had my share of hospitals, doctors, you name it, for the last 7 months. And so you testified that there are 8 physicians to 6 to 1, right? 6 APRNs or nurse practitioners. Correct me if I'm wrong.
Right. The law allows for a 6-to-1 ratio.
Okay. And is this because of the caseloads from the doctors not being able to physically handle, or if they're not available, you typically would see a nurse practitioner, correct?
That is correct.
Okay. And also, like hospital stays and things like that with the RNs are able to see firsthand, not with the doctors or the physicians present, correct? Okay. So my question is, with that being said, the nurses or the APRNs, they do require a certain amount of training, correct? So when they come out of school and they are a RN, how many years of training do they require to get to the APRN?
An RN, I believe, is a bachelor's degree, and somebody that is in education will have to follow up on this. And then an APRN would be additional training on that, and so they can get a master's, or most of ours have a doctorate.
Okay, so estimate how many years?
So a doctorate would be what is that? So a master's is 6, and a doctorate's 8.
Okay, but they're still training on the job, correct?
Correct.
In order to get to
Yes.
the APRN.
Yes.
So when it was testified earlier that a new APRN coming out wouldn't have as much knowledge, but technically they would, because they are getting the proper training along the way,
Along the way.
correct?
That is
Okay.
correct. And they also do clinical rotations with a preceptor. And so we serve as preceptors across all of our clinics.
Sure. Okay, thank you. Thank you, Mr. Chair.
Further questions? If not, we're ready to move on to the next opposition. Let's see, this was
Thank
4.
you.
Next is opposition. Thank you very much for your testimony. Give us name, address, name who you're with, and
Ooh, man, can we all stretch? This is going a long time.
no, we don't stretch. No. How do you think
stretching.
we're ever going to get out here if we stretch or go to the bathroom? This
No
is it.
stretching. Well, thank you so much for letting me come and talk today. My name is Misty Todd. I am a family physician who practices obstetrics in Cole Camp, Missouri. So we've heard a lot about access to rural care, and I and my husband, who is also a family physician who does not do obstetric care but is the nursing home director for 2 nursing homes in our county, in Benton County, we have dedicated our lives to increasing access to physician-led healthcare in rural Missouri. I grew up in Northeast Missouri and fell in love with a guy in Sedalia and ended up saying Sedalia's too big, and we both found small communities to practice. And in doing that, along the way at my training at the University of Missouri, became involved in increasing access to care, and actually currently am the first rural training track residency director for physicians training to be family medicine physicians in the state of Missouri. Doing that, I also am in collaborative practice with a nurse practitioner in my clinic. And she is wonderful, and she is an essential part of our healthcare team. But today I'm here on behalf of the Missouri Academy of Family Physicians to once again repeat that we do believe in physician-led healthcare. The first opponent testified much of the data and did a great job of doing that, and you're currently getting a packet with very similar statistics, footnotes, all of the links, and I won't bore you with that. But I do want to talk about how collaborative practice works in my mind, in my clinic, and how it actually increases access to care, specific to a patient last week. My nurse practitioner, she worked as an ICU nurse for multiple years, went to nurse practitioner school, and has come out and has worked in our clinic for 5 years. She sees patients when I'm not available, and she has her own patient panel. One of her own patients came in and said, I have some postmenopausal bleeding, and for many of the healthcare workers in the audience, postmenopausal bleeding is cancer until proven otherwise. And how do we prove that? We do an endometrial biopsy. So I'm on my part of the clinic, she's on her part of the clinic, and comes and says, I'm not sure, do I need an ultrasound, do I need a biopsy, what do I need to do? If I need to do it, I can't do it. I actually stop my clinic, I go over and do the biopsy for the patient. So the patient has less visits, the time from symptom to tissue diagnosis is decreased, she has less copays because less clinic visits, and is hopefully on her way to gyne-oncology wherever that may be. And so that's what collaborative practice looks like in my life. I also want to speak to, increasing access to healthcare. So I'm there training physicians, and there are those of us out there that want to take care of patients in rural Missouri. We're passionate about it. We speak farm, we speak cattle, but we also speak healthcare, and we speak medicine, and we're trained in evidence-based medicine. We want the best for our patients, and we believe that as the rural training track produces more physicians, we'll be able to increase more collaborative physicians. But my husband and I are in two separate clinics. We started our practices there right as COVID was going, and we were overworked, and we needed more help. And we looked to have collaborative mid-levels, whereas it be a NP or a PA. And we actually put out job openings in January of 2022, and we did not hire anyone until September of this year, of 2022, and actually could not start practice with her until December of this last year. We had 10 applicants over 9 months. We interviewed 3 of those, and it wasn't because the applicants weren't kind that we didn't choose them. It wasn't because they didn't have degrees, because they did have master's levels degrees in advanced practice nursing. It's because the skills and the experiences they had in school did not prepare them for medicine in rural America. When we asked things like, tell me about the procedures you've done, we leave it a little bit open, and one of the applicants was very excited. She was like, I'm really good at injections. And so we're like, yeah, tell us about the injections you do. Like, we do inpatient and outpatient medicine as family physicians there. We do shoulders, knees, hips, fingers, trigger fingers, lots of things, because getting to orthopedics is difficult. And she is very sincere in saying, I can give flu shots, and I can give MMR vaccines, and I can give Hep B vaccines, when really her version of injections was just immunizations. And when we ask her specifically, what is your training on knee injections, or what is your training on shoulder injections, she'd never had that done or been taught. And so the collaboration agreement allows them to work under physicians to learn those skills that they don't get in school. In our rural practice, we serve as a, catch-all in ER and, lots of farm injuries. Farmers, my dad included, are one of the tough types, They will have, smash their fingers in a post-hole driver and it's hanging on by some tissue and they won't go in. And so we always ask, what are you comfortable doing as far as suturing? Like, can you stop the bleed? And they're like, that hasn't been our experience in the people that we interviewed. They weren't familiar with stopping the bleed or, suturing on someone who was awake and actively bleeding. And that is essential to our everyday practice in rural Missouri. So I'm getting the time, and I will, I could go on as most people can, as we're all very passionate about this, but I'll open it up to questions.
Representative Fogel.
Thank you to inquire.
Go ahead.
I'm going to ask you some of the same questions. I don't know if you heard me ask of your colleague earlier, but a lot of the testimony I think we're hearing today is more specific to individual practices' preferences, not necessarily related to the state statute. So going back to what the language currently reads, a APRN has to submit 10% of their charts to be reviewed every 2 weeks. So my question, again, is kind of surrounding that, in that if we have these grave concerns that APRNs aren't doing what a physician would want them to do, I have yet to hear testimony from anybody that we should be increasing the number of charts that need to be reviewed or decreasing the amount of time that a physician has to review those charts. And it would seem like in the medical field that if you're not touching that chart for 2 weeks, the damage that you were going to do, you would have already would have already done. So I guess I would like to hear your thoughts surrounding that. And if we really do have these concerns, it would seem that there'd be an effort to strengthen the language. And I have yet to have anyone approach me about that, but I've had a lot of people approach me about the opposite. So I'd like to hear your thoughts on that.
Sure. I think in my specific case, and I can speak for my husband's, as sometimes wives like to do that. But in my collaborative practice, when I started, I reviewed every one of her notes for the first 3 months and really built that trust relationship. She had been there before I did, and I was the newcomer. However, pointing out things like evidence medicine, we don't need a pap smear every year anymore. Pointing out that, colon cancer screenings have changed. Everyone doesn't need a thyroid screen every year. Those things we talked about as those were coming. So it didn't seem as lumpy at the end of 2 weeks, where it's like, here's all of these things I saw that were wrong. It's generally creating a relationship and changing practice styles over time. In the question of the damage is already done, the way my collaborative practice works is ideal. I get calls when I'm on nursing home rounds, when I'm doing a delivery. Hey, I've got someone here with this. I'm concerned for this. What should I do now? And so the goal is not to chart search and point out bad things. It's to actually work in collaboration where there's time to make change and get to an accurate diagnosis in the most cost-effective and evidence-based way possible.
Great. Thank you for sharing that. It seems like, of course, in all professions, you have people who do things differently within their own practice. And I'm trying to decipher if the testimony that we're hearing today on behalf of the doctors, if that's common practice across the board, because I hear a lot from APRNs that their collaborating provider does not provide that support, and they're 75 miles away, and it's not a hallway consult because that person isn't physically located in their building. And really, that's just serving as something that's being done, on day 13 or day 14, and not truly providing the support that it seems like you and your colleague are doing a great job of providing. So thank you for answering my questions.
Welcome.
Further questions? Representative Seitz.
Yes, to inquire.
Go ahead.
I'm looking at one of the handouts that was passed out. It's entitled Patient Risk and Malpractice Concerns with Non-Physicians. And I'm going over some of the points. In point number 9, it states, many malpractice cases in primary care or family medicine were related to a nurse practitioner's failure to order a medical test or to obtain and address test results. And yet I heard earlier testimony from your predecessor that, and even some comments here, that too many tests were being given. This says too few tests were being given. Some of these negatives, and when I present a bill, if I'm favorable to it, if it's one of my bills, I'll type up a page and find all the positive quotes that I can find and the positive happenings. Could many of these negative instances that could be applied to APRNs also be applied to physicians? If you dug deep enough, you could find malpractice and things like that involved with physicians as well. Is that the case?
I agree. In the current way that the medical system is set up, physicians are able to hold each other accountable and answer to the Board of Healing Arts. And so under the proposed legislation, that even though they would be providing and being able to order similar tests, and I think what they're getting at this is sometimes not knowing what to do with the test results is a problem. There's kind of a decision paralysis regarding what to do with that after. How do we hold APRNs accountable if they're not under the same regulatory body that physicians are who are ordering the same test?
I understand. Could that also be applied to physicians as well? Holding them to a certain standard through misdiagnosis or something like that. I'm looking and reviewing these, and I think they could also be applied to other members in the field.
Sure. And I think that is where we do hold each other accountable as physicians. And so it seems peculiar to me that if they are wanting to order the same test and prescribe similar medicines, why would they not be held to the same standards that physicians are?
Okay, thank you.
Further questions? If not, thank you very much. And for those of you who aren't familiar, she and her husband are at Bothwell, which is a unique rural medicine practice situation. And she's very passionate about that field. So that's not a pro or con. I'm just saying, if you haven't studied that certain unit, you might want to talk to how they work it. Let's see. We are down to a con. This is getting to be long. We're down to a favor. Would you? Representative Boucher is going to keep me on track here. So,
Mr. Chairman, you asked for a con. I
is
stepped right up because that's where I fit in.
If you're
here.
coming up as a con, you are in opposition.
I'm in support.
Oh, you're in support. Sorry. All right.
I think I'm in the correct order.
Proceed. Yeah. Give me something. No.
Shannon Cooper tonight, representing United We, an organization that works very hard to remove regulatory barriers to allow women and minorities to have great job opportunities. And those of you who know me will know that I am not a physician or an APRN, but I am probably an expert at how we can use this legislative body to block out competition. And that's all this is about right now. And we've had a lot of passionate testimony talking about education, talking about a lot of things that aren't accurate. But the fact is, APRNs have the right to practice in 27 states. The world has not fallen apart. Thousands of people are not dead in the streets. And all we're asking for is to let folks that want to come out and practice healthcare in rural areas like where I'm from, places that the folks that are here tonight opposing this, they either don't care about or don't want to come practice, but they want to tell people they don't have the right to come out there. And I think it's nonsense. I think it is time that we, as a legislative body, you look at what's going on in the state of Missouri, and we have a group of qualified people that are sitting right behind me that are willing and able to come out into these areas and help your constituents out. And I think it's a shame that we have struggled with this issue for so long when there are so many people out there in need. And I heard an earlier witness talk about the opioid crisis and try to blame it on these folks who can't even write a Control 2 script. The very partners who created this problem, and they want to deflect it on folks that have never had the ability to prescribe those medications. It's ridiculous. All this is about is control. And the folks that are losing out are the people that sent you over here to represent them. And we've been here for 2.5 hours. I don't want to belabor the fact, but the world is not going to end if you let these folks come out and do what they've been trained to do. They're not asking to do brain surgery. They're asking to put their passion into helping the people that sent you over here. And with that, Mr. Chairman, I will shut up and answer any questions you might have of me.
Questions? If not, thank you for your testimony.
Well, that worked out great for me. Thank you all very much.
Let's see, that was in support, right? Representative Boucher, keep me on straight. Opposition.
Thank you, Mr. Chairman and the committee. I submitted some online writing for you. My name's Dr. Jeff Davis. I'm the current Assistant Dean for Clinical Affairs at A.T. Still University in Kirksville, Missouri. I live in Memphis, Missouri. It's in Scotland County. It's very rural. We have a little hospital there. It's a 25-bed critical access hospital. I've practiced there for 20 years. I do collaborate with nurse practitioners and physician assistants there. I don't believe this bill is only about competition. We get along great with our nurse practitioners. They provide great care for our small rural community. We actually operate 4 rural health clinics, one in Edina, which is in Knox County, one in Lancaster, which is in Schuyler County, and one over in Wauconda, Missouri, which has about 500 people that lives in it, in Clark County. And I wanted to take just a few minutes to make a couple of comments, maybe answer a couple of questions that I've heard as I've listened to some testimony that I didn't know if got clarified for the committee. First of all, the title of this bill, Regulatory Reduction Act for APRNs, and the comments that were made by the author of the bill brought to mind that we have APRNs in Missouri in collaborative practice arrangements because the government gave them the authority to do that in a collaborative practice arrangement. We didn't have it before the government regulated it. So as we've seen since that regulation, I think it started with 30 or 35 mile radius, and then it went to 50, and then it went to 75. And actually just a few years ago, for those of you that were here, I was, and we were told by nurses that 75 miles would cover every part of Missouri. And it passed so that we could have that, so that they could have that type of collaborative arrangement. However, what we have seen, just like in Oregon, Arizona, and many other states, when these laws have passed, competition hasn't driven nurse practitioners into rural areas. Competition has kept them in urban areas where they want to live and where they want to practice. So we need nurse practitioners where I practice. We also need physicians where I practice, much like the community health center that we heard from earlier. Northeast Missouri has a Northeast Missouri Health Council, a community health center that is in the same situation, needing nurse practitioners and physicians. And the best care that is provided in these areas is by physician-led teams where there is communication between the nurse practitioner and the physicians. I echo the statements of the young lady from Bothwell that was here before about how important being available to the nurse practitioner when they need you to come take a look at something that they're not certain about. And that's the best way that collaborative practice works. A couple of final comments I wanted to cover. CMS was the Centers for Medicare and Medicaid Services who gave the data that 2% of APRNs currently are in federally qualified community health centers. And that's of all practicing across the United States. She has 25 in her practice because it is in a more rural area, and that's great. One other comment that I wanted to make is that this same body approved assistant physicians a few years ago, 2014, medical school graduates with a degree who've passed 2 steps of their boards but did not get a board certificate or a residency spot, passed them to go into collaborative practice arrangement with a practicing physician and provide health care. And we have assistant physicians who are practicing in the state today. But they have more years of training, more years of clinical experience than nurse practitioners, and yet this bill would make fully licensed and board-certified physicians equal to nurse practitioners in the practice of medicine. And medical school graduates, which we graduate 175 at Kirksville every year, we have 300 that are out in clinical rotations. We have many across the state of Missouri in rural areas like Cape Girardeau and Farmington, Missouri, and here in Jefferson City. That's my role of overseeing those students in their medical school training. If they don't get into residency and they can become a physician, assistant physician in this state, have to be in a collaborative practice agreement because we think that's what's safest for them to have that supervision and oversight. And I'll conclude my comments there. If I can answer any questions, I'd be happy to.
For those of you not familiar with Missouri geography, Wyconda is the Ellington of the north, and Edina is probably equivalent to the Piedmont of the north. So if you're from the southern Missouri, these are very, very, very small, especially Wyconda, extremely small.
Right.
And you got to hunt to find it. So with that, Representative Boggs.
To inquire.
Lone Jack's a little bigger than either one of them, okay?
All right, so appreciate all the support and opposition, but I'm in, like I stated earlier, I'm in a rural area. So for those of us in a rural area, and as doctors have retired and different things, and I've watched, now I have no clinic in Mount Vernon, one of my towns, and for those that say that it's getting harder and harder to find these doctors to collaborate, what is the like if this isn't the answer, do we have another path that we can look at, or what is the answer to this? As a doctor retires, then that nurse has to reach out to someone else, and if they won't take them on, so what is the path to the answer? What's the answer to a path in this rural area that I'm talking about? One of the, I think 9%, he said, whenever you're a part of that 9%, that becomes important. So.
Right. Yeah, that's where I live. Don't live there, but I live in an area very similar to that. I think we're trying to fix an issue in the wrong way. I think the pipeline is the problem that we have. I think we need to have rural students in rural Missouri go to undergraduate school and go to medical school and become doctors and come back and practice in rural areas. And I think that's not just by recruiting rural high school students to do that. I think it's by having good opportunities for them when they finish their undergraduate medical education and their graduate medical education to go back just like I did. I was born in that hospital where I practice at and where I collaborate with nurse practitioners at. And so it worked out good. I went through the AHEC program as I was a junior high student and a high school student and got interested in health sciences. And AHEC has had its funding cut. Lots of programs like this that focus on the pipeline. I think we're trying to stick a bubble gum in a hole, and I don't think that's the best way to solve the problem with the highest quality of medicine. We want it fixed right now. I get it. We've started med clubs in our rural high schools in those communities, but it's because we're trying to inspire students to desire to go into medical education. A.T. Still University, one of the reasons why I'm there in the role that I'm in is because we are one of the top 5% of medical schools in the United States graduating primary care physicians that go into rural areas to practice medicine.
All right, I like that answer.
Questions? I have one. How as a physician do you propose, we've got a supply problem on physicians, and the supply problem is due to the residencies, due to Medicare and Medicaid paying for them. Nobody else does. We haven't increased in 30 years. So we have a constriction on supply. We went to increased Medicaid. We went to more people in Medicare. Baby boomers like myself are all getting mature. We use that term selectively. We're getting mature, and we have higher needs when we've constricted the supply of residencies. We've increased the number of medical graduates, but not residencies. How are we going to get the adequate supply? Because this is a problem. The physicians have a problem with supply because of residency. Nurse practitioners are filling that void because you don't have supply. What are you going to do?
Yeah, and just to back up one step from that, but I'll answer the question, is I think the competition that's here is in corporate healthcare, pushing nurse practitioners to provide primary care in the United States as an equivalent. And because it's cheaper for them when they're paying salaries. I think we're finding out from states like Mississippi and Tennessee and Texas, who looked in their accountable care organizations, and the cost of care to the actual patients was going up. So I think that's where the competition is, and I think that we need to solve this problem with rural residencies like she's doing in Bothwell. I think the state legislature, if it had monies to increase residency funding in the state of Missouri, to do something novel where our state started to train more physicians in rural areas. There's proof 40% of residents that are in a residency stay within 35 miles of that residency whenever they graduate their residency. So if we're sending them to St. Louis, Kansas City, Chicago for residency, they're not coming back to Bothwell or Piedmont or any of those places. And we really do have a big problem, even at the national level, with the contraction of funding for graduate medical education programs. And the way we've solved the problem is online nurse practitioner schools that are lower cost to get into, that can crank out more nurse practitioners quicker to try to flood the market and solve this problem that we do have. I won't disagree with that. And that's why I've happily practiced in collaboration with nurse practitioners. I've never had 6 myself. The highest I've ever had, 3 nurse practitioners and a PA at one time. It is time consuming, but it's the only way we can see as many patients in rural Northeast Missouri that we see.
Okay. I'm on a box, okay? We all need to increase the number of residencies, or we will be short. We will be in
I agree.
A desperate situation of we will have medicine being metered out, and we're not going to like it if we don't
rationed.
do that. And the physician somewhere, we've got to put that pressure on, or it's going to be catastrophic.
Yeah, and just one final comment. We at Kirksville, we have about 5,500 to 6,000 medical school applicants per year. We interview about 550 to 600 medical students to fill a class of 175. There are a lot of people that want to go to medical school and become doctors. That's why medical schools in the country are exploding. There were about 10 osteopathic medical schools in the United States. When I was in school, there are 38 universities now on 62 campuses across the country for osteopathic medical education. And allopathic medical education has also grown. It hasn't grown quite that fast, but there's 25% more medical schools than there was 5 years ago.
With the same number of residencies.
Exactly. And that's the problem.
That's the point, with the same number of residencies. So
I agree.
That is a critical need we need. So, Dr. Thomas.
To inquire, please.
Sorry. You go ahead.
Thank you. Thank you for your testimony, and I want to thank you also, so this is also a comment and a question. Thank you for bringing up assistant physicians, because with that choke point, we are graduating medical students, but there aren't enough residencies, so we're contributing to that glut of assistant physicians. And interestingly, as you said, they are better trained because they are actually medical school graduates. They've been through all of that. And under the category of assistant physician, they're mandated to go to rural areas. So they do go, they do address the rural healthcare crisis. So we need to figure out a way to utilize those, and yet bills I'm sure you're aware, and I'm going to ask you if you have any other thoughts about this. Bills in recent sessions have tried to limit and actually get them out of practice after a few years, essentially throwing them away and saying, oh, by the way, then you can go and pay to become a PA, go to PA school, when they've graduated from medical school. So do you have any thoughts on utilizing assistant physicians?
I do. I know they are being utilized, and I was around when the bill was originally discussed, and it took a year or two to pass, and it passed. The position of the American Medical Association, the position of the American Osteopathic Association, the position of all of the associations that support medical education in the United States believe that the best physicians for our country are board certified and residency trained. I was at the Board of Healing Arts 4 years ago when the board here in Missouri of Healing Arts planned to restrict licenses for physicians to require board certification. Right now, they don't require board certification. What they do require is that you've graduated from medical school, that you've completed 1 year of an internship in a residency, and that you've passed the third step of your board licensing examination. And if you've done that, you can then practice. A gap is being filled across the state in emergency departments by first and second, third year residents who have met these requirements to moonlight in emergency departments like Samaritan Hospital in Macon, or Troy, Missouri, or Chillicothe, Missouri, or all over the state in small rural hospitals that have emergency departments. I do believe that assistant physicians can be helpful in rural areas. I am concerned also about allowing them after 2 or 3 or 4 years of apprenticeship to then be fully licensed, just like I'm concerned about this bill giving equal licensing, rights and authorities to nurse practitioners. But I do think that if we had rural residencies in our state, that we were home brewing, that maybe we were even finding private funds to fund residencies, we could train those assistant physicians during those years in a organized training system where then they could stay in Missouri and practice for the next 10 years if we help you do this. I mean, there's possibly some ways.
May I clarify a comment I made?
Yeah, quickly, yes.
Okay. Yes, I did not in any way intend to talk about an alternate pathway to licensure, because as it stands right now, assistant physicians need to work in a collaborative practice arrangement, and I fully support that. And again, if they are not able, for a variety of reasons, to secure a residency, to continue in that collaborative practice arrangement, the bills were to actually limit the number of years somewhat, and to very short, to the time that a person could stay in that collaborative practice arrangement and then could no longer practice, which again is throwing away trained physicians. So like I said, I'm for collaborative practice, and again, with the rural mandate, this would make a difference, and I just wanted to clarify in case I hadn't made that clear before, so thank you.
Okay, other questions?
If I could just make one more comment, Chairman?
Quickly.
Okay. My nurse practitioners, over 20 years, I've probably been with 9, 10 different ones. Right now, there's 3 nurse practitioners and a PA. I've asked them routinely through the years if they desire independent practice and to not have collaborative practice with me. And we've had one through that whole time that told me she would, and she's now practicing in Alaska on the Kenai Peninsula at an Indian health service, and she is practicing independently. And I congratulate her. I'm friends with her. I communicate with her. But all of the rest of them have said no because they are comfortable with the relationship that we have, that they can come to me, that they can come to one of my other partners that are in a collaborative practice arrangement. And this bill would remove the opportunity for a nurse who wants to continue in a collaborative practice agreement, and they all would be independent because it's struck out. Now, could they come and ask me a question? They can, and if I have a great relationship, then we work in the same practice, I'm very likely to step in like the previous speaker did and run down and go do the endometrial biopsy, but I would no longer have to. I wouldn't have to review charts. I wouldn't have to collaborate. I could tell them they can schedule an appointment on my schedule and I can address the issue. That's another concern I have, that I'd like to see that we could continue to let nurses choose that if ever the state decides to allow independent practice.
Okay. Representative Bragg?
Point of clarification. Just want to make sure, did you, and I haven't read it, and clarify real quick if I've read it or something wrong, but this will make it so that APRNs can't work for you anymore? Is that what I just heard you say?
They won't work in a collaborative practice with me. I would not have a collaborative practice agreement.
I didn't read that.
Okay. Because in every place where it says an attending physician or a nurse practitioner in a collaborative practice agreement, those are all struck out.
Okay, I'm going to have to reread that.
Yeah. And it would also possibly be, and I would have a question, is the collaborative practice agreement and the Board of Nursing going to continue to offer that pathway separate? You get to choose. Do you get to choose to be independent or in a collaborative practice agreement? And that would answer my question as well.
So if that was fixed, So they could have that choice?
I think it would be better than throwing the rest of them under the bus, just for the sake of the ones that do want it.
So if I reread it and it's not there, it's...
I wouldn't be in support of it because I don't think it's the best way to practice medicine. But rather than doing it this way, if there was going to be that opportunity for the nurses, because I think we're going to have a lot that, just like we've talked about, that feel uncomfortable when they come out and desire to have that collaborative practice arrangement with their physician.
Okay, thank you.
Okay. Representative Lewis.
To inquire
Go ahead.
briefly. Good evening. I just want to provide a little bit of clarification. And first of all, thank you for coming here. What the bill does, it no longer makes a law that mandates that you have to have collaborative practice. The way you practice today with your 3 nurse practitioners and your physician assistant, you can continue that practice. It's your freedom and your choice and what's best with your practice and your patient population. And I think that's what we need to kind of refocus in on, is that I know a lot of people, including myself, enjoy freedom and liberties and to do what's best for our areas. And the chair and I have served on a healthcare study group, and we have a healthcare crisis on our hand. It was mentioned earlier that we are 43. We've got a lot of opportunity. We've been working with the APRN practice since around 1993. And I think back of my mom's a nurse by background. And when she first started, her job was to follow around the physician. And that's what she did. And there was some reference of, I'm a nurse by background too, and I worked ICU critical care, and nobody was watching over my shoulder and what I did. If I saw something suspicious or someone circling the drain or whatever, I would raise the alarms, and I practice within my scope and training and education. So we have enough sick people here in this state. We have an aging population, as the chair said. So I think there's plenty of healthcare issues, and I sometimes get frustrated because in my bedside nursing days, we were a healthcare team, and then you come to this building and it's this turf war that I never experienced in the real world. So anyway, thank you for that. Just wanted to clarify that you could continue what works for you. You like to work with 3. You can work with up to 6 under the current law, but you choose 3, and that's your freedom, your choice on what works best for you. Thank you.
Yeah, thank you for your nursing, and there are great nurses everywhere, and great nurses are being trained every day. It also they're not trained to practice medicine. They're trained to do great nursing.
Further questions? If not, we're going to move to a pro. Thank you.
Mr. Chairman, members of the committee, I'll be very brief. Nikki Strong with the Missouri Healthcare Association here to testify in support of this bill. I don't want to belabor any of the points that have already been, I think that good points have already been brought up. We just want to ensure that we're able to have access to providers in our areas, especially the rural areas. I think the healthcare workforce shortage has hit our nursing homes harder than any other industry in the country, and it's not rebounding. I'm receiving emails continually from our members saying we've lost our medical director. What do we do? From liability issues to other issues. So we have done, I think, pilot projects of nurse practitioners in a lot of our facilities. It helps us be able to treat patients having that level of knowledge in our facility keeps them out of the hospitals, and I think it will really help with access in the rural areas. That I would answer any questions.
Questions? Seeing none, thank you for your testimony. Appreciate you coming. All right, Con.
Mr. Chairman and committee members, I'll also be brief. My name is Tim Swearengin. I'm an anesthesiologist. I practice in Springfield, Missouri. Full disclosure, much of this bill does not directly affect me, except for specific sections which remove regulations with regard to controlled substances and nurse anesthetists from the Board of Healing Arts to the Board of Nursing. I assume we'll unpack that more in the next hearing, but I did want to go on record of saying we are opposed to that. I would like to address, one of the previous speakers mentioned that APRNs have to specialize before they complete their training. And I don't really understand that, because in my institution, I see on a regular basis an APRN working with a group of surgeons, and 6 months later, they're in the cardiology clinic, and 6 months later, they're in the ER or running a Walmart clinic. I cannot do that. I cannot tomorrow decide that I'm a cardiologist, but they can. And they can do that because of collaborative practice agreements and arrangements. There's a physician there overseeing them and making sure that they know what they need to know and that they get educated, a little OJT. There's no guardrails in this law that I can see. So we're talking a lot about, and I understand, rural areas, healthcare deserts, that sort of thing, but there's no guardrails to prevent APRNs from working in any specialty. And, you know, Dr. Hruza made the point, and I'll reiterate, I have yet to see the Board of Nursing see anything that isn't within the scope of APRN practice. And again, they just move freely through the healthcare system, and that's okay because of collaboration. And I'll end, unfortunately, on a sad note. I have here emails to senators and representatives from one of my colleagues in favor of this bill. I have confirmatory emails from .gov to my colleague thanking him for his support of this bill. And I have a letter from him that says, I do not support this bill. I was hacked. This is fraud. This is identity theft. And this is not right. So I hope that as you're perusing all of the emails that you received with regard to this, that you'll vet those appropriately and have discretion, because I since have heard of other examples of this, but it's hearsay. I've heard. This I know firsthand.
I'd like you to give that to our staff here so we can investigate. We got it. Okay. Okay.
And with that, I'll close and answer any questions.
Questions? Any further questions? If not, thank you for your time. We appreciate your testimony. In support. Just for my information, how many more we got in support? 1, 2, how many, 3, how many more opposed? And overflow still? All right. Okay, go ahead.
Thank you, Chairperson Hayden and the committee for hearing. My name is Jim Wallis. I am the Missouri Director of Business Development for Chestnut Health Systems. They're a fully integrated healthcare company and not-for-profit. First, I just want to say that this whole committee are rock stars to 27 social work students at the University of Missouri St. Louis, because they don't have class tonight because I'm here. The downside is they will watch this entire recorded hearing and write a reflection paper on what they viewed tonight. So I just want to say that, and there's a lot of expertise in this room. I give a different lens. I would say 4 years ago I really didn't understand the issue with APRNs in Missouri and some of the restrictions. So I think I can give a concise real-life example, and I'll do that here now. In September of 2019, Chestnut was invited, applied, and was awarded a 3-year grant by the Jefferson Foundation in Jefferson County, Missouri, to address significant waiting lists, sometimes weeks, sometimes months, to access treatment in Jefferson County. We named our program Project Access, focusing on access of substance use treatment, youth-based mental health counseling, and medication prescribing, facilitated by our Chestnut APRNs. My role in this is to sustain and grow our programming, and when the 3-year foundation grant goes away, we don't go away. So we're there to continue to serve. One of my first roles and first challenges was finding a collaborating physician. I didn't realize it was going to be a problem, and it was a problem. And I failed miserably for 6 months trying to find a collaborating physician that could oversee and supervise our Missouri licensed APRNs. I had zero success. And then an amazing thing happened in March of 2020, a global pandemic. A global pandemic happened and rules were loosened and regulations, and we were able to, our APRNs, we have programming in Illinois, so our APRNs were able to serve, our Missouri APRNs were able to serve our clients, and our med restrictive rules, in 2021 alone, our med prescribing team served over 400 children in our 5 Jefferson County school districts where we have embedded mental health clinicians. There were no issues with this adapted pandemic model of service delivery. I'm completely confident that lives were saved because the APRNs were able to practice their earned skills in a more independent fashion. In fall of 2021, the writing was on the wall, the pandemic waivers would end. I once again started the arduous process and quest of finding a collaborating physician for our Missouri APRNs. It took 6 months, and 4 months after 2022 started, and our use during 2022, once the pandemic waivers ended, the youth and family in Jefferson County had to drive to Illinois and be seen by one of our Illinois APRNs supervised by the collaborating physician agreement in Illinois. That was the only way our folks were able to see patients in Jefferson County in 2022. So this restrictive, archaic model currently in place in Missouri overseeing APRN functions is not designed to save lives. There's a better way. Working examples are to the east, west, south, north of us. I just ask that you please support the passage of House Bill 271 in its full form. And I'm confident you doing so, lives of Missourians will be saved. So thank you.
Questions? Representative Seitz.
Yes, to inquire, and I'll be brief. I see House Bill 271 as an issue of freedom and liberty as far as health care goes. Is there anything, according to your reading of this bill, is there anything in this bill that forces someone seeking health care to visit an APRN?
No.
So they would still have the option to see the primary care physician?
Yes.
Okay, then I restate that I see this as a bill that promotes health care, freedom, and liberty for individuals to make their own decisions about their health care needs. Thank you.
Questions? Seeing none, thank you for your testimony. I appreciate it.
Thank you.
All right, so we need a opposition. Everybody, please sign. Make sure you sign the testimony sheets. And
thank you, Mr. Chairman, members of the committee. David Jackson, testifying in opposition as a registered lobbyist on behalf of the Missouri Dermatological Society. I think to kind of wrap up some of this in a long evening of discussion, I think what this bill boils down to is, really whether or not you want physicians involved in that team-based healthcare setting, whether or not you want a nurse and a doctor working together, collaboratively, or separate. If the answer is together, I think there's a lot of work that can be done there. And we've talked to the sponsor and the stakeholders, and I think there are certainly improvements that can be made and adjusted to make sure that they're reflected to today's economy and practice and technologies to make sure that care is delivered in the most appropriate fashion in all areas of the state while maintaining quality. Where our concern lies with this bill is that it completely breaks apart that team-based model and tears apart that collaboration. And I think as Representative Stinnett may have mentioned, you kind of go two extremes, right? As either collaboration or no collaboration. And I think there's a lot of ways we can revamp how physicians and nurses are collaborating together to affect patient care. And I think it really goes down to that patient. It's not about the doctor or the nurse. It's about whether or not patients want a physician involved in their care and their diagnosis. And it's hard to paint with one, brush. And this is a big bill, a lot of different specialties. We're not just talking about primary care or, mental health. I mean, this impacts all specialties of all kind. I want to address a question I think Representative Fogel's asked a couple times regarding chart reviews. So last year, I talked to a lot of our physicians from different specialties and asked about chart reviews. because it's something that we hadn't had a lot of discussion about, and I really want to get their take on, if it's effective. And I kind of got a mixed bag. So there were some who said, similar to Dr. Hruza, they review 100%, and they find it very helpful. Others that said, I review 20% or, the amount required. And I think I had this conversation with Representative Lewis, and they indicated, sometimes it is retroactive. If you're working within a hospital system, and sometimes you're throwing that chart review into a black box, and maybe it's not reviewed. So one of the alternative ideas that we talked about, last year was allowing physicians and nurses to come up with their own quality control plan. And so maybe some doctors will do, work on reviewing adverse events. So there's other ways to look at that. And so I think there are a lot of different ideas. But I think my time is up, and I can answer some of those with you here in the building.
And you have written testimony you're going to submit. Is that correct?
I don't, but I'm here every day and can follow up with you individually.
Okay. All right. Let's see. Representative Boggs.
So, as was stated earlier, as far as getting more doctors back on that subject, do you believe that the doctors would get on board with, and I know it's something that we don't have a lot of control over, but if residency is the problem, would we have just full support on both sides if that was to happen? Or are we right back where we were as far as creating another competition for these doctors? Because I know we're all afraid of, in every business we don't want a bunch of competition, but competition is really good. So I just want to verify that it's not a competition thing.
Yeah, look, I think you just heard from Dr. Swearengin, who's an anesthesiologist who, in large part, this bill isn't as, directed, in his practice, but is here because he cares about patients as well. And I think you have a lot of physicians that, I think doctors and nurses both go into it for the right reasons, to treat patients, I think why everyone's here. Similar when we talk about education discussions, it's about the kids, and this is about patients. And so I think that's why doctors go into this. And I think to Representative Lewis's point earlier, there's a room full of doctors over in that room that also are blown away by what sometimes gets characterized as a turf war, because they're used to working together and saving lives with nurses every day, and they don't like this more than anybody else.
Sure, yeah, and I get that, but as you look into solutions, whenever your hands are tied because of big brother or whatever, when that happens and you can't open that door, or you can't open that gate or whatever, then I look at this as the avenue that we have in this house, and so I guess what I'm saying is, whenever you look at the options, if there's not a lot of options, then how do we fix these issues in the rural areas if we can't have more, if they're not available? And I don't know enough about how the residency part even works, but I understand that if there's only so many let out the gate, then it keeps down the competition. So, but in our area, we need some competition. We need somebody just to keep the doors open that are there. We need to maintain what we have without the growth part. So that's what I want to do. I want to make the right decision, which I realize we're not making the decision tonight, but I want to make the right decision to help all Missourians, but more specifically getting to my area is how, that whenever, because once it's gone, once Mount Vernon has no, it's empty hole. It's a big hole. And so I want to make sure that we make the right decision to, in this bill, put the right language in this bill that both sides could support it.
Right. And I think an important thing to look at, that, Representative, is whether or not this bill actually does move the needle in increasing access to care in rural areas. And that, and how many, nurses may have called your office to say, if this bill passes, they're going to open up shop in Mount Vernon. I think, as you and I discussed, or, how many of you, in St. Louis have had people call you and say, if this bill passes, I'm going to move home to Poplar Bluff and practice.
Yeah.
We haven't seen
valid
it
point.
in the last decade of changes.
Yeah.
So.
And so that's a valid point as well. So I know it doesn't sound like we're getting anywhere, but discussion is great, and it's been a great discussion, and it's great to see so many people get in the discussion. So thank you, Mr. Chairman.
Okay. Representative Thomas.
To inquire, please.
Go ahead.
Thank you. I I know you've been working on this for quite a few years, so just could you give us a little historical perspective in the time you've been working in this area? What have been the changes to collaborative practice arrangements?
Well, I don't want to keep everybody too long here, but there's a lot of people here been at it a lot longer than I have. But I think my first year down here was 2008, and in the last 15, 16 years or so, we've increased prescriptive authority to include Schedule III controlled substances. We've increased the mileage to 75 miles, and the goal behind that was to, if you draw a 75-mile radius around anywhere in the state, you should hit a metro area with a sufficient number of physicians to choose from to collaborate with. We've created 30-day windows for if a physician in a rural area is out for vacation or something like that the clinic doesn't have to shut down. We've increased the number of physicians or number of APRNs and PAs that a physician can collaborate with. I'm sure there's some others I may not be thinking of, but there's been quite a few changes, and I think we don't always look backwards, because in 2008 when we talked about adding controlled substance prescriptive authority for Schedule III, the same arguments were being made in the same room, or maybe a room over there, if this is going to increase access to care in rural areas. And, I don't know that we're looking backwards to that data to see if it's worked. And, in this bill, just 2 lines of a 55-page bill, if you really break this thing down and unroll it, Schedule II is some serious stuff. I mean, this bill is authorizing, adding 7,000 prescription pads for fentanyl, morphine, OxyContin. I mean, some serious stuff. And so, again, that's just 2 lines of a 55-page bill.
Yes. Representative Clark.
To inquire, Mr. Chair.
Go ahead.
Thank you so much. So can you run through a typical day of an APRN?
So, Representative, to full disclosure, I'm a lobbyist of representing doctors, and so I don't want to speak out of turn there. So I would defer to maybe an APRN on that.
Okay.
Sorry.
Well, I will wait and table that question. I would like to know what is the job description, the specifics of what they actually do, and how many times they would confer or go to a doctor for what they're doing. How many times do they? If a patient is in pain, right, and a nurse say, okay, doctor, we need to prescribe X, Y, Z in 500 milligram. And the doctor typically says, okay, go ahead. And so if they are already knowing or have that knowledge to do that, why not take the free range, or why not take the restrictions off of them where there isn't a delay in access to care?
Yeah, so I think you touched on an important point. This kind of goes to the chart reviews that I was mentioning earlier, with Representative Fogel. One thing I do hear from physicians and the value of chart reviews is that even though it's after the fact, they see patterns. And so you may notice certain patterns of prescribing, and you'd be able to coach and work with that nurse practitioner. So whenever they see similar cases coming in, that maybe, they know not to do a certain test, or, maybe to run, a separate test, and you kind of coach around those patterns and work and try to correct there. But I think you bring up an interesting point in that, and I think Representative Seitz mentioned earlier in highlighting part of the bill about, nurses' skill and training under the proposed legislation. On the bottom of page 26 and top of page 27, the current law today says that in a collaborative arrangement, a nurse practitioner has the authority to administer or dispense drugs and provide treatment as long as the delivery of healthcare services is within the scope of practice of the registered professional nurse and consistent with that nurse's skill, training, and competence. So under current law, they have the ability to practice pursuant and consistent with their skill, training, and competence. The difference is that the physician's involved in that care, and in that that physician and that nurse are making that decision locally, what's best for them and their practice and their patients, rather than a state board in Jeff City deciding what's most appropriate. I think that's kind of the difference.
And that's basically built on trust, right? So that's that collaborative agreement that they form within their practice, and they develop a trust to where if the APRNs are seeing physically the condition of a patient and the doctor is not present, they are trusting the APRNs to be the second eyes basically for them, but they're not diagnosing, they're basically treating the patient.
No, actually, I mean, even in current situation today, I mean, a doctor can delegate the ability for a nurse to diagnose and treat. And, this bill, would just remove the doctor from that requirement. And so, under this bill, if you have a patient, let's say dermatology, and a patient gets diagnosed with skin cancer, the question is, do you want a doctor to, oversee that or be involved in that care? And so, this gives no limit, to what a nurse practitioner could do. It's up to the Board of Nursing, which is, composed of nurses, and have no physician involvement. And I think it's important to note that Missouri is a state that doesn't define the practice of medicine. A lot of states that, have independent practice for APRNs also define the practice of medicine to say XYZ procedures are medicine, these procedures are nursing. We don't do that. And so that's why this is so controversial, because when you leave it open to interpretation, it's completely up to a state board in Jefferson City what's allowed and what's not, rather than that local practice and that local physician working with that nurse to see what fits best within their skill, competence, and training.
Sure, but traditionally, if they don't know what to do, they collaborate, correct?
Correct.
Okay, thank you.
Representative Sides.
Yes, to briefly inquire. I think that Representative Lewis and Representative Gregg noted that the bill does not eliminate collaborative practice, but it simply becomes a personal decision as to whether or not the APRN wants to continue in that practice or go out and operate more independently. Those that are comfortable with the positions that they are in would still be in that collaborative practice. So again, as I stated before, this becomes an issue of liberty for those individuals. Can they practice without the all-seeing eye of the physician hovering over them? And I think on page 26, lines 5, 6, and 7, or 5 and 6 talks about that. In fact, that whole paragraph, a physician may enter into a collaborative practice arrangements with registered professional nurses, and that is not going to change. So that option still exists within the bill.
So, Representative, the way, and perhaps I'm incorrect in this interpretation, the way I interpret that is that it on line 5 there, it allows a physician to enter into a collaborative practice arrangement with a registered professional nurse who is not an advanced practice registered nurse. And so, as I understand that, you're allowing physicians to enter into a collaborative practice with an RN and not an APRN, because you're elevating the APRN to practice and have the same scope of practice in autonomy as a physician. And so you're basically moving up an RN to what an APRN is today. And again, perhaps I'm wrong in that interpretation. I defer to the sponsor, somebody to clarify that, but that's, and I think you also have to look at, people are always going to need care, and people are always going to want physicians involved in their care to an extent, right? And there are going to be people willing to pay for that. The question is, if, this bill passes, how many physicians start going into concierge care, and it becomes if you can afford a doctor, you get a doctor, and if not, you don't. And that's where you also have to look at how this system is structured in team-based care.
Right. I see what you're talking about as far as an interpretation of what we just talked about, but I go back to a previous point that these APRNs are not going to be practicing outside of their competency level or their experiences as APRNs. That's right there in the bill on page 40, line 45 through 47. So they would still be acting consistent with the required education, training, and certification that they have. And they're not going to be stepping outside of those roles. At least that's not in this legislation.
And I think maybe we'd agree to disagree on this. I think where my client feels that decision is already that autonomy is already allowed right now under current law in allowing them to practice to the full extent of their training. It's a matter of who's best to decide that, of what their skill set is. Is it that doctor working with them in the clinic or in the hospital day in, day out, who's done that preceptorship with them, that understands their skill sets, or is it a state board in Jefferson City and full of nurses with no physicians deciding what may be beyond their skill or training? And so I think that's where I think the disagreement is, and how that's handled.
Sure. I appreciate it. Thank you.
Other questions? Yes, Representative Gregg.
Thank you. Just to continue that question real quick then. Sure. Who's best to choose healthcare choices? The board, us, or the patient? If the patient has the option to go to a nurse practitioner or a doctor, and they've got that choice, who's best to make that decision?
Yeah, I mean, I think patients, and that's where I would, urge people to ask, your constituents too, if they want a physician involved in their patient care. And, with insurance and everything else, that's where it gets complicated. Like I said, I think you'll have more physicians migrating towards that concierge, type care. But also, I think it's important, to look at patients don't always have that choice. And, if you're looking at primary care and whether you want to go to an urgent health clinic, and I mean, look, I've made that decision with my family and my kids before where it's, do you want to wait a day to get into the doctor, or the doctor's office says, hey, we can have you come in and see an APRN today, or you can see the doctor tomorrow. And, and I think patients, have that ability to make that decision, and I think that's fair.
But I may be wrong, but Alton, Missouri probably doesn't have a walk-in clinic. So, yeah, I'm looking more at the rural, honestly. But you may not have that choice. But if do we have enough doctors? No, we don't. We don't have enough. So the issue for this bill, the reason it's here, though, isn't it because we just don't have enough?
Well, what I'm saying, though, is that you in some circumstances are going to be because this bill isn't specific to primary care, you may be, in a hospital setting, or you may be in a situation where you don't have that ability to decide your provider. If you're getting, let's say anesthesia, and you're getting rolled in, from an ambulance, like, you're not going to be quizzing and asking for resumes and deciding who's doing what or who's qualified for what. Whenever you walk in to, get a procedure done, you assume that facility or that hospital or that somebody has verified that person's qualified to do what they're doing, and so you don't have to quiz them or try to make sure that they have the credentials you think they do. If somebody walks in with scrubs and a white coat and says that they're Dr. Jackson, you're going to assume they're a physician, not necessarily a doctor of nursing practice. And so we want that transparency, and sure, we want patients to be able to make that decision. But I also would caution that we've been hearing for years that these laws will allow, and create more access to care in rural areas, and we just haven't seen it in the changes we've made in Missouri, and we haven't seen it in other states. And instead, what we've seen is, more specialty care, med spas, and things like that in urban areas, in that migration in urban areas. And so I think it's just important to look at, because it all sounds good. If we had a magic bill that did increase the number of providers in rural areas, it'd be great, right? But we're just not convinced it does that.
But are we getting healthcare in those areas with current plan?
To an extent, right? But at the same time, I think you have to balance that between quality, access and quality, and whether or not, look, as I mentioned in opening, we're not in just all-out kill mode on this, in the sense that, our big thing is making sure physicians are involved in the patient's care. How that's done in a way to help increase access to care in rural areas, we're on board to try to figure that out. Where our strong opposition is to breaking apart the collaborative practice arrangement.
Okay, thank you.
Questions? Keithling?
Choir.
Representative Keithling?
Thank you. I'm glad you say that no one's closed off to this completely, and I think it seems to be. I'm hearing a lot of people are agreeing on a lot of the problems here, and not as much agreement on the solutions. But I'm not hearing anything that seems insurmountable to overcome. And how do we address the accessibility of healthcare in our state? And to Representative Nixon Clark's point, with building the trust, you were talking about that, and I think I've heard 2-3 physicians come in, and they've told a similar story of, well, we've started out in one place with me reviewing 100% of the charts and following up on every patient, and I've gotten to a place where over years or months, whatever it is, I trust them, and I do less and less of that. I catch less mistakes, and it looks like there's a point at which there's a tipping point where we start where the physicians too start trusting that, but it takes the collaboration to get there. A lot of the time on the testimony from the other side, from the physician side, this has been devoted to the training requirement and the training problem and the gap in expertise that might cause. And the collaboration is a way I think we overcome that. And I wonder if there's a point where, because I'm hearing in the, kind of buried in the physician's testimony that at least on a personal level, at an individual practice level, there seems to be a point where they grow to a certain comfort where if they feel like they're their APRNs are getting to a point where they can exercise more and more independence, complete independence. I don't know, but there's a tipping point where that happens, and so I'm wondering if that's a place where there's some potential movement on this, and I think the other concern I have is it's like we're talking about, everyone talks about turf wars and protectionism and what's happening here. And I think there is a liberty component to this, as Representative Seitz put up, because when I'm looking at this, I'm reading, we're talking about mileage restrictions. We're talking about 6-to-1 ratios of how many contracts you can work with. And I don't think this was the intention how this was set up. I think this was set up in a patient care philosophy mindset that the priority was prioritizing patient care, but it reads like franchising agreements. And I think what we want to do is make sure we're providing care and the state isn't standing in the way of more accessible health care by creating these pseudo kind of franchise requirements. And that would be my hope. Any suggestions that you might have, that physicians might have, is how do we maintain to cover that training gap, which the collaboration seems to solve, without looking like we're setting up, which isn't the intent here, setting up franchise protectionist anything.
Yeah, I mean, I think it's important to also look at when you're looking at chart reviews or other measures and that gained trust over a number of years, that the vast majority of physicians and nurses that you are going to hear from are working in the same facility, right? It's a very small percent of nurse practitioners that are actually practicing outside of that same facility and fall under that kind of radius range there, and probably more specific to your primary care type settings. But and so whenever you're in the same clinic working with a physician, even though you're going to have more trust and more independence there, you're still down the hall to collaborate with and call in to look at something, and you're still going to have that that connection and that partnership there in treating patient care that I think is important. And so on the ratio and everything else, the other component I think it's important to remember is the vast majority of physicians going to hospital-employed settings. And so, what you don't want is a hospital system to say you're going to collaborate with 10 doctors or 10 APRNs, and doctors say I can't feasibly do that, and that's too much for me to take on. But it's your job on the line, right? And that's a protection, too, to make sure that you don't have anybody that's forced to collaborate with more than they can handle, that patient still has that trust that doctor is going to be somewhat involved in their care.
And I think, and what we're doing in the process is we're limiting the amount of APRNs who can come in and practice, even under a physician. I mean, I think you're right. I think that the intention is to not overload any single physician and not give them more where they can't review 20% of charts or whatever the number of charts is that they feel comfortable reviewing, and turning these into just someone buying up all these licensing agreements. But it seems like there is so much flexibility that needs to happen here, because there's so many different kinds of practices we're talking about and types of treatment and medical facilities we're talking about. And I'm hearing from the physicians and from, I think, the APRNs that it's very practice-driven and practice-dependent. And I think it's hard crafting a law that's going to take into account all those different setups and allow everyone to work efficiently in an accessible manner, but still providing as much quality health care as they can.
I agree.
Thank you.
Representative Lewis? Go ahead.
Good evening.
Good evening.
Thanks for being here. You're representing the dermatologists.
I am, and I do wear several other hats and representing
Yes.
other specialties, but some of our physicians have been here testifying, so
you're the derms
I am testifying
today.
for the dermatologist hat right now.
Good. So the dermatologists that you're representing, do you have like a average cost of what their incentives are that they receive for collaborating with nurse practitioners?
I do not have the information, but I'm happy to ask them and report back.
I would love that. Thank you very much.
You bet.
What's that? Oh, I'm sorry. He was. I thought my car was in the wrong place. Representative Courtway.
To inquire, please.
Go ahead.
Thank you. So I'm just curious, I stepped out for a second, so if this has already been touched, I'm sorry, but, and I'm not sure if the bill sponsor would be agreeable to this, but it seems to me that one of the biggest problems we have here is is everyone's talking about their lack of training or the lack of years or the amount of hours they have. So I'm just curious if we would put an amendment on this bill that would say the first 5 years, APRN would have to have a collaborating license with a doctor, collaborating agreement. Thank you. It's getting late. A collaborating agreement with a doctor for 5 years. They work a full-time job that's 40 hours a week, 2,000 hours roughly a year. That gets us up to 10,000 hours in 5 years. I'm just curious if that's something that would appease both sides of the aisle per se, the fors and the against.
No, I appreciate, that thought, Representative, and I know that's been discussed, before. I think we're our client in not just dermatologists, I think, other physicians that we work with feel very strongly in a collaborative practice model, in making sure we maintain that collaboration in some capacity, because even after that number of years, it's still not going to be equivalent, to medical school, but the goal is to have that team-led care in collaboration. But I think that it is important to look at and try to rewire the best way to collaborate and allow for flexibility in certain areas to increase access and while also maintaining that quality. And so I think we're open to and anything that can figure out the best ways to collaborate. But it is very important to our client that physicians and nurses remain in some type of collaborative model that physicians are involved in a patient's care.
Thank you.
Other questions? If not, we're ready for Representative Pouget. My microphone's on. Thank you. Thank you. Thank you. You're falling down your job of moving this for me, and I will replace you if it isn't improved, the work doesn't improve. So thank you. Thank you very much.
Thank you, Mr. Chair, members of the committee. My name is Mandy Hagseth. I'm the Director of Policy and Advocacy with Missouri Family Health Council. We have a little bit of a different line of sight on this issue. We are the administrators of the Title X Federal Family Planning Program, and then we also administer a privately funded state-based contraceptive equity initiative as well. So one or both of these programs is delivered through a network of approximately 80 health center sites all across the state, ranging in type. We've got community action agencies, federally qualified health centers, hospital-based clinics. Did I say community action agencies? It's been a long day. Hospital-based clinics, standalone family planning providers as well. In 2021, we served about 44-ish thousand patients, and we have about 75 to 80 APRNs that deliver family planning services throughout our network. So keeping it very brief, I just want to mention that from our line of sight, we can tell you that we have had providers in our network have to reduce their service site hours or close some of their service sites providing services altogether. The need for family planning services in the state of Missouri greatly outweighs the capacity of the current family planning network. And just as we've heard tonight, there is a healthcare crisis. There's also a reproductive health crisis in the state of Missouri. And we've got 75 to 80 APRNs in our network who are trained, ready to provide these services. And in the experience of the providers in our network, collaborating physicians are difficult to find, prohibitively expensive sometimes to keep, and also there are a lot of barriers, and we can share anecdotes with you offline if that is helpful, just about the barriers to securing some of those relationships. And at the end of the day, services are being reduced. They're greatly needed in the family planning space. We really appreciate your consideration of these bills and urge your support. Thank you so much.
Questions? If not, thank you very much for your testimony. Now we will go to any more opposition.
Good morning. Wait, no.
Go ahead. Yeah. We understand. Please go ahead. How many more support and opposition do we have for this bill? Where did you come from when we took our count before? Yeah, I tell you what, we need to stand at ease for 5 minutes right now, okay? There's not a lot of help, but we got to stand at 5 minutes. We'll be back in 5 minutes and start back up. And turn your mics off. Everybody turn your mics off. Go ahead, and we're going to get started. State your name, and you are in opposition, correct?
Correct, yes.
Okay, go ahead.
Thanks. My name is Jeff Howell. I represent the Missouri State Orthopaedic Association of Orthopedic Surgeons opposed to the bill. I'm just going to try to be quick and not very verbose. There was a couple questions and comments. Representative Thomas asked about the history of collaborative practice. So collaborative practice passed in 1993. The rules were not completed until 1996, and there was a nice period of calm as everyone settled into their roles. And then in the early 2000s, we started seeing some CRNA bills, like the one you're going to hear after this one. And about 2005 or 6, some bills came that were to allow nurses to prescribe controlled substances. That finally passed in 2008. They were given the ability to prescribe controlled substances except for Schedule IIs. In 2009, the following year, the chart review requirement was reduced to 10%, 20% for those controlled substance charts. In 2010, APRNs were allowed to prescribe physical therapy. In 2012, non-collaborating physicians listed on the agreement were allowed to sign off on charts if in the collaborative practice agreement. In 2013, APRNs in rural health clinics got a 28-day waiver to the proximity rule, the 75 mile. At that time, it was 50 miles. They got a 28-day waiver to that. And there was also a waiver granted for the use of telehealth services, and that was in 2013. In 2014, APRNs were allowed to order restraints in mental health facilities on patients with a 24-hour review from a physician. In 2015, they were granted the ability to prescribe hydrocodone off Schedule II. That remains the extent of their controlled substance prescribing authority to this day. In 2016 and 17, the nurse licensure compact passed, and they made some adjustments to that the following year in 2017. 2018, we moved proximity from 50 miles to 75 miles. I hear a lot of people ask me, why do we have this arbitrary number? It is not an arbitrary number. That number was moved to 75 miles because Representative Rowland from Theodosia had a couple people that could not get health care coverage. And I agreed with the Nurse Association to move that to 75 miles. It is not an arbitrary number. If we move it to 100 or 105, that's an arbitrary number. In 2019, the waiver for telehealth was repealed, and so a waiver is no longer needed for that. You don't have to go ask the boards for a waiver. In 2020, we reached an agreement on APRN licensure, which is kind of what Representative Cook has introduced, that eventually failed. It imploded. And then last year, APRNs were allowed to order home health services without physicians' orders to do so. So that's kind of a history of collaborative practice in a nutshell over the past 30 years? 30 years. Someone asked about solving the rural healthcare crisis. That takes money, and good things cost money. And the chair mentioned that CMS hasn't provided new residency slots for like 30 years, but the Cures Act actually approved 1,000 new residency slots to be awarded nationwide, and the first 200 of those were awarded in early January. 3 teaching hospitals in Missouri applied for those, and 2 got slots. So I think, don't quote me on this, but I think those 2 hospitals got a total of 3 slots. So out of the 200 available, Missouri got 3. So 125 of those out of the 200 are earmarked for primary care, and then I think another 25 for psychiatry. And so at some point in the next year or so, I'm sure they'll award the rest of those residency slots under the Cures Act. Utah and Virginia are the most recent states to use state funds to supply residency slots at their in-state teaching hospitals. So we can do that through the budget process. I have the language Utah passed on my desk in my office. So if anyone's interested in that legislation. I'll be happy to work with you on that, regardless of what happens to this bill, because we do need more physicians, and we can do that, and we can earmark those funds so that they're used for primary care and that those residents have to practice in rural areas. We can do that. And I will also let you know that Missouri is the #1 exporter of medical students. We send medical students to more states than any other state. And we have 7 medical schools, and our residency slots are there. So these students leave Missouri, go practice in Boston or Florida, and they never come back. And I know that because they don't pay any dues to my organization. They're free. My feeling on the bill as it sits is, and I think the chair kind of alluded to this at the very beginning when he was talking to the sponsor. This bill kind of takes two things that are inherently different, and it elevates them. And he mentioned DOs and MDs. Does it put it on the same level as NPs? And the sponsor said, yeah, that's pretty much it. Well, when you take two things like that are identical, one of them becomes unnecessary. You no longer need that one thing. And this bill allows you to declare those two things the same, but it doesn't let you say which one's unnecessary. But there are other people that are going to make that determination for you. And so, in other states where this has happened, physicians are fired. They lose their jobs and they're replaced with nurses. And I have, the news articles, and I'll share that with you if you want. But I think that if you have a small clinic in a place like, I don't know, Piedmont or Willow Springs, and that community has a physician, and it's a part of a larger health system, I think that facility will lose its physician. That community will lose its physician, and they'll be replaced by a nurse. And that's my theory, and I'm sticking to that. I'll be happy to answer any questions.
Questions? Seeing none, thank you very much for your, and I would like that information on those other states to me, okay?
See you tomorrow.
All right, thank you. There is legislation drafted on that, by the way, so I would like to see that. No, on Missouri, so go ahead.
All right, 4 now, right? There we go. Thank you, Chair. Thank you, Committee. My name is Jeremy Kathi. I'm the State Director for Americans for Prosperity. I felt the tingle of people saying freedom and liberty, and so I had to come running. I had to make sure that I got in and testified today. But no, seriously, Americans for Prosperity, one of the things that we really work on and one of the things that we support is what we call the personal option. What we try to do is we try to support healthcare policies that increase access to quality and affordable healthcare. One of the interesting parts about being in the position that I'm in right now is that on any given healthcare policy, I've got different allies and different opponents. So it's one of those things where just depending on what it is, I'm in agreement or in disagreement with different groups and organizations. And so it's not one of those things where I'm in here supporting only one side on any particular thing. What we try to do is we support the policies that are going to, help Missourians overall. So on this one, reforms like this, they have dramatically expanded access to healthcare services around the country, including rural and underserved communities. States that enact full practice authority have increased the availability for checkups, decreased hospital use, and reduced emergency room visits. Providing NPs full practice authority has also helped states reduce healthcare costs. We've all looked at the budget. We understand that it's one of the fastest growing portions of our budget right now. States that implement these reforms spend 17% less per capita on outpatient care, 11% less on prescription drugs, 15% less on pediatric preventive care than states that restrict access. As states experience increasing primary care shortages, NPs can play a crucial role in ensuring families can obtain high-quality medical care. Analysis by the HHS estimates that states could reduce their provider shortage by 2/3 simply by listing laws that prevent NPs from independently treating patients. These reforms will significantly reduce the cost of healthcare services to patients as well. In 2014, an analysis from the National Bureau of Economic Research found patients spend 15% less for pediatric checkups in states that expand practice capabilities of NPs compared to those states with more restrictive access. More recently, a 2019 study in the Journal of Nursing Regulations showed families spend 17% less on outpatient care, 11% less on prescription drugs in full practice authority states. Experts predict these low prices would generate enormous savings for the state healthcare system as well. These savings would ensure more families can afford healthcare where and when they need it. And I have a more expansive and in-depth testimony that I can email you, and hopefully you can share that with the rest of the committee that goes into it, cites all the sources for that as well. But in our position, doing this provides greater access and more affordability to more Missourians, and we think it's the right thing to do, and we would appreciate your support.
Okay. Questions? Seeing none, thank you for your controversy.
All right, thank you.
What did he do? He testified. Not controversy, he just testified. I'm sorry. It's getting long. So that was in favor of opposition. Thank you. Seeing no opposition, any more in favor? And if he was in favor, opposition?
Is there opposition?
There's no more opposition, then you can go ahead. I would ask the members, we do have another bill after this, so be aware. Let's keep our questions pretty to the subject. So go ahead.
I'll be exceedingly brief, I hope. Thank you. My name is Leann Chilton. I represent BJC Healthcare in St. Louis, and I've proudly represented them for over 23 years. I'm here to testify in support, primarily because these nurses have gotten additional credentialing. They have gone through a master's program. They have gone through a clinical program. They deserve to have a license. They deserve to be able to have their direction under the Board of Nursing, not under the Board of Healing Arts. And we do see a lot of collaboration. We've got 31,000 employees. 9,000 are nurses. So we absolutely have to collaborate. We also have rural hospitals, as well as, of course, St. Louis Children's Hospital, Barnes Jewish, rural, urban, suburban. We've got it all, right? So in order for us to make sure we can maximize the training that we want, the recruiting that we want, and the retention of people to stay in our state, we think that APRNs need this additional flexibility, and we would ask for your support.
Questions? Seeing none, thank you very much for your testimony. In support, there's no more opposition. In support? If you're in support, since we don't have opposition, be prepared to come up quickly. Go ahead.
Thank you. My name is Kathi Harness, and I'm here today on behalf of the National Council of State Boards of Nursing, and we want to go on record in support of House Bill 271 and House Bill 330. The National Council of State Boards of Nursing is a council that works with all the state boards of nursing in all 50 states. We do that to help promote good public policy, to improve access and quality care throughout the state with our nurses. And I would like to say that this is not an expansion of scope. All this is that we can practice to the full extent of our education and training.
Questions?
Thank you.
If not, next witness, please.
Good evening, Mr. Chairman, members of the committee. Derek Leffert, CEO of the Association of Missouri Nurse Practitioners. Just want to make a couple of quick points here. I know it's been a long hearing, and certainly understand you guys being tired. I guess the first thing I would say is imagine that you spent 6 to 8 years in school, and you come out and you can't actually do what you're trained and educated to do. That would be a question I would have for folks. Secondly, there was a lot of things said about APRNs acting outside their scope of education and training. There are existing mechanisms to address that through the Board of Nursing. Their licensure can be suspended, revoked, or disciplined. Physician appointment wait times. We can throw out our side's study. They can throw out their side study. But at the end of the day, how many of you guys have made a phone call to try to get an appointment with a physician and probably couldn't get one? That's a question you need to ask. And then in addition to there being a shortage of providers, more importantly, there's a shortage of collaborating physicians, right? So the health systems a lot of times won't allow their physicians to collaborate with APRNs on top of any other number of issues that are related to the collaborative physicians. So that in and of itself is an issue. That not only is the pool of providers, physicians limited, but also the collaborating physicians as well. Another important point to make here, it was said earlier, but I'll say it again. During the pandemic, the fears that things were going to fall apart, the sky was going to fall, that didn't come to fruition, right? The barriers were eliminated and nothing catastrophic happened. And then finally, I will tell you that a lot of APRNs are looking at moving to other states. We're surrounded by states that have full practice authority, and I can tell you from experience, a lot of our members, especially in the border areas, are suggesting that they're going to go practice in those other states. And with that, I'd answer any questions.
Questions? Yes, Representative Keithley.
Thank you. To inquire, just quickly, I had how much does the mileage drive? You'd brought up collaboration. There's just a shortage of physicians who are willing to or able to, and that the bottleneck is really in the collaboration, not in anything else. Does easing the mileage restriction, does eliminating the mileage restriction, anything like that have any effect on that?
I think eliminating certainly helps. I think the bill that Representative Riley has before you is certainly probably a better answer, a better solution to the problem. But I think eliminating the mileage was certainly a step in the right direction.
Thank you. Next question. Seeing none, thank you for your testimony. Okay, if you're in opposition, please. I'm sorry. This is in opposition.
Mr. Chair, members of the committee, Sarah Schlemeier here on behalf of the American College of Obstetricians and Gynecologists, as well as the emergency physicians. I think we've spoken a lot tonight about the need for addressing the primary care situation, but I represent two physician groups that are working in collaboration during very critical moments of healthcare, thinking of, moving to emergency C-section from just a typical delivery situation. Emergency room, people go to emergency rooms for a reason. It's because their health is in a very critical situation where the team practice is best placed, and this bill goes a little further than just that primary care setting. So with that, I'm happy to answer any questions.
And your opposition, correct?
Opposition, yes,
All right.
sir. Sorry for the
Questions?
late appearance.
Seeing none, thank you for your testimony. In favor?
Good evening, Kara Hoover here on behalf of SSM Healthcare. We simply want to go on record in support of House Bill 330. I don't really have anything to add from the previous 3 hours.
All right. Questions? If not, thank you for your testimony. We got to be getting short here. Go ahead.
I think I'm last, maybe. Hi, I'm Heidi Lucas. I'm the Executive Director of the Missouri Nurses Association. And I just want to leave you with one thing. In 26 other states and the District of Columbia, this bill that is presented to you tonight is what they have. Our nurse practitioners are able to practice to the full extent of their education and training without physician supervision. If it didn't work in those states, trust me, we would see over the course of the last couple of years, there had been back movement on those. States would have rescinded it if it wasn't working, if malpractice rates were high, if people were getting hurt. That is simply not happening. In the last 5 years, since 2017, 5 states and 1 U.S. territory has adopted restriction-free practice environment, including our friends in Kansas just last year. So we're seeing some major problems along the state lines as nurses are choosing to go and practice in Kansas. And trust me, that's the last thing we want to do. We don't want to lose anything to Kansas. So we want to keep our nurse practitioners here in the state of Missouri, keep them happy, keep them practicing.
Questions? Seeing none, thank you for your testimony.
Thank you.
Are we finished? No, one more. I'm sorry. You were hiding by that pillar. Go ahead.
I won't even sit down.
Okay.
Jessica Pabst on behalf of the Missouri Hospital Association and the University of Missouri Healthcare System. We are in full support of both bills. However, on behalf of MHA, we would like to see the collaborative practice remain in statute.
Thank you. Questions? Okay, no questions. Thank you very much. There is a question about full support with a question, but we'll pass that up. Next, who is next? Are we through? Information only. You have waited a long time for your information only, haven't you?
Perhaps the longest.
The longest. Go ahead.
All right. I'll try to keep it brief. So good evening, Chairman Hayden and members of the committee. Thank you for allowing me to testify for HB 271 and 330 as informational purposes. My name is Ramon Martinez. I am the Health and Mental Health Policy Fellow with the Most Policy Initiative. We're a nonprofit, nonpartisan organization here in Jeff City. Our primary goal is to provide the Missouri legislature with relevant scientific research on request, and we have provided a written short science note on scope of practice laws for APRNs, which we can provide to every member of the committee upon request. All 200 of our notes are on our website, mostpolicyinitiative.org. Now, with that, let me briefly summarize the research. First things first, when it comes to a really large area of research, such as APRNs and scope of practice, always remember that there's going to be nuance. The VA, for example, allows APRNs full practice authority, and yet the VA themselves, through their evidence-based synthesis program, say that a lot of the increases in, or a lot of the maintenance, if you will, similar quality, similar cost that a lot of the research may suggest, there's no evidence that suggests that that's due to the policy change alone. Now, with that, what I can provide is an aggregate of the data. Regarding access, APRNs can improve service to patients on Medicare. They can improve service to more rural and healthcare shortage areas. These are often at similar cost and quality to physician services, but remember those caveats. And remember the metrics. Are they based on rural areas that don't have any healthcare provisions or any healthcare providers whatsoever, or are they based on areas that are saturated with specialties? Regarding the workforce, states with these laws see APRNs work more hours. They are more often self-employed. APRNs are more likely to practice in full authority states, and yet both restrictive and full authority APRN practice states have had similar issues and shortages regarding APRNs. So that can suggest that there's other factors that affect APRN supply in the workforce. Relaxed APRN laws can also result in modest shifts in the workforce internally within the healthcare system. Think hospital nurses who may transition into the APRN role. Most studies only do comparisons between full practice states and fully restrictive practice states. So the research and the nuance in some of the states that might have one area that's restrictive or one area that's restrictive, that data is still not there yet. But with that, I'll take any questions. Clearly, there's been a lot of conversation this evening.
Questions? If any of you aren't familiar with the research they do, it's always fair, both sides, and very high quality work, and we appreciate your testimony. We would like to have you send that to the committee when you get it around.
Absolutely.
Okay. Other questions? Other testimony? Anybody else for information only? If not, that will conclude the hearing on the first two. 271 and 330. My stack of papers is so far down, I'm having trouble finding it. With that, we will start the hearing on our next bill, which is Representative Cook's 329. Representative Cook, start when ready. Representative Cook tried to get off the hook by offering pizza, and I informed him we couldn't eat it, and that was torture in itself. So,
Chairman Hayden and committee, great to see you again this evening. Thank you for hearing House Bill 329. I'm going to go into a few details. I know we've been here for a long time this evening, but this is a very, very important piece of legislation. Certified registered nurse anesthetists, are known as CRNAs, have been administering anesthesia for nearly 150 years. CRNAs spend an average of 11 and a half years between education and clinical ICU rotations before graduating with their doctorate in nursing or nursing and anesthesia practice. All CRNAs pass the national exam, making their profession 100% certified. I'm going to kind of jump ahead of my notes. I know it's been a long night. So in 2001, the Bush administration gave the power to the states to remove supervision. And you can see in front of you, I passed out a map. I love visuals, and you gotta love the pictures. So you're gonna look at these, and you're gonna see the front page, 48 states with no CRNA supervision. 7 states. We are letting Kansas and Arkansas and Oklahoma, Illinois even, and Iowa, Kentucky, Tennessee get ahead of us, and we know we love Oklahoma. So, and they're getting ahead of us, and we can't let that happen. But I just wanted to provide that with you, so you could see that for your information. On another page that I sent you as well, has CRNA and anesthesiologist representation across the state, and you can see CRNAs are represented quite frequently in rural areas. And I think that is vitally important. I represent Texas County, Phelps County, and Marys County. In Texas County, the Texas County Memorial Hospital has none anesthesiologists. We don't have any. We have 2 CRNAs. Now we have 3 anesthesiologists up at Phelps Health. I mean, we have 1 at Ozarks Healthcare and down in West Plains and Howell County. But that just goes to show you, our CRNAs, they're going out in the rural communities. They're going out there to provide health care in our rural areas. And again, I just think with the first map I provided, and then the second, obviously, you can see how valuable our CRNAs are to Missouri and to the United States. So you can see that. Going back to some more of my notes here. Again, I'm not going to go into too much of a greater detail. There's a lot of folks behind me, and I know you all want to get out of here. But this bill is going to remove the supervision, and the CRNAs, they know what they're doing. They have the education, the intelligence to do this. There's no, in these 48 states, I looked for information that shows that maybe has there been any kind of issues since those 43 states have changed the supervision laws. I couldn't find any issues there. Now, of course, you might hear that there might be some data behind that. Make sure you fact check that. Make sure they have information on that. I was provided some information. I had some anesthesiologists, and they're very intelligent as well. They came to my office, and I appreciate them coming. Every one of them that came to my office was from the city. I did not have one anesthesiologist come to my office that was from a rural area, and nothing against that. I mean, that's, they prefer to practice there. That's fine, and I appreciate that. We need them around as well, and we need our doctors. We need great doctors, but our CRNAs are here asking for a little bit, and with that, I present a little bit here. You have some maps of what's going on across the United States and here in Missouri. With that, I'll take any questions.
Questions? You've done such a job of either baffling us or answering all our questions, or we got lockjaw, one or the other. No questions? If not, we'll start out with those in support. Just before we start, I almost hate to do this. How many are we going to have in support? Raise your hand pretty high. Higher. Higher. No. You get an account?
I got around 10.
All right. How many in opposition? 4. Okay. 5. All right. Proceed, please.
All right, good evening, Chairman Hayden, committee members. Thank you for the opportunity to speak today. My name is Denise Steid. I'm a certified registered nurse anesthetist in Missouri, and I'm here today to represent the Missouri Association of Nurse Anesthetists. The heart of this bill is to update laws to benefit both metropolitan and rural constituents. So we are in support of this non-appropriated bill because it provides direct benefits to all Missourians. There are currently over 1,700 CRNAs in the state of Missouri, and we practice in all hospitals with surgical services. We are the only anesthesia provider in 41% of hospitals, and the only anesthesia provider in 78% of rural hospitals. In 43 states and in all branches of the U.S. military, CRNAs are practicing without supervision. Yet Missouri statutes can currently say that CRNAs are required to be supervised by a physician, a dentist, or a podiatrist. These operating providers want to focus on the surgery and not be burdened with the presumed liability of managing over a specialty that they themselves admit they were not trained in. This implied liability discourages partnership with the CRNAs and reduces recruitment to these rural hospitals. CRNAs and physician anesthesiologists are two different types of anesthesia providers with different backgrounds. CRNAs, we are not trying to diminish the value that anesthesiologists bring to Missouri. We both are valued members, and we both are very much needed in the state. House Bill 329 seeks to remove the word supervision and allow CRNAs to practice at the request of a physician, dentist, or podiatrist. As such, this legislation does not remove physician involvement from the operating room. Furthermore, the bill fixes a misinterpretation that Missouri CRNAs are prohibited from giving controlled substances. This would include pain and anxiety medicine to patients without having first have an order or a protocol. Interpretations of the statute are inconsistent, and CRNAs are left in jeopardy for the potential violation of a regulatory interpretation. House Bill 329 is a budget-neutral solution to help alleviate these concerns without compromising patient safety, and updates current laws to more accurately describe how CRNAs practice today. Despite what others may say, anesthesia is exactly the same no matter who is administering it. We all use the same machines, the same medications, and there's multiple publications to confirm that there is no difference in safety if there's a CRNA at the head of the bed or a physician anesthesiologist. We are two separate anesthesia providers that have overlapping scopes. This creates competition, and we encourage competition. It's healthy for healthcare reform and to keep costs low. Either way, we share the same standards of care. We use the same guidelines, the same protocols, all for the best interest of the patient. Both physician anesthesiologists and CRNAs have a longstanding history of providing patient-centered care, though let us not forget that the CRNAs are the ones providing the anesthesia. We ask that you support House Bill 329. It clarifies the statutes for practices already in place, removes the regulatory burdens for CRNAs and the healthcare facilities that are currently suffocating in rural Missouri. It allows CRNAs to practice without the risk of violating contradictory regulations. It's a step in the right direction to ensure that Missourians have adequate access to care. For these reasons, we respectfully ask for your support for House Bill 329.
Questions? I guess I have one. Under the bill, it would allow for pain management clinics operated by CRNAs. Is that correct?
That's a good clarification. So we made sure in the bill to say that anesthesia services can only be provided after the request of a physician, dentist, or podiatrist.
So you cannot operate an independent pain management system under this bill under your interpretation?
No, sir.
Okay, thank you. Representative Keithley?
Thank you. To inquire.
Go ahead.
I think to me the major or the significant change to the statute in this is removing the supervision of an anesthesiologist or a physician, a dentist, or a podiatrist, and that's what I guess is the freeing part that allows CRNAs. I don't know if that's what you mean when you say this is a clarification of practices that are what's already in practice. But I mean, to me, I read that and I read it as pretty broad because it doesn't require an anesthesiologist. I mean, it requires a physician, a dentist, or a podiatrist. And I'm wondering, I'm assuming that CRNAs are practicing in a surgical setting predominantly, and I'm wondering what kind of procedure treatment is going to be administered where there would not be a physician, dentist, podiatrist, or anesthesiologist already on call. What is the situation that this statute allows a CRNA to operate without a physician in the room?
Absolutely. So the state map that was passed out with the green counties, those are currently counties that only have CRNAs. Those counties do not have physician anesthesiologists. So in those counties, the supervising provider is the surgeon, the dentist, or podiatrist. We call these the operating practitioner. These operating practitioners do not wish to supervise the anesthesia. They were not trained in the anesthesia. We have some testifying here today to provide witness to that. Supporting states, as Representative Cook presented, that all of the surrounding states around Missouri do not have a supervision requirement for CRNAs. So we were trained as independent practitioners. And the misinterpretation is both for what the word supervision means, which implies that the surgeon, dentist, or podiatrist is overseeing what the CRNA is doing, and that is not accurate. In addition, that in our current state statutes, there was a little miscommunication with the Bureau who regulates narcotics to say that CRNAs could not administer controlled substances. Now, this is important because the definition of anesthesia itself is to abolish pain that is accompanied with surgical or procedure stimulus. So for a CRNA that we are having patients go to sleep for procedures and surgeries and treating their pain, you can't take away controlled substances and allow us to do our job. Missouri is the only state where CRNAs have this extra step to jump through to get controlled substances for our patients. And then lastly, to clarify, the medication for controlled substances, again, that's only during anesthesia services provided for a surgery procedure at the request of a physician, dentist, or podiatrist.
As it relates to the beginning part of that with the physician, so I mean, I'm hearing that the rationale for this is, well, physicians, dentists, podiatrists, if they're the ones performing the surgery or the procedure, well, they don't want to do the supervisional. Mm-hmm. But it's not changing the on-the-ground fact that there is always going to be a physician in the room overseeing what they're doing in the building, certainly when whatever's happening, because by definition of patients in surgery, there's someone performing the surgery, and that's not a CRNA presumably doing that.
Exactly.
And in which case, so just to finish is I see this as less actually changing any practice, true, which I think has been admitted, has been stated in your testimony, but I do see it as a significant sharking of liability. Is the main concern less about CRNAs in this and more about doctors and physicians who just don't want to be responsible for CRNA activities that maybe they admittedly don't know much about. But
yes, yeah, and I have a colleague here today that's going to talk specifically about the presumed liability and the liability that is put upon the surgeon, though that does not relate to case law. So case law shows that there is no difference in liability to a surgeon, dentist, podiatrist, again, no matter who is providing the anesthetic. But that word supervision makes it seem as though they should be responsible. And then also to clarify, so in hospitals this bill allows hospitals to choose their own supervision model. So we fully recognize that mainly in metropolitan areas, they will likely keep the same supervision that is depicted in the current statute. So this would just allow rural facilities and their medical boards, made up of physicians of their local region, it would allow them to decide what's best for our patient population.
Thank you.
Representative Fogle.
Thank you. Can you quickly talk me through a lot of the conversations we've had today regarding the earlier bills was about education. So can you quickly walk me through the differences between what you guys do and what training perhaps a general dentist would have as it relates to administering anesthesia?
Yes, absolutely. So CRNA starts out with a bachelor's degree in nursing. It's a 4-year degree. Then we work as a nurse. We are required to work in an ICU for a minimum of 1 year, though the COA reports that the average before admittance is 4.5 years, working in an ICU. Then we are admitted into graduate school, which is a minimum of a 36-month program, after which we pass a national certification exam before we are allowed to practice. A dentist, I think, takes various rotations through certain things. It's actually funny. We had at the hospital that I work at, we train oromaxillary facial surgeons, so surgeons that do surgery on the face and the jaw. So they start out as dentists. They come to us and do a rotation with us in the OR for several months before they can go on to to practice surgery, but just ironically thinking that I was training the dentist in anesthesia, and he, according to our current law, was allowed to give just like fentanyl, for example, and I was not. And I was educating him on the practice of anesthesia. Dentists in general have no specific training in the administration of anesthesia, similar to podiatrists as well.
Representative Thomas?
To inquire, please.
Go ahead.
Thank you. A clarification. When you said earlier that you would not be able to operate a pain clinic, I want to know if that's accurate, because you said if there's a physician referral, you could provide the services. I don't know that there's anything in here that says you can't, under the new conditions, that you can't operate the clinic, which would be a change.
Yeah, so according to our current state statutes, we have to practice within our scope and our training. I was not trained in pain, so I would not be allowed to go open up a pain clinic. There is a fellowship that a CRNA can obtain. So after 2 years of being a CRNA, you go back for a 12-month fellowship in chronic pain management. There is another certification after the end of that training, and then you're certified to practice in chronic pain management. But again, if a CRNA is not trained in that, then that's not within their scope and would not be allowed within the statutes.
Okay, because again, that was unclear, since you said that as long as you had the referral, you could provide the treatment. And I'm still not sure that you can't operate that clinic. And are you able to do spinal stimulators?
So no, spinal cord stimulators are not taught extensively within the pain certification course. No, CRNAs would not be placing spinal cord stimulators. Even after the pain certification, those CRNAs would still need a patient to be a request from the physician, dentist, or podiatrist. So even though they're certified, they still have to have a request or a referral.
But once you have the request, can you then follow up on that?
For those that are pain certified, yes,
Right.
that is within
so
their
you
scope
can
and
provide
training.
that. Okay. All right. Thank you.
Further questions? If not, thank you very much, and thank you for your testimony. So we are ready for a opposition. Dr. Marshall, when you're ready, start, please.
Thank you, Representative Hayden and members of the committee. My name is Julie Marshall. I'm from Columbia, Missouri. I'm here to oppose House Bill 329, and I will try to avoid hitting too many of these topics I think that have already come up. I am a physician anesthesiologist. I have worked with CRNAs in medical direction and supervision for over 14 years, and I do agree that CRNAs are a very important part of our practice and part of the healthcare team in Missouri, and I do appreciate everything that they do for Missourians. I'm in academic medicine. I have spent 5 years as a residency program director. I write exam questions for a national board exam, and I am the current president of the Missouri Society of Anesthesiologists. So I appreciate the prior testimony about the reasons for discussing bringing this bill forward. I did speak with her last week about some of the things that were in this bill and the reasons for bringing it forward, and those were some of the items that were brought to the floor. So the three reasons that were brought forward were, number one, member request, when they had surveyed their members, that there was a compliance with some of the, or a question about compliance with some of these controlled substances, which she alluded to. And this was actually a question that had come up back in 2017 with the BNDD, and we had addressed that and got some language clarified about what that meant for orders for controlled substances. So in the state of Missouri, we do not need to have an order for every controlled substance if a CRNA is under the direct supervision of an anesthesiologist or is working with a protocol under the supervision of another physician. So that was the questions brought forward about if it is a surgeon, podiatrist, or dentist. So in Missouri, every procedure is supervised by either a physician anesthesiologist or by one of these other providers. Protocols are in place at facilities in order to have the appropriate kind of guidelines for CRNAs to practice. And if they need to go outside those guidelines, then they need to just clarify and request that they go beyond that for the person who is supervising them. So if you're in a procedure, if you have somebody there, potentially in the room, that you can just ask, I need to go beyond those guidelines. Anesthesia is a unique specialty. We are dealing with patients that are not involved in their care. They have entrusted us in a very vulnerable time in their lives for us to give very powerful medications that control their physiology. So they decrease their blood pressure, may make it so they are not breathing independently. They may change the way that their heart contracts. And so, there are a lot of things that may change in an anesthetic, and having a physician available to immediately respond is very important. So I am getting a wave. I was going to provide a few details as far as data, and some of my colleagues will cover some of these as far as some of the language. We actually have 45 states with physician involvement in the United States. Supervision may not be the word that is used. It may be other things such as direction. There is data showing a difference in outcome for independent studies. So a 2017 study looking at 200,000 patients showed a 6.9 access deaths per 1,000 complications when there is only a CRNA involved in care. There is a 80% higher unexpected disposition when CRNAs are providing care versus an anesthesiologist. For opt-out states, there is an 8.7% increase in inpatient costs with an average of $1,800. And we have both national data and data in the state of Missouri that physicians want, or patients, Missourians want physicians involved in their care.
Thank you. Questions? Yes, Representative Vogel.
Thank you. I want to follow up on a question that a representative asked earlier. So I can't think of an example, but would there ever be a time where a CRNA was providing a service that there wasn't a physician nearby in the building that was getting ready to, whether it's oral surgery or any other type of surgery? Is there ever an example of a time that wouldn't be the case?
I'm not going to be able to say an absolute, but facilities have a protocol also for those. If there's, I'm not sure if I can think of one off the top of my head.
Okay. So your concerns related to, in case of a medical emergency, would those same providers not be on site already, which would alleviate the concern of having someone there in case of a medical emergency? Do you get what I'm trying to ask? I'm just trying to understand how those things intersect.
If there's guidelines, with these protocols, there may be a certain level of like a vasopressive substance, something to increase blood pressure. That's within the protocol. And if it's beyond that, is involving the physician in order to continue to make guidelines and choices. And physicians I have spoken to who are surgeons on this, they want to be involved. And honestly, our American College of Surgeons and the Missouri chapter of the American College of Surgeons support continuing physician-led care. They have written letters, and I'm sure we can get copies to everyone if they don't have it. So, when things are going wrong with the patient that they have brought to a procedure, those physicians want to know and want to continue in that discussion and be involved in directing the care.
Can I ask a follow-up question? Do you think those sentiments would remain true for general dentists and podiatrists who maybe aren't as confident in those emergency management situations, but are operating as the supervising physician or dentist in the case?
I work with podiatrists. I don't work with any dentists. And the podiatrists I work with are very involved in the care of their patients. If there's something that's changing, they always do want to be involved in the discussion. So, they can delegate what they feel is appropriate to the CRNA, and each facility and each setup, just like I think with the last bill you heard, there's a lot of variability in what things may be out there, but that's up to the facility and the physician.
Okay, that was helpful. Thank you.
Other questions? Pouchet, this is Representative Pouchet. This is your first query, and I am so happy that you're involved tonight. Oh yeah, it's Rhea. Representative.
Yeah, the microphone didn't work. Good evening, thank you. Just going back on the same subject line and brought it up. So, would there be an instance where a dentist or a podiatrist or some other physician, doctor, overrode a CRNA on when it came to anesthesia?
I have not been told of an instance that occurred. When I was speaking to our colleague from the Missouri Society of Nurse Anesthetists, I asked if there was ever a problem that they were aware of where there was a protocol in place and that somehow impeded or impaired patient care. And there was no instances that was brought to me.
So there wasn't like a disagreement on how to proceed, even in an emergency situation, between a CRNA and the providing surgeon, or
I don't
that
have
we're
any
aware of?
information of one, no. But I mean,
But-
I just don't have that
I
information.
mean, obviously they'd be involved because they're performing a surgery or an operation or some sort, but if they're not going to have any input on anesthesia, I don't see why it's an issue. I guess. I don't know. I just, as a non-medical person, I'm like, well, if it's not their world, why are they,
Why? If there is a physician anesthesiologist involved, obviously we are bringing in that expertise. If
Right.
we're in a situation where that is not available, so this is not an access issue. Right now, CRNAs are everywhere that they want to be in the state of Missouri. Is that in order to provide that same care safely for very powerful medications, is to have protocols in place for what is considered a reasonable component of medications for that facility and that type of procedure.
I totally understand it's very delicate and important stuff and a lot smarter than me doing it. But if the podiatrist or dentist doesn't overrule or argue with the CRNA, if there's no physician anesthesiologist, then I don't see where the concern is.
I think it's just continuing to involve them in care. So if you were providing like a sedation for a patient who is undergoing a dental procedure and they are not doing well.
Sure.
That physician, the person who is in charge of that procedure needs to have that ability to be part of the discussion and part of the determination of if the CRNA involved wants to continue to provide additional sedating medications and is going beyond what's considered to be in the bounds of the standard care. That's kind of an important thing for that dentist to be able to guide whether or not that procedure is going the way that they want it to as well.
Well, obviously it's not going in the way they wanted because that's who would be in the situation of outstream. But with their limited experience and knowledge of anesthesia, wouldn't they normally just go with the person who's trained in that?
And in that instance, if they choose to do that in a very limited instance of a dental procedure, then they would have that right to choose to do so.
Okay. I'm just trying to understand. Thank you.
Patty, Representative Lewis, I'm sorry.
To inquire.
Granted.
Thank you. Good evening. Thank you so much for being here and sticking around and for hours and hours. I'll try and be brief here. But I just, you said something about like protocols. Right. Who writes the anesthesia protocols when there aren't any CRNAs?
I will defer potentially to how these have been written in the past, but there have been protocols provided to facilities that have come under review. This was years ago when this was set up as examples, and those were provided to facilities if they needed to have a template in order to help guide care. I believe all facilities that, should have them available. I know we have discussed, when we were discussing with the, concerns about bringing forth this bill, that there might be some facilities that have some outdated ones. If that was a concern, I I and the society are happy to help working through that again. But I believe those were helped, put together back when this program was initially started.
Okay.
I couldn't give you a year on it. I'm sorry.
Okay. So, and then a different question though, just quick yes or no. So, is a physician anesthesiologist required to deliver safe anesthesia care?
Yes, I would hope so.
So then,
Sorry.
what would your answer be to the 78% of hospitals or healthcare settings in rural Missouri that don't have an anesthesiologist present?
Right. So there are some payment issues. One of my colleagues will come up and talk about that in a little bit more detail. But there is a discrepancy in the way that CRNAs can be paid in some of their rural settings compared to how anesthesiologists can be paid. So at a federal level, they can be paid under Medicare Part A, where we get paid under Medicare Part B. And I will let my colleague kind of address that in a little bit more detail, but it sets up a payment discrepancy in those two settings.
But I wasn't asking about pay. I was asking about like safe care of anesthesia.
Right. So there is a challenge of getting the payment at those rural areas in order to support anesthesiologists. There is obviously a lot of CRNAs in the rural areas that are serving there. When we do get into situations with opt-out states, we don't see an increase in CRNA moving to rural areas. It's pretty much the same number, but we don't. This isn't an access issue question in Missouri either. Right now, every place that wants a CRNA in a rural area can continue to have it with our current system.
Thank you.
Further questions? If not, we thank you for your testimony and appreciate your time, and particularly staying as late as you have. Okay, and somebody in support.
Good evening. Thank you, Representative Hayden and members of the committee, for allowing me to share this wonderful evening with you guys here. It's an introduction. My name is Sam Hadi. I'm a board-certified neurosurgeon, and I practice in St. Louis. I am Department Chair of Surgery for Mercy Clinic South, and also Medical Director of Spine and Pain for Mercy East. I am testifying in support of HB 329. I have had the unique opportunity to work with a solo CRNA practice in rural Missouri, as well as with CRNAs and anesthesiologists in St. Louis. At both locations that I've worked at, the CRNA care was excellent. I honestly saw no difference in the care between anesthesia provided by my solo CRNAs in rural Missouri and the CRNA physician collaboration team that we have in St. Louis. At both locations, my patients received excellent care. I was impressed with the quality of care done in rural Missouri. We were able to do quite a few surgeries. The bill intended before you will not remove the physician involvement, will not change the relationship between the CRNAs, at least the surgeons. I think we're all here for the patient's best interest, and they've done a very good job. As a surgeon, I would prefer not to be liable and in charge of something that I am not an expert or trained in, although I would be happy to collaborate and work with them toward improving the patient care. With that, I'd be happy to answer any questions from anybody.
Questions? Representative Keithley?
Thank you. To inquire?
Yes, go ahead.
I'd like to not be liable for a lot of things in my business too, but so a question I have is, I'm in your role as a neurosurgeon, how many of your patients are you meeting with pre-op, build up to surgery, how far in advance?
Well, I mean, obviously with every patient, I'll see them preoperatively, both in my office. I'll see them the day of surgery. I'll see them postoperatively, and we'll follow up with them in the clinic afterwards.
And how much involvement do they have in a pre-op with the CRNA or the anesthesiologist, whoever's providing that, in the build-up to that?
You might want to ask them about that. They have their own specific areas that they ask about questions. I do my area based on what I check for my neurosurgery surgery that I'm going to proceed with. Mm-hmm. So I don't want to answer something that I'm not an expert in, so I would defer to them to answer what questions they do and what they do preoperatively.
And then in terms of choosing a CRNA team or staff person, who's making that decision ultimately?
So I had influence if I would, had preferences on somebody that I worked with, or personality issues, or just people that, you liked more, like you would any other field. But I did not make those choices. They were assigned to me by the staff, whoever's running the board, or the anesthesiologist group had some sort of process for putting people in my room.
Okay. Thank you.
Representative Fogel.
Just a few quick questions. When you put a patient under, I don't have the right terminology. When a CRNA puts a patient under, are there things that regulatory guidelines on how close you have to stay in proximity to that patient as a surgeon? Like, is there anything that says you have to be in the building if your patient's under, or anything that says you have to be within a certain yard or feet?
Yes.
I was like, miles, not the right one. Certain yards or certain feet within the patient that you're being treated. I'm trying to get to the heart of this in case of a medical emergency situation and how
Correct.
close
I think
a surgeon would be to the patient.
Most hospitals will require you to be in the building. You can't go sign in, do your pre-op consents, et cetera, and leave and go do a clinic or see a patient in another facility or another building. They won't. That's not good care, and most of the time not allowed by hospital laws.
Okay, but that would be dependent on the hospital. There's nothing in any other.
Not that I know of.
Okay, thanks.
Representative Stinnett.
To inquire.
Go ahead.
Can you tell me, in the rural communities that you were speaking of, what types of procedures you were doing there? Were
Sure.
they different?
The community was Rolla, Missouri, and it was kyphoplasties, lumbar discectomies, lumbar decompressions, and anterior cervical discectomies and fusions.
Okay, thanks.
Could you repeat those? No. Okay. Representative Sykes.
Yes, to inquire.
Go ahead.
Would you say that the training for CRNAs is greater in scope than what you've received, and yet you're to be placed in a supervisory position? Do you think they're more than qualified to be self-sufficient and self-supervising because of their training?
Well, as a neurosurgeon, I'm supposed to know everything.
That's what I thought.
Yeah, but on
Yeah.
these, actually, the training for us for anesthesia is it's limited. It's
Okay.
what we learn on the job.
Okay, thank you.
Representative Lewis.
Just to inquire.
Go ahead.
Good evening. Thanks for being here. I just want to kind of talk about like an emergency, because I think that sounds pretty scary to a lot of people, emergency. And I worked critical care, ICU, and academic facilities. And so when we think of and correct me if I'm wrong, but when we think of like an emergency or, code blue, anesthesia or CRNAs are the first to come to the rescue to protect the airway. That is what they are trained to do. So you are in good hands with your physician, anesthesiologist, and your CRNA. They're the ones who come running and intubate the patient. So I don't know, just my thoughts. Do you have any comments on that?
Yes, I don't respond to many codes.
Right.
Okay. Unless you have a head bleed or you have a serious problem that needs some sort of craniotomy, I have very little to offer. And so I kind of make sure that there's somebody running the show and I move on to my work. If I'm the only person around, I will do the best that I can in that room. But I am so specialized that my area of expertise does not extend past neurosurgery to any significant extent, unfortunately.
Thank you so much.
Further questions? If not, thank you for your testimony. We appreciate it.
Thank you.
In support, oppositions.
Good evening, Mr. Chairman. I appreciate the ability to come talk to you. I commend the committee's stamina for allowing us to talk about something that's very important to us. So your stamina in being here is a real good thing for us, so I appreciate it. I'm Matt Casey. I'm a physician anesthesiologist in St. Louis. I work for Western Anesthesia. I have possibly a slightly different perspective to come before you. My oldest sister, who is my greatest influence to become and to get into the medical field, is a pediatric nurse practitioner, and my wife is a nurse anesthetist. So I definitely hear I have a different perspective on some of these issues than maybe some because of the conversations I have at home. Both of those individuals would not practice in an independent setting. Both of them love the collaboration that they have with their physicians. They learn from their physicians learn from them. They think that the care that patients get from a care team model is better than them alone. And the vast majority, I've been doing this for 20 years and working in an anesthesia care team model my whole career, the vast majority of nurse anesthetists that I work with feel that same way. I really would love to hear the argument that my experience, my training, combined with a nurse anesthetist training, provides the exact same care as one of us alone. It makes absolutely no sense to me that two people's experience that are different, their educations that are different, can come together and work together collaborative and wouldn't provide a better product and better patient care than one alone. I would love to hear that argument, and I never have. Couple questions that have come up that I've heard since I've been here. One is the setting of how does this rural anesthesia happen, and do you think it's worse without a physician? And I think definitely yes. I think we would love to have physician involvement for the exact reason that I just mentioned. Another question was asked about, is there a time when a nurse anesthetist would be alone without a physician, a podiatrist, or a dentist? I think maybe you're getting to a point of possibly situations like a interventional pain clinic, a ketamine clinic, a medical spa, things like that are where this could possibly lead to nurse anesthetists or nurse practitioners practicing alone without any type of supervision or collaboration with a physician. And lastly, I find it very short-minded that people that come up in front of you say that the care is the exact same, we use the same practice parameters, we use the same techniques, we use the same decision-making. I won't go into the weeds because we don't have time, and I'd love to go into the weeds with you on this, but every practice, maybe I shouldn't say every because that always gets you in trouble, but almost all practice parameters that are commonly used in anesthesia have been developed by research and clinical data developed by physicians. Our peer review research is unmatched. Our quality and safety initiatives over the last 50 years are the envy of every specialty in anesthesia. Every little minute detail that becomes second nature for every CRNA and every physician, including how much anesthesia gas to use and what's the appropriate number, was based on physician research that created that. So the people that say that physicians aren't needed, that our care is the exact same and we don't need them, they use the physician's data and all the research that we've done over the last 60 years, and then they say we're not necessary. I think that's very short-sighted. Thank you. I'm here to respond to any questions.
Representative Nixon Clark, please.
To inquire, Mr.
Go
Chair.
ahead.
Thank you so much. I hadn't heard that they were trying to take your position, correct? My question is, previously it was testified that there is an issue with getting paid in the rural areas for anesthesiologists, correct?
I think the way the way care is paid for by Medicare and Medicaid is different based on a physician in rural areas, yes.
Sure. And with that being said, and with the concerns of not being enough anesthesiologists in the rural area, what would be your solution?
Getting more physicians. We don't have, we have a national crisis of anesthesia personnel, of medicine in all aspects, not just primary care, not just anesthesia, in everywhere. We look at different states that have different rules on supervision and direction. They still have problems with access to care in rural areas. Missouri isn't the only state in the country that has problems with rural medicine. Every state does. So we need more physicians, we need more nurses, we need more nurse practitioners, and that's a money problem.
Sure. And so for the last 4.5 hours, we've established that there's a lack of physicians, right? And so in the meantime, what happens? People are dying. So how do we fix that right now?
Well, we do a couple things. One, we try to make the physicians as available in as many situations as possible. You will get data on the counties that don't have a physician available. You should also get data on how many procedures are being done in these facilities. The vast majority of procedures in this state are being done in Kansas City, Columbia, St. Louis. 90% of all procedures are being done in these places. So are we solving a problem for 10%? Maybe. But are we trying to create a system that doesn't incentivize people to go into medicine and go into become physicians? I think we might be. And I think we might be creating a problem that people say, man, I don't want to go through 4 years. I took me 3 years to get into med school. Every part of that, my journey to medicine, there was an obstacle. And at that obstacle, I could have gone, and I was instructed by a couple people, why don't you go into nursing? It's going to be shorter, and you're going to get there faster. I wanted the privilege to be called a physician and to have a patient-physician relationship. I think that is something that is so important to me that after 3 years or after not getting to med school and going to a master's program, starting a PhD program, until I got into med school, I would be, I didn't want to waver from that goal. And I don't want to create systems and laws that dissuade people like me from going into medicine. And I think some of these might.
Sure. And so is it safe to say that your definitive answer that the 10%, it doesn't matter?
No.
Okay.
It means that we have to do better ways to get stuff. And if we say that my job is not important, that my input doesn't mean anything, if that meant that all of a sudden thousands of nurse anesthetists were going to come and move to the rural areas, maybe we have to really think about that. And maybe I'd have to say something different at this mic. But that's not going to happen. The nurse anesthetists, just like physicians, work where there are jobs and where it's where they want to live. And that's been proven for many years. So trying to create access by giving someone more authority doesn't create access, and it hasn't worked for a long time, in my opinion.
Thank you so much.
Representative Fogel.
Thank you. Is there any service that you provide that, let me rephrase this. Is there any medical service that is provided that a physician anesthesiologist has to provide the anesthesia for versus the CRNA? Or are there any very labor intensive or very, you know what I'm trying to ask?
Kind of. And it's probably facility dependent. It's probably comfort level and experience dependent. I know in my facility, and I work with nurse anesthetists and certified anesthesiology assistants, they do a broad range of physical activities into the anesthetic care. I am the one that is called in our facility to handle emergency intubations that require a fiber optic intubation. In my training, I did over 1,000 fiber optic intubations in 4 years, and I led a training program for 4 years in Chicago before I moved back to St. Louis in difficult airway management. So that's one way with difficult airway where my training is far superior to even some of my physician colleagues and where I'm relied on to handle those type of things. That doesn't mean that I'm the only person that can do it, and sometimes I try to teach and help people because they need to learn some skills in this area. But that's one way that I do things that most nurse anesthetists don't get the same experience that I do in the training.
And can you clarify for me, are you here testifying on behalf of Mercy or are you here testifying on behalf of yourself?
No, I work at Mercy. I work for a private anesthesiology group. So
Okay.
I'm here for myself. I'm here as a member of the Missouri Society of Anesthesia.
Okay, thank you so much.
Representative Sites, please.
Thank you. To inquire. First, I'd like to state that everyone on this committee would appreciate your service and what you've done in the medical field. I think it's outstanding, your work as a physician and the specific things that you've done. But earlier you mentioned collaborative practice, so I have to go right back to the piece of legislation that we're talking about. And on page 2, lines 32 through 35, it states, "Nothing in this subsection shall be construed to prohibit or prevent a certified registered nurse anesthetist from entering into a collaborative practice arrangement under section 334.104. So again, if they choose in the area in which they live to maintain being in a collaborative practice arrangement, they can do that according to this legislation. But just like I spoke in favor of the last bill that was presented, this would give these individuals a choice whether or not to remain in the collaborative practice or to go off and do things a little bit more on their own.
Two things. One, just because you don't have to be into a collaborative practice region doesn't mean that I think there are a lot of nurse anesthetists that would choose to it. I testified to that early. My wife is one of them. She would choose. I wonder where that would go down the road, especially with hospital administrators who oftentimes forget about patient care, sometimes forget about what they want, and are all only looking at a dollar value on something. And would they prohibit, and would they create a system in a hospital that said, I'm going to not pay the physician as much because I don't have to. And if they want to stay, maybe they could. Or if the nurse anesthetist wanted to work with them, they could. I think that creates a terrible idea and a terrible opportunity for hospital administrators to meddle in something that they really shouldn't.
Do you think that's happening in the 42 or 44 states where they do not have the CRNA supervision, or whatever you want to call it based on the last testimony?
I think the majority of anesthesia care, even in those states, are some version of a collaborative care team with a physician. But because you can't, for myself, when I work in the care team, and to bill Medicare and Medicaid, I have to perform 6 vital functions to say that I've performed my duty and to be reimbursed for that. That becomes pretty onersome. And a lot of places will choose not to bill in that way, and they'll bill as a supervision, not a direction, which is a lesser standard, because they don't want to get audited and they don't want to find that they're not performing all 6 steps. So I think a lot of the data that you're shown says that medical supervision or less than medical direction is happening. And it's happening some places, but I think a lot more places are doing anesthesia care team and not billing for it because they're worried that they don't completely comply with all of the regulations.
Okay,
So I
thank
think
you.
some of the data is a little misleading.
Okay, appreciate it.
Is this your second time representing Keith Lee or not?
No, not on
No.
this.
Okay, go ahead.
Thank you. To inquire.
Go ahead.
And then just to Representative Seitz's point on this, well, I mean, I guess and maybe this question would be better suited to someone who is, I guess, here on behalf of a facility itself. I mean, I do see this as restricting. That may not be the intent, but I do see restrictive language in this regarding collaboration. I mean, if you look at Section 7 on page 10, a certified registered nurse anesthetist, as defined in subsection 8, shall not be required to enter into a collaborative practice arrangement. It does not say who's requiring them. I mean, if I were a CRNA, I could read that and say, no, my facility can't make me enter into this collaborative. I'm completely independent as far as the decision to go into collaboration. I don't know if you can speak to that as whether facilities have these collaboration requirements beyond supervision, or if they would seek to input those. But I'm curious how restrictive that would actually be on the facility. I don't know if that's the intent behind how that language is, but I think that's how it reads.
I can't comment to it, but it does worry us, and that's part of the language that worries us and what we see as a possible, down the road effect.
Thank you.
I'll raise my own hand. When we look at rural practice and we look at, and I'm in an area that has had 2 hospitals close, and we are desperate. But is that desperation caused in part by how we do Medicare and Medicaid, and is the reason we're getting CRNAs at these hospitals is because we're getting percent of bill, and administrators cannot pay for an anesthesiologist because of Medicare and Medicaid as a percent of bill, which is lower in my area, which is 40 miles from Columbia, than it is in Columbia. Is that correct?
I think that is correct. I think the other part of it is it's very clear that complicated procedures are done better at places that do a lot of them. Every time that I'm on call, not even on call, every time I'm working in St. Louis, we get a transfer from one of Mercy's rural hospitals. Every day there is something added to our operating room schedule because it's something that isn't done in the rural place. And that's not a bad thing. I think that's good for the patient. When you go to a place that's doing more cases, you have a surgeon who's doing more of one thing, they do a better job. That's been very clearly documented in many studies. So I don't disparage the rural hospitals from shipping patients up to an urban center, but that's the reality, and that's why we have 50 anesthesiologists where I work. That's why we have 70 anesthetists at where I work, because we're doing more cases, because we're doing more complicated things. The bread and butter, easy procedures are done in these places. The last thing I'll say is anesthesia has become very safe. And so when you look at, are the outcomes better with or without? The outcomes are good no matter what you do, because of the 50 to 60 years of work, groundbreaking work on patient safety that has been led by physicians in the anesthesia space. That can't be overlooked, that all of that work to create a safe environment shouldn't be used as a reason to to take away from the physicians that helped create that.
As a rural legislator, I'm firmly convinced that our Medicare and Medicaid system is choking our rural hospitals on their payment systems, and a lot of what we're talking about of lack of rural care is due to government interference in the form of Medicaid, Medicare, and Obamacare. And what's designed to help has actually hastened the destruction of rural medical systems. And if you're in one of those areas and you think you're getting a fair shake, I think you're sadly mistaken. And I think that's part of what we're discussing here is not whether we have anesthetists. I think it's a function of the payment system we're getting on Medicare, Medicaid, and other systems. And that's another bandbox I'm on, and I'm through. But other questions? By the way, I think you could run for politics. I've been married 50 years, and you danced around that of hacking your wife off when you go home tonight. I thought marvelously. So I wish I could do as well when I get home tonight. So thank you very much for your testimony. Any other questions? I'm sorry, any other questions? All right, we are to someone in support. Oh, quick idea. How many more would he have in support? How many in opposition? Tell Mama breakfast is coming in, I guess. So is there other room still? The police making sure we're not convicts in here. So, okay, all right. Because the numbers that would take us about to 11:30. What we have right now, we need to really speed it up and cut them down. Go ahead.
All right. Good evening. My name is Dr. Andrew Palmisano. I'm a board-certified orthopedic surgeon from Jackson County. I support this bill for a couple different reasons I'll get into. First off, the operating room is very much a team effort, as we've discussed already tonight. We each have our role to do in our specific area of expertise. I complete complex joint reconstructive surgeries, and the CRNA in the room performs the anesthetic, and that allows me to do what I do. Just as the CRNA is not qualified to supervise the surgery that I complete, I don't feel I'm qualified to supervise or to perform their role. By having the operating surgeon sign off or supervise the CRNA, liability that is not warranted or appropriate is now shifted onto that surgeon, podiatrist, or dentist. The operating surgeon has enough liability for the procedure itself, and I don't want to take on the liability of the anesthetic or the CRNA. So I think shifting this liability to the appropriate provider makes logical sense. Along with this, I feel many surgeons would agree, and they do not want to take on the liability and practice in the areas where there is excess liability, as we've been discussing. I believe the burden serves to limit care and surgical services and specialties in these areas of the state, which are predominantly CRNA only. And removing this barrier will allow better access and better care for our patients. Lastly, I've spoken to many of my surgical colleagues as well as the anesthesia physicians that I work with on a daily basis, none of which have opposed this bill, and all of which agree that removing the burden from the surgeon, placing the liability on the person that's actually performing these duties would only serve our communities and our patients better moving forward. Open to any questions.
Questions? I have one real quick. So if you're doing that, we've had a lot of discussions earlier on about liability. You're just saying basically it shifts the liability to CRNA, and necessarily if we shift liability, their malpractice has to go up, correct? If you're shifting liability from yourself because of that liability, then it's going to be on the CRNA. So somebody's going to have that responsibility, either the hospital or the CRNA. Correct? I mean, I've got lawyers in here, so
honestly, I don't know.
I mean, that's my question. The liability doesn't go away, so by shifting it, their malpractice has to go up if you're shifting responsibility.
So potentially, honestly, I don't know about CRNA's liability insurance.
Okay, but you would feel your responsibility, your liability would go down.
It would go down. I don't think it would lower my malpractice. That'd be nice. But
with insurance, it probably increases both of your liability. Both of your malpractice goes up, I would guess, but I don't know that. But that was a question, so you don't know the answer to that.
I do not know the answer to
that. Okay. Representative Lewis.
To inquire.
Go ahead.
Good evening. Thank you for being here. I just wanted to make sure I heard correctly. You said none of your group opposes this. Is that correct? Mm-hmm. And how, excuse me, how many surgeons are in your group?
So we have about 40 surgeons, and I've spoken to friends of mine, and I was at a previous practice that I've spoke with a couple of those as well, and it's all basically the same concern that we have is liability, and a lot of us we practice outside of Kansas City, mm-hmm. And we don't want to. I don't want to go to some of these communities just because of that, because of the liability issues and things, and it was discussed that some of the particular surgeries, more complex surgeries aren't performed in some of the outlying areas. We're really talking, bread and butter cases and surgeries and things like that don't need to go to a big community or a big, urban area, but that allows more access to care. So even the anesthesiologists that we have at our hospital, they agreed with that they thought that would allow, better access to care. There's already CRNA only areas of the state, quite a bit of them, and that allows some of those, more standard type cases to stay in those places. A lot of my patients, I do a lot of revision surgeries, so I do hip and knee replacements, and a lot of broken ones or failed ones. They come in from 2-3 hours away. A lot of these patients are 80 years old. They got to drive, quite a bit. They get hotel rooms. They have, family come with them. So some of these things, if they can stay near their community, it's a lot safer for them. But clearly, if they're more complex things or more complex patients in general, they're going to still go to the big city. But it's to allow better access to care for the majority of people in those areas.
Well, thank you. I appreciate that. And I just want to quickly point out, I want to thank all the people in Scrubs who aren't going to be testifying, but are hanging in here, showing their either support or opposition. It's really, really nice to have you all involved. So just wanted to give a shout out to all of you just being part of the process.
Representative Fogel.
Thank you. To inquire.
Go ahead.
We've covered this already somewhat, but I just want a specific answer or more technical answer. When you're either pre-op, in surgery, or post-op, are you in the moment directing the dosage and the meds that the CRNA is pushing?
So I am not. To tell you a little bit, of my anesthesia training, when I was in residency, we had to do a month of anesthesia. We had to do an oral exam at the end of that to test out of it. I asked on my first day if I could take that oral exam, and I did, and I passed it. I took a month off. So I did not have any specific training on that. That's not part of orthopedic residency. It was really just to have anesthesia, to have bodies at the place I was at. But I don't know the dosing for, I know the medications of propofol and fentanyl and things, but I have no idea about the dosing or how you would, keep a patient at a certain level or what MAC or any of those types of things. With that said, doesn't mean I'm not involved in the care. If I'm completing a surgery and they start, spraying blood, I, try to say, okay, what's going on? How's your blood pressure? That type of thing. Or if I notice that, hey, I don't hear that beep very frequently anymore. Why are they at 40, heart rate? Well, then, yeah, you're involved in that, but I'm not telling them what medications to push, and I have no idea what to tell them.
Okay, so
Just
when you
like
walk
they can't
into
tell me what to do when I'm, operating.
When you walk into the surgery room, that's already taken place, and now you're presenting the patients in front of you. At what point are you consenting or signing off in that collaborative practice the dosage and the meds that were pushed? When you sign the chart?
So
or
it'd be after the procedure, but and they have their protocols and things, but yeah, I can't give them any specifics of, they couldn't ask me. They could ask me, and I'd just look at them like I'm not sure how to help you with that.
Okay.
So I'm in the room, yes, and I'm still part of the care team, but that's what they've went to school, went to training for. In the majority of cases, if not all cases I'm in, there are anesthesia physicians at my facility, but they never are in the room. They're not the ones performing the day in and day out, in the trenches kind of the procedures. And to be honest with you, a lot of them, we'll do spinal anesthetics for some of our replacements. And if you're not familiar with them, basically you're putting a needle in their back, trying to numb up some of the nerve roots so that we can perform the surgery. If they're not able to get it, then you would call in your anesthesia attending. Well, they come in and oftentimes they go, if they couldn't get it, they do it all day long. I can't get it. And so, each have their roles and they're necessary, but, specifically for liability and talking about access, I think that's what this is about in my mind.
Okay, thank you.
Representative Keithley.
Thank you. To inquire.
Go ahead.
I just want to clarify some of that. As far as I understand it, I don't think that this would really shift liability at all. I think it just removes you from the liability or removes the physician. I mean, a CRNA carries malpractice as CRNA. At least that's my understanding. I'm a lawyer. If I had a client, and I don't do medical malpractice, but if I had a client who had an issue go on in surgery, I would sue the hospital, I would sue the doctor, I would sue the CRNA too. So, I mean, everyone's on the hook for the liability. You're not shifting liability, you're just removing yourself from that liability equation. So, I mean, that's how I understand it. And I want to make sure that I'm clear in understanding if that's how you see it, because I think that's different than shifting it, saying, well, the CRNA is more responsible for whatever's administered. And that might be true, but and I would pose the same question to you about, in terms of, in your experience, your preoperative care with the patient versus, in your experience, the CRNA or the anesthesiologist preoperative care, because I think that's an important distinction here. When we're looking at the patient's involvement and how much they're vetting, how much they're controlling their team, especially if, the hospital or the facility or you are seeking to remove yourself from the liability equation. I start questioning that when you're the one who is putting the team together, the facility is the one who's putting the team together, and the CRNA is not necessarily being chosen by the patient. The patient's choosing you. They're not choosing the anesthesia team to deliver it necessarily. Unless I could be wrong about how that plays out, but that's in the couple surgeries I've had in my life, that's how it's played out.
Yeah, so I mean, I agree. For for each facility will have their CRNA team or have their anesthesia team, and that's not necessarily the patient choosing that person. For what I do in total joints, we have you either talk with the CRNA or the anesthesiologist beforehand, so you have met them beforehand. Usually it's a week or two before, so that we can develop the plan. I think talking about the liability as well is I still have plenty of liability. I just now, my concern is having liability of the anesthesia itself. So if something goes wrong with anesthesia, obviously, like you had mentioned, you're going to name everybody that you possibly can, plus, their family members, anybody. You put it all on there and see how it shakes out. I think for the anesthesia portion of it, if I'm not the one directing it, I didn't have to sign off on it, that type of thing, then that hopefully would remove me from it and keep the liability on the person that is performing that. Just like if something goes wrong in surgery, in the surgery that I'm doing, the CRNA or the anesthesia physician, they're not on the hook for that. They're not going to be named for that. So shifting may not be the right term, but I think applying liability to where it should be is probably, more of a correct statement.
And then if I could just do one more, because I think it might actually be in the interest of time, because I'll pose this question to you, but I really mean it for I think anyone else who comes to testify here, because I can see myself asking this at the same time, because it's the second time I'm asking this. You said that this is about access in your mind and expanding the access, and there's been a lot of conversation here tonight devoted to expanding this to the rural areas. And I'll be honest, I'm struggling to see how this actually is going to, how this as presented is going to actually increase the amount of surgeries we're able to perform in the state of Missouri. Because although we'd be giving CRNAs this independence within each surgery, the CRNAs aren't really the bottleneck here. I think it's the physicians who have to be involved in the surgery one way or the other. So, I mean, you're addressing the CRNA independence issue, but you're not addressing the much larger bottleneck that is who's going to be doing the underlying surgery. You still have to have a physician in the room. So if we're talking about this in context of whether a liability shield for you is a good idea, let's talk about that. But if we're talking about this in the context of, this is a good idea for expanding access to rural areas, I don't really see that right now, and I'm trying to figure out how does this actually accomplish that.
I don't think it's access of CRNAs. I think it is access of certain surgical specialties. With that said, I'm a subspecialist, and I do a lot of cases that have a lot of liability associated with it, and doing a lot of revision work. Going to some of these outlying places where I would have to be the supervising physician for the anesthesia, honestly, it's easier to stay in the city and not have to deal with that. So I do agree with you. I think it's a bottleneck, but I think that by releasing some of that, at least in my opinion, and from talking to my colleagues, they would be more likely to go to those areas to perform these surgeries. So it's not an access to CRNAs; it's an access to the care that a lot of us just don't want to. It's more liability that we have to deal with, more issues, more burden. Some of my colleagues have tried to learn a bit more about anesthesia before they go to some of these places. I'm just like, I did 6 years of training after medical school, and none of which was anesthesia. I don't really want to go learn that job too, and I don't think I could appropriately. So I do agree with you, but I think the access to care is getting some of the physicians to go to those areas and remove some of the burden for that.
Questions? Seeing none, thank you for your testimony, and appreciate you spend the night. Maybe the morning, I don't know the way we're going. You're going to have some anesthesia, pain management, I think. So proceed when ready.
All right, Mr. Chairman, committee members, I'm still Tim Swearengin, an anesthesiologist in Springfield, Missouri. Side note, Mr. Chairman, I agree with you completely. The Affordable Care Act was absolutely designed to crush small critical access hospitals and drive everything into mega health centers, but that is a discussion for another day. I'd like to start like Dr. Casey. My wife is also a nurse, and it's been my great privilege through my career to work with an outstanding group of nurse anesthetists. I am not anti-nurse, APRN, or nurse anesthetist. I am pro physician-led care. And one of our nurse anesthetists who I worked with throughout my entire career always joked that we should put on a clinic for people to come and see how team-based anesthesia care is delivered. Couple things. You all know me from my last testimony. I don't belabor this. The map that Representative Cook gave you, if you look in the footnotes, they say, according to the Nursing Practice Act or the Board of Nursing, there are other statutes in those states with regard to the Board of Healing Arts, other places in regulatory statute. This is the map, according to the American Medical Association, of states that require physician involvement in anesthesia in the green. Red is no physician involvement. I can leave that for you. To my surgical colleagues who have testified here today, we kind of danced around the issue, but it does appear that they are just interested in unloading any sort of liability that they have with regard to this procedure. I have never met a surgeon who does not want to be involved in the care of the patient. And let's, don't forget that anesthesia is not just the matter of pushing drugs to put a patient to sleep. We manage blood pressure, and we need to know, is their blood pressure low because they're bleeding to death, because they have sepsis, which is an overwhelming infection which causes it, because they have swelling in their brain, because they have decreased heart function, all these sorts of things. And I've not met a surgeon yet who doesn't want to be involved in those types of decisions. I'm not talking about, do I push, 150 or 200 milligrams of propofol, but involvement in the anesthesia care, okay? But what I've heard here tonight is I would like to unload the liability. As Dr. Marshall alluded to, a letter from the American College of Surgeons and the Missouri chapter of the American College who want to preserve physician-led anesthesia care. A couple things, again, that we've danced around here tonight. You're 100% right. I am not a fan of podiatrists or dentists being in charge, but, I didn't create these rules. I think that, a physician anesthesiologist and an anesthesia care team is the way to do it. I see my time is short, but I want to touch base on one last thing that we've danced around here all night. There is federal legislation called Rural Pass-Through. It gives critical access hospitals, which do less than 800 procedures a year. Now, mind you, if you are doing a fee-for-service, what we would call eat what you kill, you can only bill and collect on 800 procedures a year. You cannot make a living doing that. Critical access hospitals through Rural Pass-Through have the discretion to use Medicare Part A dollars to pay for a CRNA. Why this does not include physician anesthesiologists, I have no idea. But the legislation doesn't. The CEOs of these hospitals do not have the discretion to do that same thing for physician anesthesiologists. So I can tell you that if we fix Rural Pass-Through, I do know physician anesthesiologists who would love nothing more than to go back and practice in the area of their youth, where they grew up, Gentry County, Missouri. But they can't, because they can't earn a living there. But a CEO of that hospital can pay a CRNA to essentially not do cases or do a very limited number of cases, still a full salary, they can make a living, and we cannot. I believe that one of our senators may be sponsoring a resolution to our Missouri delegation, congressional delegation, to try to put a fix on Rural Pass-Through, to just simply make those dollars available to physician anesthesiologists. Any questions?
Questions? I think you are very correct. Is that pass through, a lot of those nuances are killing us in rural hospitals and killing. I know there's some CEOs and some office managers of rural hospitals, and in asides, they're telling me that they're getting squeezed and can't help it. So,
to inquire.
Go ahead. I'm sorry.
Just a follow-up. I know you said if you were living in a perfect world, you might not include dentists, podiatrists, and surgeons in a leader of the care team that's administering anesthesia. So that's the reality of the situation, it's how the statute is now. So if your options were a surgeon, a podiatrist, or a dentist to administer anesthesia on you as the patient, or a CRNA, where would your comfort level lie? And let's answer that one first.
Well, so you have to keep dentists and podiatrists separate because of the types of procedures they do.
Of course.
But if you're asking me if I would prefer to have a CRNA administer anesthesia without any type of physician supervision, or would I want, to at least have the surgeon involved in my anesthetic care? The answer is yes. I would want the surgeon involved in the care.
Okay. It's, we're talking a lot about confidence and an ability to do one's job. And it's interesting to me that we've had several surgeons now come on and basically publicly testify that they're uncomfortable providing that care, or that they don't feel like they have the competency to do it in the same way that their CRNA colleagues do. And, as a patient who might one day have to undergo anesthesia, it's been interesting to hear that even they have that discomfort when we have a room full of CRNAs who are advocating for themselves, that they do have confidence in their ability to do that job. So just something that I wasn't necessarily expecting out of today's hearing, but it's been interesting to hear both sides of that perspective.
I think those surgeons, as I said, are uncomfortable with the liability that goes along with it. I would be shocked if they are not interested in being a part of the care that is provided to their patients.
Further questions? Thank you for your testimony, and thank you for hanging with us for a long time. All right, we're talking about in support.
Good evening. My name is Amy O'Brien. I live in Audrain County, and I'm the former CEO of Audrain Community Hospital. Our hospital closed in March of 2022 due to financial difficulties stemming from an ownership transition the previous year and not having enough capital to survive that significant change. The hospital did not close because of low patient volumes or an inability to recruit physicians or advanced practice providers. Access to health care is pivotal in a thriving community. Especially in rural areas, health care facilities provide Missourians with necessary primary care, preventive medicine, emergency services, and surgical services. And these services would not be possible without CRNAs. Our hospital in Audrain County used an all CRNA model because that is all the hospital budget would afford. Compared to physician anesthesiologist supervision models, the CRNA-only model saves hospitals approximately 39% annually. And this unspent money can then be invested back into the hospital to support technology and staffing needs. Our patients reported having great experiences with CRNAs. We never had a complaint or a safety concern. We provided general surgery, orthopedic surgery, GYN surgery, and ophthalmic surgery. The only complaints that I ever received were from the general surgeon and the GYN surgeon that they did not like having to sign off on the CRNA work. And at the time, I did not have a solution. So hearing about the House Bill 329, I realized that we could have a solution for surgeons that don't want to sign off on anesthesia services. We can have a solution for the CRNAs to feel valued and appreciated in our state of Missouri. We have the opportunity for CRNAs to legally do what they have been doing for years, and that is providing great anesthesia care to Missourians. Missouri is ranked 47th in overall healthcare performance. Over the last 2 years, we realized how important it is for healthcare organizations to have options for providing care to their patients. 2023 is the year we need to move forward in removing the red tape that clearly serves no purpose. This legislation reduces regulatory burdens on hospitals and physicians and will allow them the flexibility to choose the supervision model that best fits their needs. So I ask you to vote in favor of House Bill 329.
Thank you. Questions? Seeing none, thank you for hanging with us tonight. Next up, opposition. How many, just a quick poll, how many are left in favor? So I can kind of manage time. 5? Is that the right count? 5? And how many opposed? 1 opposed, all right.
There's 3.
Okay, go ahead.
Good evening. My name is Quinn Johnson. I'm a physician. I practice anesthesiology in Columbia. I practiced in Joplin for 7.5 years and have had the privilege of working in Columbia for the last 13 years. I think tonight, to keep it brief, I've heard all the testimony from the previous bills that you all heard, and I know there's a common theme. But I think the common theme is physician involvement in patient care provides superior care. The issue of why a physician can't be involved is varied. There's economic pressures, there's geographical pressures, there's all sorts of things. But the physician involvement and physician-led care is the best. And as a state, as a group of professionals, I think we owe it to try and figure out how to provide the most optimal care we can to our patients. While there isn't a one solution or an easy solution, I think some of the things that I personally have concern with all of the bills that have been presented tonight, but in particular this bill, is it seems to be a little bit of an overkill. It feels like we've identified an infection on somebody's arm and we're just going to cut it off and let's just get rid of it. And so there's too much red tape. Let's just fix the problem. And if we just open the doors, everything will be okay. Because what these bills do is it allows for each advanced practice nurse to kind of say, and I've heard it repeatedly tonight, you're going to help determine the extent and the parameters that you're going to function under. And I think that's at the heart of the problem. Who's providing the oversight? Who's providing the quality? And the physician is the most advanced trained, the person who has the most experience, typically, to help provide that oversight and help all of us understand what the quality needs to be and the extent and the parameters needs to be there. So physician-led care is important. So these bills, I think, again, just leave the door too wide open. Now, briefly, I'm glad that it's already been addressed where individuals have said, hey, this does not open the door to chronic pain. I have strong concerns that the language in the bill does allow for chronic pain, and it leaves it wide open because of the way that the language is written about diagnosis and intervention and a few things there. I personally have had experience where we've watched individuals, and it's not all of them. I work in a care team model, and I have for 20 years, and I've had great experiences with CRNAs. It's always the 5% that you got to worry about. And that 5% is going to use this open language and the things that we have by completely extracting it and cutting off the arm to take advantage of what's going on. And chronic pain has been delved into by CRNAs in this state, and I've seen it in my own city in Columbia where CRNAs have opened a ketamine clinic with not advertising that there's any kind of physician oversight. In fact, they began to say they were anesthesiologists when they first opened the clinic, which is incredibly concerning. This clinic continues to be open. Ketamine is a drug that we use in anesthesia. It is not something that you just want to have open access to. It has very limited uses, and it can be very dangerous. That's one example of what we're dealing with when we're just saying, let's just remove the physician, and it solves all our problems. With that, that's why I oppose the bill, and I hope that we can figure out a way to continue to have physician-led care, because, again, I think we've all agreed that's the best possible care that we can provide to the citizens of Missouri. Open for questions.
Questions? Thank you for your testimony. When you mentioned ketamine and rompin, and you mentioned rompin, but ketamine as a veterinarian, I have seen the effects of ketamine, and this isn't good. As you see dogs and cats and horses go under anesthesia.
Right.
In veterinary medicine, we have a term for the cut off the arm. We call it put them down. So everything is put them down, and that way we don't treat them. So it's getting late. All right. Next witness.
Good evening. My name is Dennis Purcell. I'm a board-certified, Missouri-licensed OBGYN specialist, and I served as a combat surgeon during Operation Desert Storm. I'm here to speak in favor of House Bill 329, and I'm here to tell you that I'm here as a surgeon. I'm not an anesthetist. I'm not an anesthesiologist. And in the rural hospital that I've served in the last 12 years, I haven't had availability of an anesthesiologist ever once. I've worked with nurse anesthetists for over 36 years, and I'm here to tell you that as a group, they are the most steadfast, dependable, hardworking, well-educated, well-trained individuals you're going to ever find on this earth. I've had surgery myself with the anesthesia administered by nurse anesthetists, and I would highly recommend it. Please understand that when I walk into a rural Missouri operative theater, I am the surgical expert in the room. I am not the anesthesia expert. That role is filled by a very capable nurse anesthetist in my facility. And unlike some of the testimony you've had previously, my nurse anesthetist can do laryngoscopic intubations. They can do tap blocks. They can do other things that are at the cutting edge of medical science. And they have the capability to give the best doggone anesthesia that you would need in an emergency situation. There are times when we don't have time to triage a patient and get them off to the big city center. I would love, more than anything I could tell you, to have full, all the time, anesthesia care in my hospital, but it's not a reality. It's a dream. Someday, maybe, but I doubt it. Not the way things are going. So, just to summarize, I'm here to speak in favor of House Bill 329. I think it's somewhat irksome that a nurse anesthetist has to have me sign off on their anesthesia chart when in reality, I don't know what the hell I'm doing, and they do. They're the experts. I do the surgery. And between the two of us, we keep the patient alive and well. We wake him up and we get him home. I want my colleagues in anesthesia to know I am not antithetical to anesthesiologists in the way. Some of my best friends are anesthesiologists. But I'm here to tell you that they're just not everywhere. And no matter which kind of a map we hold up to you, in Missouri, there is a real cringing lack of anesthesia, so we can't provide this model of care that everybody is talking so altruistically about. We just can't do it in rural health care at the current time. Thank you for your attention, and I wanted to take a moment just to thank your committee. I am so impressed at how well you serve your constituents, and I thank you for your service.
Did we record that? We are recording. Oh, we are recording. Questions? Representative Seitz.
Yes, very briefly, I'd just like to thank you for your service to our nation. I appreciate that.
My privilege.
Representative Toshin Reich. You have not participated, so I'm going to give you a chance here.
Okay. I've been listening all night to every testimony except when I step out of the room for a moment. But he's saying this because I haven't asked a question all night. So I'll ask my first and last question. What hospital do you work at?
Mercy, Lebanon.
Lebanon.
I'm now retired, and I'm doing a consultative practice in Lebanon.
My grandchildren live near Lebanon. Thank you.
You're welcome.
Okay, further questions. Now I'll pick on you. Further questions.
I wanted a question from the nurse in the room.
Yeah.
Yeah, Patty. But
Thank you very much for your time, your effort, and your drive from Lebanon. Okay, so that in opposition.
Sorry. Good evening. Good evening. Sorry it's kind of late. My name is Dr. Yulia Peniston. I'm an OBGYN physician. I work in a rural hospital in Chillicothe, Missouri, and I'm here to support the House Bill 329. I had a great opportunity to work with our group of CRNAs since 2011, and the best group of CRNAs I've ever worked with. I don't think I can go and repeat. I can't remember which physician was here, the OBGYN physician who just spoke. He basically said everything that I wanted to say. I would not be able to do what I do without CRNAs. One of the things that was not brought up to our attention this evening is, yes, there is a crisis in rural America, but I think not letting CRNAs do what they do the best will make the crisis worse. For example, I take call from home. So when a pregnant patient comes in labor, she requires an epidural if she chooses to do so. If I have to come in for every single epidural in the middle of the night to supervise my CRNAs, I will not be able to do my job the next day. And of course, I have to attend to C-sections and do GYN surgery. So I really do think that they're very, very, very capable. They know what they're doing. I just sign a piece of paper. That's all I do. And unfortunately, I don't know what they're doing. And going back to being a team, we always communicate together. I am there for my patients every single step of the way. If the machine beeps, I kind of look over to make sure nothing is happening, and I communicate with my CRNAs. If I provide any kind of local anesthetic, I will let them know that I'm injecting a local anesthetic to make sure there's no changes in blood pressure. If they tell me that the patient is not breathing well and we need to take the patient out of the Trendelenburg for the patient to breathe well, we'll do it right away. So it's always a team effort. It's never he or she's doing her job and his job and I'm doing my job. We're doing it together to provide the best patient care that we possibly can. Sorry, I don't know why I'm so nervous. Any questions?
Questions. You're testifying in favor then?
Yes, sir.
Have you filled out witness form?
Yes, I have.
Okay. Forgot to remind me. I need to remind everyone, make sure you fill out witness form. Questions? Thank you for your coming down all the way from Chillicothe. We appreciate it. Opposition? Go ahead and start.
Thank you very much. I'm Dr. Kathi Perryman. I'm here in Missouri Society of Anesthesiologists, and I just want to talk to you a bit about my experience. I started off as a nurse. I became a nurse anesthetist and practiced in a care team setting as a nurse anesthetist. And I heard the question here earlier today, why in the world would you go back to school for 4 years and add another 4+ years on to that to be, a resident, to become an anesthesiologist? And my answer to that question was that I knew that I wanted to have that full knowledge base. I wanted to have the skill set and that I could not achieve as a nurse anesthetist. And I really loved what I was doing, and I really understood that the staff anesthesiologist that I was working with and collaborating with was an extremely important part of the team. And there were several instances during my career in which that anesthesiologist intervened and really made a big difference in the patient's safety. And that happens with surgeons as well. So I did. I went back to school for 4 years. I finished my anesthesiology residency, did a fellowship in pediatric anesthesiology, and had a wonderful practice collaborating again with CRNAs for over 3 decades. So I value them as members of the team. Most of the CRNAs that I've known over my career would not want to practice independently, but when they are, if they're in a rural setting, the surgeon is a very important part of that team. We collaborate with surgeons all the time in tertiary care centers, and the description that the last OBGYN gave is very, very much, I think, what we're talking about retaining is that teamwork that is so important in patient care and patient safety.
Thank you. You're obviously bringing a different approach from anybody we've had so far. Questions? Again, Dr. Perman, thank you for spending a long, long day, and we appreciate your effort.
Thank you.
Let's see. This is opposition in favor. Yeah, and how many, again, I'm taking a head count. How many left in favor? I think they are multiplying outside. I think there's something going on outside that we don't know about here. You know, so all right, that was in favor. How many opposed? One. Okay. Commence.
Hello. My name is Carla Klubine, and I am the Chief Executive Officer of Pershing Memorial Hospital, a critical access hospital located in Linn County, Missouri. Our hospital, as small as it is, still has some outpatient services that perform procedures at our facility, and those include orthopedics, gastroenterology, urology, ophthalmology, and podiatry. At Pershing Hospital, our anesthesia services have been provided solely by CRNAs for more than 30 years. In the 31 years that I have been a part of our organization, the care provided by our CRNAs have been nothing short of exceptional. In the 15 months that I have served as the CEO, I have not received one complaint or concern from patients, staff, or physicians regarding the quality of care or professionalisms our CRNAs provide. Access to health care impacts the quality of life of citizens in rural communities such as mine. Without our hospital, patients would be required to travel up to 90 miles to receive some of the same outpatient procedures that they receive at my facility. We serve a large elderly population. Transportation for this population can be very difficult and impossible at times. Due to challenges of travel, many of our elderly patients will decline referrals or procedures that require them to travel more than just a few miles. During my time as CEO, I have been actively trying to recruit both primary care and specialty physicians to my facility. To say this is challenging is an understatement. The rural community is not attractive to the physician candidates for various reasons. Some of those include supervisory responsibilities. If not for CRNAs providing services or providing anesthesia coverage at my facility, we would not be able to provide the limited number of services that I listed to you earlier. And the loss of that revenue alone would be enough to impact my facility's ability to stay open. When rural hospitals close, more patients are left without access to health care. Thank you.
Okay. Questions? Seeing none, thank you for your testimony. I appreciate that's a long drive from Linn County, Missouri this time of night, and I appreciate it. Thank you. Okay, and let's see, that was, I need opposition. Proceed when ready.
Thank you, Mr. Chairman. David Jackson, registered lobbyist for the Missouri Society of Anesthesiologists. I don't know how it's over 10 o'clock and we haven't had a joke about people falling asleep yet, given the contents of the bill, but I'll provide that dad joke. In all seriousness, I want to thank the committee. I know this has been a long day, a long hearing, but we have people on both sides of here who come and traveled a long way, and this is their profession. They went to school a long time to do this, regardless of what side you're on. And a lot of hearings like this, people start filtering off and leaving. So we thank you for regardless of where you stand on the bill. I think it's important to think about and go back to patients. We haven't had anybody testify as a patient today, talking about what they want in their anesthesia care when they go into surgery and who they want involved in their anesthesia. I think Dr. Swearengin mentioned before, and I think it's important to reiterate the map that everyone talks about in these 46 states, in my opinion, is very misleading in that is relative to the word supervision. And so states that require medical direction or collaboration or involvement, or if the statutes are in the Board of Healing Arts chapter and not the Board of Nursing chapter, it is not counted in that colored map. So I think that's important to clarify as we're thinking about what's going on in other states. Secondly, I think it's important to look at the current law and what's currently being provided. Right now, CRNAs are already permitted to provide anesthesia care without an anesthesiologist in rural hospitals. I think, as Representative Keithley mentioned, this does nothing to change the amount of surgeries. If this bill passes, you can't do any more surgeries. You still have to have the surgeon. What this bill says is that the physician in the room is no longer the quarterback. And opposed to, the other bill we talked about before, when you have somebody that takes a prescription, maybe and comes back in a week or is in a collaborative practice arrangement with the doctor 75 miles away, you have a little more time. When you're under anesthesia, seconds matter. And so what this says is that a physician and even a surgeon, they can delegate something to the CRNA as much or as little as they feel comfortable. But that physician has that critical care training in managing an emergency. And and we feel that patients want and deserve to have that physician involved in that care. In regards to the protocols, I'm happy to discuss more of that offline with you. As I said, I'm here every day. All a facility has to do is have a protocol in place that says, here is a range of medications that's provided for each surgery. And if you go beyond those protocols, beyond that range, in a certain scenario, you have to get a verbal order from the doctor during surgery and they sign off on it afterwards. I'm a little shocked how many people have said that, this is already happening and seem to be admitting not following the current law, which is a little alarming. But when we talk about rural areas right now where you don't have anesthesiologists, it's a very small percentage of the total surgeries provided. I think, as one of the physicians mentioned earlier, a lot of things are getting rerouted to urban areas for a reason. But I know I'm over my time limit. Thank you.
Questions? Seeing none, thank you for your testimony. Let's see, that was opposition. In favor?
Good evening. My name is Joe Dietrich. I'm a CRNA in Chillicothe. Dr. Pennington and Ms. Klubine are in hospitals that I work at, and we're very fortunate to have them there. I've been a CRNA for 28 years, 16 years at Truman Medical Center in Kansas City as a CRNA instructor in an anesthesia care team setting, and the last 12 years in private practice in a rural setting. Our group provides sole CRNA coverage to 6 hospitals in North Missouri. We cover over 5% of Missouri counties. I'm going to get to, I think I can answer your question about collaborative practice. I believe I can answer your question about pain management. I'm going to talk to you about other situations. My concern with the need to pass this bill is that there is such a convoluted pathway to both the supervision issue and the prescriptive authority issue that we can't comply with them all the time, or we're at risk for adverse interpretation by a regulator and therefore can be cited or lose the possibility of obtaining some services. I would certainly challenge that I can provide safe anesthesia and done so. I can tell you in our hospitals, our employees actually seek out the CRNAs to provide their anesthesia. I do know Dr. Perryman. About 30 years ago in my training, I rotated with her in my pediatric rotation and appreciated that very much. So to your question about supervision outside the operating room, there are situations where that's necessary. When we do labor pain analgesia, that's usually in the labor and delivery suite. There's a physician not necessarily immediately there, the obstetrician. Sometimes we do radiological sedation and an MRI most specifically, and we may get called for critical services such as airway management or code blues in the in the ER or in the ICU. We don't have an operating practitioner in those. Now, a little history is the operating practitioner and supervision definition actually comes from CMS and Medicare, and then got codified in the statutes. So we're having to work backwards to undo this. We've got to get it out of the statutes before we can get it cleared by Medicare. Medicare defines what anesthesia is only in the hospital regulations. So we have to do this weaving thing to try to pretend that we're following all the regulations. Also, there are times in an emergency specific to the prescriptive authority when we can't have those signed in advance that B&DD has said is necessary. If we have an emergency C-section, they can't put those orders in. Or if in the middle of the night I'm doing a labor epidural, the obstetrician may have called in the order to admit the patient, which includes an order for the epidural to be placed on the patient request. If I need to give ephedrine, which is a controlled medication to support the blood pressure, I don't have an order in for that, and the nurse would have to wake up the physician to get that. Mind you, the controlled substance is very narrowly focused to the perioperative environment, to the drugs that we give every day or in recovery room where I know what that patient received, how they responded, and what the best choice is. Not trying to expand practice in those cases. So for us, it's streamlining the convoluted processes to reduce the risk of adverse interpretations. And one of the other things in the CMS regulations that relieving supervision would cause refers to podiatrists and dentists. The CMS regulations, unfortunately, are contradictory in their description of who can supervise. We actually had a state surveyor in Bethany last October, and thank goodness I was there because I know the regulations, who questioned whether we could do an anesthetic for a podiatry case because they weren't an MD or a DO. And I showed her where that is in the CMS regulations, but they're a little contradictory. So we need to clean these up so we can just continue essentially the practices that we're doing, but without risk of losing our licenses, being cited, or the hospitals losing their ability to do podiatry or dental cases, which all 6 of the hospitals we cover do one or the other. Thank you.
I have a question. So you're saying we need CMS revisions, that what we're doing is not going to have effect? I got a little lost on that.
I know, it's convoluted.
I mean, because we don't have any control over CMS. I wish we did. But
No,
we
you
certainly
don't, except, so supervision is something that was going to be relieved entirely by CMS back in the year 2001 because of a 1998 article that showed we were just as safe. However, because of the push-pull, throw something against the wall, everything against the wall, something will stick, they came out and the states can opt out of the supervision regulation. But we have to get out of statute before the governor can opt out of the supervision. And the description of supervision in the CMS guidelines is variable. If we're free of the supervision, then we don't have the issue providing any question about being able to provide anesthesia for dental or surgical cases. That also gets into the definition of what is anesthesia. Is a sedation case where I give a little bit of medication actually an anesthetic? Is labor pain relief an anesthetic? Those are defined differently in different places, and those things become crystal clear and okay if we can get relief from the supervision guidelines. And then regarding the prescriptive authority, again, there are just times where we can't comply in spite of best efforts for putting in an order set that I personally wrote for our institutions for the physician to sign for me to give. And to your question, if I may address the previously addressed questions, if that's okay. You asked about pain management. Back in 2014, a bill was passed that prevented CRNAs from using advanced imaging modalities such as CT scanning or real-time X-ray. So being able to place the spinal cord stimulator is not feasible. These orders only allow us to administer medications in the perioperative environment, so we can't send them home on a script for pain medicine. Ketamine clinic, okay, I don't know, maybe, but low-dose ketamine has actually been proven to be very helpful in a number of situations. But the type of pain management you're referring to, Representative Thomas, I don't see as feasible just because you can't use the imaging necessary, which was the entire intent of the bill in 2014. You had a question about the collaborative practice. That's where things got muddied years back when they wanted to give APRNs prescriptive authority and in a collaborative practice agreement, CRNAs were specifically carved out of being able to give those. I think the concern by the opposition was, okay, a CRNA could get collaborative practice agreement, use the prescriptive authority to do what we're asking to do going forward. Collaborative practice and supervision are not the same thing. Supervision is a definition that comes down from Medicare. Just means we have to work in the presence during an anesthetic of the MD, DO, podiatrist, or dentist. Again, you get into the definition of exactly what's anesthesia. So there's nobody I know uses collaborative practice in a nurse anesthesia environment. For us, it'd be impossible. We cover 6 hospitals. We have 5 full-time CRNAs, several part-time CRNAs. The math just wouldn't work in those situations anyway. And all we need to do is have the presence of the practitioner in the operating room. That part's not going to change. What's going to change is the regulatory risk from interpretation of these, our ability to navigate these little zigzags of the convoluted regulations, and making sure we're doing everything we can to be compliant.
Representative Stinnett.
So, am I understanding that you're saying there's always a physician, podiatrist, or dentist throughout your administering of the anesthesia process?
In an anesthetic in the operating room, that's correct. Because they're the people that are only allowed by CMS to do surgery.
Okay, so there's never a point in time where you're with the patient and they aren't present either before they start the surgery or
Immediately
during a portion.
available is a common phrase, but we don't start a procedure until the surgeon's in the operating suite, so to speak, and they may be back out dictating, but they're going to come follow up on the patient. Again, we have a very cooperative environment with all our surgeons. We're very fortunate in that regard.
So a protocol change would not be sufficient enough to address the issue that you talked about where a physician was at home, you needed to start, say, an epidural. I'm not an anesthesiologist, so forgive me.
They cannot call in a controlled medication order set.
Okay.
And if the patient comes in the middle of the night and they haven't got on the computer, because they would only do this on somebody they've already seen in clinics. If there's what might call a walk-in, somebody from another town they've never seen, they would come in and see that patient directly. But they would have to get on a computer to do an online order for those situations. And it's not one, I give ephedrine for a labor epidural and low blood pressure. It's a blood pressure medication probably once every 20 or 30 or 40 epidurals. It's not common. And again, it gets back to the stuff, this is what I do every day, multiple times. And I'm the only one in advanced practice without prescriptive authority to any degree.
Sure. Okay, thanks.
Further questions? If not, thank you very much for your testimony. Appreciate it.
Sean.
Let's see. Opposition? Okay, if we're through with opposition or in favor?
Opposition.
Okay.
My name is Ryan DeBoof. I'm a registered lobbyist for the Missouri Association of Osteopathic Physicians and Surgeons. I certainly cannot add any more to the expertise you guys have heard tonight, but wanted to go on the record in opposition to the bill. Happy to answer any questions.
Questions? If not, thank you. Appreciate it. In support, apparently all the opposition is down. In support. How many more we got in support? Those rabbits are still going out there. All right, go ahead.
Thank you, Mr. Chairman. My name is Michael Burns. I'm here in support of House Bill 329. Just to introduce myself, I've been a CRNA in the state of Missouri for 22 years. I'm currently a professor of nurse anesthesia in St. Louis, Missouri. Prior to that, I did work in rural Missouri for 20-plus years, performing the various anesthetic tasks. I'm definitely a proud member of the nursing profession. We certainly are not anti-anesthesiologists. I respect their profession and respect all their contributions as well, and I've enjoyed working with them throughout the years. Just to explain the nurse anesthesia education, it's a 4-year undergraduate degree. It's required prior to applying to nurse anesthesia. They must have, on average, 1 to 4 years of critical care experience as well. That varies. I think they gave you the average of 4.5 years seems to be the average experience. One of the concerns that I wanted to make sure I address, that let's say this bill passes tomorrow, we can't take a lot of more applicants into the nurse anesthesia programs. And that's regulated by the Council of Accreditation of our national body up in Chicago. And so the number of CRNAs that are, of the 26,000 RNs in the state of Missouri, we're only allowed to take less than 80 CRNAs in the 4 programs in the state of Missouri. And so in order to increase that number, it would take quite the rigorous process for it to be able to increase that even just the slightest amount per program. So we do appreciate that we do have a nursing shortage, and certainly by increasing the access to health care or decreasing the supervision, this would not take from the floor nurses and so forth within the state of Missouri. As far as once they accept into the nurse anesthesia program, they have 3 years, 36 months of doctorate-prepared education. Upon completion of that, they've completed greater than 2,000 hours in the cockpit, if you will, and performing anesthesia. If you compare that to our commercial airline pilots of 1,500 hours, versus cargo of 2,000 hours. Certainly, that has some appeal. If you add our ICU experience, we're going to 8,000 or more hours total in the clinical area. And we have a recertification process and reboarding. As far as the malpractice, I think we all presented studies that one group's really good, the other group's pretty good. I think really the proof's of the pudding that the malpractice insurance rates have actually gone down. And I think both sides have alluded to anesthesia has become pretty safe as far as the medications, the monitoring devices, the advancement. So you have to have enormous studies to show a little difference, if any. But I've enjoyed, I've been in this for 22 years, but in 3 decades, the anesthesia premiums have actually gone down 36%. And if you do a cost for inflation, it's around 74% reduction. I wish all my other insurances would go down as far as my auto and my home and so forth. So I think both the anesthesiology world and the nurse anesthetist world, we've enjoyed a reduction in our malpractice premiums. We certainly have a high-risk business, but I think both professions are truly dedicated to patient safety. And that has been shown that we don't have a lot of claims, and therefore we have decreased liability insurance. So, when you look at states that are opt-out, there's certainly a few of those. They happen to surround Missouri. I think a lot of our folks are wanting to go to those particular states and practice when they graduate the nurse anesthesia programs. But nonetheless, those malpractice insurance rates aren't elevated either. And we checked with our national organization, and they do not change the premiums. The MedPro underwrites them. They also underwrite the anesthesiology malpractice insurance rates as well. And so both groups of, again, our dedication to patient safety has reigned king. We actually have decreased claims in both groups, and certainly our insurance rates are been shown to be reduced. Thank you for your time. Any questions?
Questions? Seeing none, thank you very much for your testimony. That was very helpful on the malpractice. Thank you.
All right, thank you.
Excuse me, in support.
Hi, my name is Morgan Roberts. I'm an OR nurse. I've been working as an OR nurse in Columbia for the last 5 years. So I work in a large hospital with CRNAs and anesthesiologists. So I work in the operating room every single day. And I just wanted to note, I think we've covered a lot of the same thing over and over again, so I'll try to make it short. But I just want to note that the supervision that the anesthesiologists are giving to the CRNAs is not probably what you're thinking of as supervision. The anesthesiologist typically will come in the room as the patient's going off to sleep, and then they'll leave the room, and the CRNA will stay in the room with the patient for the rest of the procedure. So no one is guiding the CRNA throughout the entire case. They're doing that. They're very, capable of making those decisions of what medications they need to give, how to adjust their anesthesia throughout the case. And then at the end of the case, anesthesiologists will come in, sign off on the chart, and that's pretty much the extent of what the supervision is on a day-to-day basis. So that being said, if I'm having surgery or if a family member is having surgery, I will specifically request a CRNA for that care, just based on what I see in my everyday practice. That's all.
Questions? Thank you very much, and thank you for sticking with us as long as you have. Further opposition? Support. I'm sorry, support. Make sure everybody fills out their sheets. Yeah, still, that, we all saw that where they all got out of the Volkswagen, they kept coming, Go ahead.
Thanks. Hi, everybody. My name is Jack Siegel. I'm the outreach manager for the Missouri Nurses Association, and I want to go on record in support of the bill on behalf of our nurse members throughout the state. I don't want to repeat much of the testimony that you've heard already. I'm sure it's been a very long hearing for everyone. What I will say is that supporting this bill would help CRNAs continue providing health care in Missouri to people who need it, especially in rural settings. It would remove restrictions and concerns over liability and put Missouri more in line with states that border it. I think all of those are good reasons, and I'm happy to try to answer any questions.
Questions? Seeing none, thank you very much.
Thank you.
Come on up. Make sure you fill out your forms, please.
I have. Mr. Chairman, I love the way that you say Missouri.
That's the correct way to
That's
say
the
it.
only way to say it. That's the only way.
And I think I may be close to the last one, so we'll get out of here before midnight. Anyways, my name is Zach Smith. I grew up in the rural town of Clever, Missouri. My dad was a lineman for Ozark Electric, and my mom taught fourth grade Missouri State history, so I kind of know what's going on here. I'm very happily married and have 3 beautiful daughters. After graduating from Mercy College in Springfield, Missouri with my nursing degree, I worked exclusively in the intensive care unit for 7 years. I've had the opportunity to serve in several of our Missouri hospitals, from level 1 trauma centers all the way down to small community hospitals. I was admitted to Missouri State University's CRNA program, where I am currently a student nurse anesthetist, and I will graduate in 2025, hopefully. As a former ICU nurse, I was trained to be extremely vigilant in the care of my patients, and this carries over to my current education. When literal seconds matter, CRNA students are being trained on what to do, when to do it, and how to keep our patients safe and alive. Upon graduation, I will have approximately 2,400 hours of training on top of my 13,000 clinical hours as an ICU nurse. After speaking with my fellow students, many of them are here today, if they would raise their hands. We're all struggling with the same dilemma. We all struggle with deciding where to work and where to raise our families after graduation. We have 43 other states to choose from that do not require burdensome supervision for the surgeon or restrictions on our future licenses. I wanted this testimony to be accurate and reflect some of the feelings of my fellow students. This was the response from a survey of CRNA students in Missouri. 81% of the students in Missouri are Missouri residents. 73% of those students from Missouri have possible intentions to leave the state after graduation. 61 intend to leave so that they can have an unrestricted license and the ability to practice at the height of their education and training. I live within easy driving distance of Arkansas, Oklahoma, and Kansas, 3 of the 43 states that have updated laws that reflect how anesthesia care is actually provided in the operating room. I do not want to serve the people of those states. I do not want to practice my skill outside of the state of Missouri. I love the idea of serving my family, friends, neighbors, and those in need of health care in rural Missouri. I have deep ties with my family and friends, and I'm actively involved in my community. I want nothing more than to work in the state of Missouri. But unless this law is changed, I have decided to move to a state that will embrace my training and expertise. Politicians always talk about wanting to make Missouri a great place to live, work, and raise your family. You now have the opportunity to do that for my family with this bill. I ask that you please support House Bill 329 so that myself and many of my fellow students that are here have the ability to stay in Missouri and serve in the communities, both big and small, that we all love. Thank you, and I'm happy to take any questions.
Questions?
Yes, sir.
Keithley.
To inquire.
Yeah.
I counted about 6 Missouris. And
I said I love the way that he said. I love the fact that that's on the record. That's fantastic.
I have no.
It's Nixie.
No
it's not Nixa. Oh my goodness.
Let's see. You started him. I've been
studying this thing for like 24 hours.
Nixon Clark.
Yes, ma'am.
It's the magic number 4. 4. To inquire, Mr. Chair.
Go ahead.
Thank you so much. So my question is, as a CRNA, what guidelines or what is set or training do they follow? Do they mimic the diagnosis or administer the medicines based off of the anesthesia pathways that have been previously set? Or how do they know how much to administer and when to administer? So do they follow that pathway is my question.
So that varies depending on the patient. You have to deal with patient age is a big factor. Patient sex is a big factor. Their comorbidities, so what I may use on patient A, I may not use on patient B.
Yeah, so I guess what my question is, previously, like if they have data that says a woman in labor gets this amount, but where is that data coming from? Is it previously been proven by anesthesiologists that this is the tone that
I
is
am
set?
not the one to ask that question.
Okay.
Student, CRNA, so.
Well, after 5.5 hours, I think I'm certified to become a CRNA now.
You can ask any question, I just may not answer it.
Okay. Yes, okay, thank you so much.
Thank you very much. Other questions? Representative Lewis.
Thank you, Mr. Chair. To inquire.
Go ahead.
Well, I just want to thank you for coming and your dedication and your education and coming here and sitting here for so many hours. I think your testimony was spot on. I think you wrapped this up really, really nicely. I guess speaking for myself, I certainly want to keep all of you all here in Missouri. You've identified the workforce crisis we've had. We've talked about the healthcare crisis. You can go to any neighboring state. So certainly we can. My goal is to get this across the finish line and keep you all here in Missouri or Missouri.
I would love to stay. I would absolutely love to stay, but they've got pretty good duck hunting in South Dakota. So,
Representative Gregg.
Well, I'm a little bit biased here, but you were very eloquent in your presentation. Again, I personally would like to keep you here where you're at. Your mama and daddy raised you well, I can tell. He is one of my constituents. So,
Shannon for votes.
Wanted to beat that 3-minute.
There we go. We sat down just the other day real quick here. Tell me real quick, and I apologize here because it's late. You gave me a rundown of how you spend time with your patients. Can you really quick give us that real quick?
In regards to as an ICU nurse or as
surgery, I think is what we were talking
surgery.
about. Yeah.
As we do pre-op, and then as soon as I walk in there and I'm like, hey, I'm Zach, I'm going to be your student nurse today. I've got 1 week of training, along those lines. I am with them until I send them off to PACU. So whether that be a 30-minute procedure, whether that be several hours, that patient's life is my sole responsibility. Once I push certain medications, I have bought that airway. I am breathing for that patient. I'm making sure that they stay alive. And I do that in a safe manner. I don't just arbitrarily look at a patient and say, I could probably give them this amount of drug. No, I'm thinking critically. Like I said, 13,000 hours where I managed drips that could potentially kill people. Your heart would explode, your heart would stop. You just never wake up. So I would like to think that, although I'm not a medical doctor, I would like to think that that measly 13,000 hours accounts for something. So,
thank you very much.
Further questions? If not, thank you, and we appreciate your time and effort and all your nursing colleagues. Is your mic on?
I'd like to thank both CRNAs and anesthesiologists for their safe, quality, patient-centered care that we provide for all constituents in the state of Missouri. I also want to thank CRNAs and anesthesiologists for their focus on research, continued education, and clinical excellence within the state of Missouri. There are a couple of points I'd like to clarify with the committee before we conclude our evening. The first is the map or the handout presented by the Missouri Society of Anesthesiologists. It's the red and green map, I believe. And they discuss that 48 of the 50 states have language regarding supervision, medical direction, or physician involvement. And I just want to clarify and assure the committee that with the legislation as it's written, that will not change with this map. This bill has provisions regarding physician involvement of the podiatrist, surgeon, or dentist. And again, we don't operate within a silo when we take care of patients. We all work together for a team to, again, provide that high-quality, patient-centered care. And with that, are there any questions?
Anybody have questions? If not, thank you very much for your testimony.
Well, thank you all for your time.
Is there anybody in opposition left? Is there anybody for information only left? Is there anybody still out there? No. Thank you very much. We appreciate your attention. Question? You bet. You can come up here. You have to fill out a form. Okay, fill out the testimony, we appreciate it. For information only. If not, the 329, the hearing on 329 is closed. Thank you very much.